gone to the endoscopy suite, and we'll be starting with the second day of the training right now with the live patients.
बहुत अच्छा आदमी है वो ना ताबेदार ये बिल्कुल सही कह रहे हैं यार वो है तो बस नीचे लग गई इसको साफ कर लूँगी नीचे लग रही है तो आपके पास सिस्टम पेंटेक्स चल रहा है पेंटेक्स का चल रहा है मैंने दोबारा अप्लाई किया हुआ है ठीक है मेरा PC1 जो है तैयार पड़ा है फेडरल से भी हमने लेना है ठीक है तो उसमें मेरा ये भी है कुछ और सिस्टम सारे कुछ रखा हुआ है ठीक है वो आजकल मैंने बना के भी रखा हुआ तो मैं चाह रहा था उसको मैं रेगुलर इनको करवाऊँ क्योंकि मेरा ट्रेनिंग बहुत है ठीक है मैंने हाईएस्ट नंबर ऑफ ट्रेनिंग जो कहीं कर लिए करते हैं वो ठीक है मैं कहना 25-26 लड़के हैं और उनको उस वाले से ही था जौहर कर रहा था जौहर का सिर्फ एक ही जो माना प्रॉब्लम है कम्युनिकेशन गैप पड़ा है स्टूडेंट के साथ मैंने कहा थोड़ा सा मैं उसको करके प्रॉपर वो मेडिसिन लगाओ माउथगार्ड वगैरह मेडिसिन कहाँ एनेस्थीसिया वाले हैं कोई देंगे आ रहे हैं अच्छा ठीक है तो मैंने पहले भी आपसे कहा था तो जस्ट चल अब मुझे बता दें आई कैन कम फॉर 2-3 डेज प्लान हो ना मुझे बता दिया करो तो उसमें फिर हम उसी में रखिए हाँ वो होता है ना वो ये मुसीबत पड़ जाती है कि मैं बहुत लिमिटेड डे डालते हो ना मुझे खुद ही शर्म आ रही होती है बंदे वो करने यहाँ बहुत लिमिटेड सा हो जाता है पकड़ा हुआ आजकल वो कभी आ जाए हाँ उन्हें फारूक ही इज अ गुड रिसोर्स हाँ तो
हेलो
अच्छा बच्चा भी है और हमने पिछले दिन किया CPT करवाई हैंड्स ऑन ठीक है
हेलो
जिन्होंने पास किया हुआ था जी ठीक है अभी करवाई थी हमने दिसंबर में 2 दिन की थी हमने 20 से 5 के 6 लोग लिए थे अच्छा और उनको करवाए थे 2 दिन में 2 केसेस करवाए और बाकी सारा कुछ था तो वो फारूक आता है लाहौर तो उसको फिर मैं कहता हूँ हाँ वो असल में उसका जो है ना वो रेगुलरली आता है तो ही डज हिज ओन वर्क एंड देन ही इट्स इजियर फॉर हिम मैं जो है ना बहुत ही लिमिटेड डेज के लिए
हेलो
घर भी सिर्फ आधे दिन के लिए जाता हूँ
हेलो
ओके वो माइक
खालिद भाई सलाम
वालेकुम सलाम
जी बिल्कुल और काफ़ी देर से हम सुन रहे हैं मैं यही कहना चाह रही थी हमें आवाज़ आ रही है आप लोगों की
और हमने बहुत शुक्रिया शुक्र है हमने कोई जो है ना गलत बातें नहीं की
सलाम काशिफ भाई
जो है ना आपने सारा कुछ रिकॉर्ड कर लिया है ना
नहीं मुझे बिल्कुल पूरी आवाज़ आ रही थी
अच्छा
Okay, this is a 32-year-old male patient who's a known case of diabetes mellitus. He presented with a complaint of pain in the epigastrium since 3 months. 2 sessions of ERCPs were done in December 2019, the second being successful, which showed findings of pancreatic divism, and CT also showed findings of chronic pancreatitis.
So did everybody get the history? Could you hear that?
जी खालिद भाई हिस्ट्री हमने सुन ली है
ओके तो आप लोगों का आप बलून लगाते हैं लीनियर के ऊपर लगाना चाहिए?
I think it makes, for me, I think it does make a little difference. I feel like I think it's a good idea to do that. Because especially in, if you are in D2 or in wherever there are a lot of air bubbles, or if there is a diverticulum in D2, so that helps you approximate. So I always check like the balloon आपका हो गया, check हो गया, बिल्कुल ठीक है, good. I think it's ready. Ready है ना? हाँ जी. हाँ जी, ये है कि सीधा चलते जाएं, excellent, बिल्कुल सीधा, यानी कि go back, नहीं अभी नहीं. It will hit, you see, it hits the back of the throat, you feel that, and that's when you flip. Big wheel towards you. Just a little bit, big wheel, little bit towards you. Okay. Nee, well, I think it's hung up. Try again. Okay. Above, yeah, you are gonna hit the back of the throat, and then you flip. I think it's flipping maybe a little bit early. That's what's happening. और आप flip करें उसको, big wheel towards you.
टांग है ना उधर पड़ी हुई है।
चल सीधे थे जिस तरीके से करते हैं आप वही उसी से कर लें। I think it's getting hung up. Not moving? Let's say getting hung up.
छोड़ दो, कुछ नहीं करना।
Hi, now it's better, okay? Good. So gentle. So you can, what I do is I do a little bit movement with this, so that what does is it's kind of helps them swallow it. Keep going down, keep going down. So, after we get to the GE junction, we'll stop there, okay? Good, excellent, keep going down. चलते जाएं, चलते जाएं. Almost right there. Okay, there you. I think you are now. So what I do is I'll keep this right here, straight there. ठीक है? जब आप G junction के ऊपर हैं, तो I'll come back a little bit. Right there is the G junction. So okay, if you look here, it's close to 40 right now. ठीक है? We're gonna go to probably 47 or so, 48, 47. And inflate it. I just want to show which way we are gonna go.
खालिद भाई,
जी,
ये जो आप बता रहे हैं ना मैनूवर्स, ये प्लीज़ ज़रा थोड़ा सा लाउड एंड क्लियर ताकि हम लोग भी सुन लें यहाँ पे कि किस स्टेशन पे आप क्या करवा रहे हैं.
so can you hear me better now?
जी जी, थैंक यू.
Good. So what I was telling is like when we get to the GE junction, just stop for a second, take a pause there, and then what you need to do is this is a nice neutral position of the scope. So I'm looking here at the incisors. I see that the mark is at 40. So what I was saying is usually it's 7 to 10 centimeter you go into the stomach towards the opposite wall of the stomach. So we're going to try to go right there. Okay. Chalte jaye. Big, gentle. Okay. And then stop there and a little bit this way. Okay. Right there. Now it's close to 45. So 5 centimeter in him. And suction. Big wheel towards you. Okay. Can we switch karna zara? So when you do that maneuver, you see you are right onto the liver. But this is the distal part of the liver. So what we need to do is, right now if you imagine, like majority of the liver is on the right side of the screen when you are looking at the screen. So what we need to do is, still keep it here, pull the scope back, and liver, big wheel towards you a little bit, just a little bit, okay? And when a liver is now mostly moving to the left of the screen, when 2/3 of the liver is on the left of the screen and 1/3 on the right, that's where right now we are at 180 degrees, the scope position. We're just going to rotate the scope and bring it to 90. So when you, This needs to move. It should move. Or you have to move back and keep going, and pull the scope back a little. That's good. That's good. Keep going. 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 Right there. So your wheel is way too up. You see that the aorta was trying to go that way. It should be landing. Okay. So you need to go to the right. Go to the right. Or no, other right. Keep going. Keep going. Keep going. Keep going. And you can step. ट्रांसड्यूसर की मूवमेंट वो नहीं हो रही है जो होनी चाहिए विद ट्रांसमिट नहीं हो रही सो दैट्स व्हाई आई रियली स्टेप बैक लाइक स्टेप स्कोप स्ट्रेट ठीक है राइट देयर इज द एओर्टा दिस वन ठीक है ये जो ऊपर है हां जी तो नहीं 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 नो नो जस्ट कीप इट स्ट्रेट राइट देयर रिलीज द व्हील अ लिटिल बिट No, रोटेट नहीं करना है इसको सिर्फ रिलीज करना है ठीक है नहीं लेकिन आपकी स्कोप भी रोटेट हो रही है ना दैट्स व्हाई यू आर लूजिंग इट राइट देयर ठीक है तो आप जेंटली गो इन व्हाइल कीपिंग दैट इन जेंटली गो इन व्हाइल कीपिंग दैट इन व्यू ठीक है रिलीज कर दें वो थोड़ा सा ताकि व्हील को तो सो यू डोंट हैव अ ट्रबल गेटिंग इनटू द स्टमक रोटेट अ लिटिल बिट sometimes right or left right there okay so keep going down okay ab jo hai na you are already close to the pancreas I see the pancreas on there but there's so much air bubbles okay now it's better now you see the celiac right there celiac right there ठीक है इसको आप जरा और इसको क्लियर करना है तो बिग जेंटली एडवांस तो नहीं उसी जगह पे ना आपकी स्कोप you stabilize the scope okay good big wheel a little bit towards you lot of air bubbles in that's better now okay now air bubbles are gone good so just keep that in view aorta gently advance the scope okay thoda sa rotate right little bit more right there you see the aorta celiac coming up okay now forget about the aorta okay now we're going to just follow the celiac and make any movement right or left to keep that in the view okay abhi tak view mein hai okay and gently advance gently humne follow karna hai main trunk ko follow karna hai ठीक है right there right here okay we're going to stop right there so you see there is a one left gastric coming off going that way there is a splenic going that way common hepatic going down towards the liver so when you get to these three branches usually either it's a trifurcation it's not complete trifurcation left gastric is coming up a little bit early and then it divides into common hepatic and then divides into splenic so from here the splenic is going down or going up right so our goal is to bring the splenic to the right side of the screen so what we need to do is keep that in view okay और no नहीं रोटेट नहीं करना आपको ठीक है नहीं and just gently advance and release the wheel just very little you see that how it's moving to that side now big wheel a little bit towards you you're rotating the wrong way that's what's happening okay this ठीक है so right there that's all pancreas in here okay? This is all pancreas so let's bring that back good excellent ठीक है so this is pancreas. I think there's a flood. Yeah, we need to need a little better view of that. I think it's like it. Okay. Right there. This is all pancreas. You see that there is there could be a small stone there in the pancreas. Yeah, this is giving us some shadowing there. ठीक है. तो इसको आपने maintain रखना है right in the center. Okay. Well, no, center. The pancreas should stay right underneath the transducer between 4 and 7 o'clock position, ठीक है? Or between 5 and 7 o'clock position. And gentle, go to the right a little bit, ठीक है? Good. वो देखें ना आपको पता लग रहा है कि कौन सी movement करनी है for it to bring it down. So if we push it gently, it will come underneath the transducer. Okay? If it's moving away from you to the left, then you gotta push the scope in. If it's moving towards the right, you gotta pull the scope back a little bit. So it's a very gentle movement. Okay? Here, now you clearly see that there is a splenic artery right here, and splenic vein is right underneath right here. So दोनों का जो है ना आपका yeah. So it's a pancreas. It's not a healthy looking pancreas. You see was a small stone in there. There are foci strands, and the boundary is not very clear. So it looks like it's like beaten up pancreas really. ठीक है? So it's got features of chronic pancreatitis. To some extent, it's atrophic too. And I don't know if this is really a duct itself completely, or there is any fluid collection. We need to study at that a little bit more. ठीक है? Yeah. Keep going. Okay. So this is नहीं अभी push नहीं करना. Yeah, this is the duct right there. ठीक है? हमने अब pancreas को ले आए. We brought that right in the underneath the transducer. Now what we need
खालिद
to do
भाई ये
is
duct नहीं है dilated सी
I'm coming. Let me just explain it. So एक मिनट मैं अब सारा कुछ करता हूँ. ठीक है? So you see that like the main goal is right now, after looking at the duct, keep that right in the center of the transducer. ठीक है ना? Transducer ये है ना, तो इसका try to keep that right in the center. ठीक है? अब ये you see that stone in there, you see the splenic artery, you see the splenic vein. What I'm going to do is I'm going to put a Doppler on that. ठीक है? Now this is the area which looks like more fluid in that, and we do see a stone in that area as well. ठीक है? Let's try to go a little bit to the right from there. ठीक है? Rotate to the right, rotate to the right. Okay, now we're going to stop there. ठीक है? So this is the main duct right here. If you look at the size of that, probably is 3 millimeter. ठीक है? But when you follow that towards the neck, it kind of blows up, and there's a lot of junk and fluid in that. So here, right there, that duct right there. So always, whenever you do the measurements is like a perpendicular to the long axis of that. ठीक है? अब यहाँ से आप यहाँ से लेकर यहाँ तक measurement नहीं कर सकते. You always have go to 90 angle from here set there, and then 90 angle to the long axis of that. ठीक है? So it's where is the measurement? उस पे आ रही है? No, where is it on the screen? I think it's behind that. Anyway.
2.2 millimeter ये ऊपर आ रही है.
किधर आ रहा है?
Yeah.
It's right. Yeah, उस स्क्रीन पे नहीं आ रही. ठीक है. ठीक है, इस स्क्रीन पे आ रही. उस पे बंद किया?
नहीं वो बड़ा हो गया.
बड़ा हो गया ना इसलिए. ठीक है. सही है. Okay. So it's 2.2. So that's which I said between 2 and 3. So if you follow that right here, go a little bit to the right. Keep going. Keep that underneath the transducer. You see that's the duct, and it gets dilated here and there. It's a very tortuous. This is the duct right there. ठीक है? Or if we pull it back a little bit, so that brings that right underneath. So when it's going to the right, you pull the scope back. When it's running away to the left, you push the scope in. ठीक है? Good. You lost it. That's okay. Go. So when you lose it, you do the opposite of what you did. Okay. So here now, there's a lot of junk in the duct. There's the stone here, and if you go a little bit to the left, you see the duct looks much bigger now, right here. So it's a dilated duct. Okay. और नीचे वाला जो है, is it just that's the duct right there, looks like, and it looks very big here. Either it's a duct or a fluid collection or a cyst there, and the duct may be passing behind it. I don't know, but looks like it's probably is a very dilated duct right here. ठीक है? Or it's going downwards as well. And there's a stone in there. I'm going to take the Doppler off. Yeah, that's a duct. Looks like a very dilated duct.
Which part is this? This the body?
This is the neck area, almost a proximal body and neck. Okay? Right there is a very dilated duct actually. Okay? That's what it looks like at least. And there are stones in there. Yes, sorry, duct. यहाँ पे, this is looks like this is all duct right there. So he has a definite features of high probability chronic pancreatitis or good features of chronic pancreatitis. So the duct is almost 10 and a half. Okay. Right. And this is also a portion of the duct looks like, but there is a lot of debris, stone debris in that probably. And there are stones everywhere. It is, and if you go to the left towards the neck, what you need to do, you need to just rotate perfect. And you see a lot of dilation, a lot of junk. And here you can see it's going around the portal vein and portal confluence and going downwards towards the head. Okay? Let's go to the stomach now, to the duodenum, D1. G, okay? So always try to do that endoscopically, okay? And go to a neutral position. That's going to just tell you where the lumen is. And नहीं बिल्कुल सेंटर में जाए. यार पिक्चर वो कैमरा की बड़ी करना जरा एक मिनट. Okay, so you see that just goal is to follow those. थोड़ा इसके ऊपर lubricant gel लगा दो. Okay, good. So you will follow those folds. Big wheel towards you because your transducer is hung up on there. ठीक है. वो होता है कि transducer is away from the camera, so it can get hung up there. ठीक है. So it's just like a ERCP scope. You have to be, it's upwards, right? Good. Good. Keep going. So every time what I usually say is like if you don't see it, stop. Just suction whatever you need to do. And because it's very important for you to see it कि आप किधर जा रहे हैं. You're in the right place. There are a lot of bubbles. As soon as you get into the duodenal bulb, just stop there. ठीक है? अभी नहीं. Go into the duodenal bulb right there. Okay. So just suction all those bubbles. Suction, and now inflate, inflate, inflate. Inflate करें इसको. Inflate, 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 inflate. ठीक है? Inflate. और show me the duodenal apex. ठीक है? Right there. ठीक है? I'll pull it back a little bit. ठीक है? यहाँ पे. ठीक है? What right now, if you look here, ठीक है? ये वाला है duodenal apex. यहाँ से this is all duodenal part of that. Duodenal apex is there. Our goal is to take the transducer right there. Okay, perfect. Big wheel towards you and put it on the left corner. ठीक है? Right there. Okay, we're gonna stop right there. ठीक है? वो ज़रा पिक्चर बड़ी कर देना. किधर है वो? मुझे बता दो, मैं खुद ही कर लूँगा. Well, good, right. नहीं, ultrasound. See. So here, we just put the transducer right in there. ठीक है? Big wheel towards you a little bit towards you, a little bit. Okay, and rotate a little bit to the right. Perfect, right there. You see that's a portal vein right here, portal confluence. ठीक है? और यहाँ पे this is a superior mesenteric vein and this is a splenic vein. You see the duct? This is one of the ducts, right? You see a stone in there. It's all an anechoic area with a stone right in there. So we know that it's one of the ducts. So either it is a bile duct or a pancreatic duct. But so far what we have seen is, we saw that like a pancreatic duct getting dilated when we were moving towards the neck. ठीक है? Pancreatic atrophy, all the features of chronic pancreatitis, pancreatic duct stone. So I'm thinking likely it's a pancreatic duct. ठीक है? Right now that's what I'm thinking, okay? And that's why you see that how dilated that is. So right now what I'm thinking is, yes, stones, features of chronic pancreatitis. It doesn't look like a main duct IPMN to me because he has all the other features of chronic pancreatitis. So likely this is related to a stone obstruction of the main pancreatic duct. And that was the reason, because it's impacted, that was the reason they had a hard time getting into the duct itself. It's probably is impacted right in the proximal portion. Okay? You see a stone right in here. The duct is quite dilated. It's going to rotate it to the right side. Keep big wheel towards you a little bit. You see that? How impacted those are? So there are multiple stones. So, and this whole area, which is the head of the pancreas, is completely blocked by those stones. There's no way to get into the main pancreatic duct from here. So it is possible that there is a secondary a pancreas divisum. What that really means is main ventral duct is obstructed by the stones and the dorsal duct has to open up to some extent. So which I haven't seen evidence yet, but whatever they were telling possible pancreas divisum, I think that's the etiology and that's what happened. So here you see the main pancreatic duct is completely blocked by this large stone, which is very calcific stones. And these pancreatic duct stones, they are not the nice stones. What I call them is like they are as hard as diamonds, but the worthless diamonds. Yes. Okay. And so here we don't see anything beside the stones. I do see a parenchyma right here. Right. We'll rotate a little bit to the right, a little bit to the right, a little bit to the right, all the way to the wall. You just see full of stones. Even we are still seeing that. Okay? Let's follow that towards the distal pancreas. Okay? Good. Okay. अब यहाँ पे रुक जाएं एक मिनट के लिए.
खालिद भाई,
You see that that it's blocking that area. ठीक है?
एक और duct.
Okay. And it was moving downwards, right? So what do you do is like to bring it up right into your view. You put a big wheel towards you a little bit towards you, little bit towards you, little bit towards. Okay. So what you need to do is maybe need to pull the scope back then. Okay. And to keep it just right there. Actually, you need it to go in a little bit to get that back into the view. Okay. आपकी duct आ गई यहाँ पे आप. Let's follow that towards the neck. Okay. Okay. दूसरे हाथ से hold करना. And when it's moving away from you, that way you need to release the wheel to get that. Okay, so just to have a control of that, but it didn't come. Just a little bit release. And there was a question.
खालिद भाई, आपको नजर आया पेनक्रेटिक डिवीजन? मैंने पूछा था, उन्होंने सस्पेशन दी
No,
थी.
I did not see. So I don't know if you heard me or not. Can you hear me?
जी,
Right? Okay.
जी.
So what I was saying is I haven't seen that evidence of that yet, but I think it's a secondary divisum, pancreas
Okay.
divisum, because the main pancreatic duct is blocked by the stones completely.
ठीक है.
So the dorsal duct has to open up to some extent. So I
ठीक.
think it's a secondary divisum possible, but I have not seen that yet. I haven't seen the dorsal duct. And I suspect I may not be seeing, it's going to be quite small, because I can follow the main duct all the way to the ventral pancreas, even though it is blocked, but I can follow that. So I'll take a look in a minute, but I have not clearly seen that yet.
ठीक.
Okay? So do I need to speak up?
जी प्लीज खालिद
Okay.
भाई, थोड़ा सा, ताकि हम लोग यहाँ पे सुन. ये एक और ऊपर से डक्ट आ रही है खालिद भाई, ये मैं ऊपर ना, आप अभी करते हैं तो आप देखिएगा.
ठीक है. So let's go to the D2 right now. हाँ जी, endoscopic view. Always do that. Always when you move the scope from one station to the next station, please make a habit to do it under endoscopic view. Don't try to push through and when you don't see it. Okay. Sometimes we have to do different things, but whenever you're doing something new, and especially with every scope, try to make a habit when you move from one station to the next station or one area to the next area, do it under endoscopic view. So we did that. Okay? It's okay. If you don't see the ampulla, that's fine. No problem. You are in the D2. Let's reduce the scope. Okay? Let's reduce. हाँ, जैसे वो ERCP में. ठीक है? Okay? हाँ जी. No, I think, yeah, that's fine. Yeah, let's reduce it. Okay, good. Reduce. Now it's reduced. Okay? And so now what we're going to do is, what I do is sometimes I rotate myself. If I need too much rotation, then I just rotate my body, because instead you don't want to put too much burden on your shoulders and joints, and because this is what we do every day. And so you want to get take care of yourself too. So right now, there's a lot of air in the duodenum.
Yeah.
That's why you don't see anything. And other thing is, if you can put a little bit water in the balloon, because we have the balloon, so let's take advantage of that. That's good. Just a very little. Suction all that, and then just keep a little bit water in there. That's good enough, okay? So right now, stabilize your scope. Looks like it's stable, okay? And stable and थोड़ा सा step back a little bit, okay? And now rotate the scope right and left, okay? So what do you see there? By just looking at it, do you think it's a aorta or it's a IVC?
It seems to be IVC.
Okay, let's rotate from there to get to the aorta. What do you need to do?
No, this right and left.
Right.
Right.
Yeah, I know you're doing the right thing. Yeah. Okay. We did not see that, right?
Maybe that is aorta.
And where is the IVC then?
IVC थोड़ा सा इस तरफ और
Okay.
पहले IVC है then aorta.
Yeah. So aorta is in the center. Okay. IVC is to the left of that, and then the right kidney. And from the right side of the aorta is the pancreatic bile duct, and then the pancreatic duct. Okay. Go a little bit to the right.
Right.
Okay. The aorta's position is not doesn't look right, right? It's coming like this. It should be coming like this.
yeah.
Okay. So there is something with the wrong with the scope position itself. Okay.
Meaning अंदर position जो हमारी
Yeah, I think it is an scope transducer is not in the right direction. Okay. Okay. Okay, good. Pull it back a little bit, scope. Pull it back a little bit. Okay. I still do, I do see a lot of artifact there. But okay, right there. Okay. Yeah, yeah. So there is something right here, right? One of the vessels. Now we are getting into a better look position, at least. Okay. So you are easily compressing that, right? And also you see a blood flowing back and forth in that structure. So it's likely it's a IVC. Aorta won't be compressed that easily. Right there. That was the aorta. Okay. Go back a little bit. Go back a little bit, So you're doing the movement here, but it's not getting transmitted properly. Okay, so yeah, now go a little bit to the left, right kidney, okay? Go to the left, right, keep going, 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 further, a little bit, one more. Sometimes the aorta is a little bit down, it happens, like you see the IVC, and then you see the aorta is in a different plane a little bit. We lost the plane. We did not get to that. Okay. Go back. Yeah, just go back a little bit. Go back means rotate to the left. Okay, right there. And right kidney. Good. So you're seeing the right kidney so clearly. So there's something wrong with the plane. Usually the right kidney wouldn't be that close to the transducer, okay? So here we do see the IVC, but we haven't seen that. There it comes, okay? There it comes, good. So when you are in that place, go back. It's hard sometimes, it's slipping, it's just...
balloon जो है ना मैंने suction की और deflate हुआ हुआ है.
Okay, so come back a little bit with, okay, release the wheel a little bit, release it, okay? Okay, we're gonna pull the screw back gently. We're gonna rotate right or left, it's okay. Sometimes you overcorrect yourself, so you need to uncorrect yourself a little bit. Okay, you see that? You overcorrected yourself because you are too to the right. Okay, don't let the wheel go. You don't move too much with the wheel. You are doing this and this with the wheel, so that's what the problem is. Okay, so the wheel need to stay in one position, and.
Reduce this artifact by letting the
Yeah, so there are a lot of air bubble. You need to suction those. Okay, that one. Put a little bit water in the balloon. No air anymore. Okay. So right there, it's getting better. Okay, I'll stop there. Don't do anything. Pull the scope back a little bit. Okay, right there. Okay, now stay there. There is something coming up here. You see those stones coming up? So that's the pancreas area. Now we just got to adjust our scope so that we can bring that in a proper position right here. Okay, so no, you can overcorrect it. Go back, right there. You see that? No, एक मिनट. इसी जगह जब पहुंच जाते हैं तो रुक जाएंगे यहाँ पे. ठीक है. Right there. Okay. Now the only thing you need to do is pull the scope back gently, gently, gently. नहीं रोटेट नहीं करना है इसको ना
मैं नहीं
scope.
कर रहा, कुछ भी नहीं कर रहा.
खालिद भाई ये मैनूवर आप हमें साथ
Right
साथ
there.
प्लीज बता
ठीक है.
दें.
Right there. See, ठीक है. So you see that now everything is like big wheel towards you a little bit, big wheel towards you a little bit. Right there. This is all that pancreatic head, and you see all the stones at the bottom, right? Okay. Right
Yeah,
there. They all are filling it up. It's good. Everything is filling up that stair, and you see the duct, the stone, big stone with the distal dilation of the duct. Okay. Keep pulling. Yeah, that's a big stone. Pull big wheel towards you a little bit. Keep pulling the scope back. Keep pulling the scope back. Right there. Okay. So now, just it moved a little bit to the left side. Okay. So this is all the artifact from the air in the intestinal
नीचे
lumen.
क्या है ये जो? Is it gallbladder?
Likely it is, but let's not pay attention to that yet. Okay. Good. So let's bring that back. There. Good. एक मिनट ज़रा तक. Good. So एक elevator भी आपका जो on था. हाँ, it shouldn't be because it's not a big problem, but sometimes it can get hung up onto the intestinal mucosa. So we're back into the stomach.
खालिद भाई ये यहाँ पे सारे डिमांड कर रहे हैं कि आप D2 पे जो मूवमेंट्स कर रहे हैं ना वो प्लीज साथ साथ बताते जाएं.
जी ठीक है मैं बता.
थैंक यू.
Okay. So what I'm going to do is I'll just go to the D2 and D1 I think explained a little bit. So I'm just going to go to D2. There's a lot of air bubbles. I'll reduce the scope. Once I get into a position, so I'm moving back. If you look at the scope is really straight, okay? I don't see the papilla there. I'm not worried about seeing the papilla. My whole goal is to get the better view with the EUS scope. And once I'm completely reduced, what I'm going to do is maybe put a little bit water in the balloon a couple of times to get rid of that air, a lot of air there, artifact there. So let's see if we can get rid of that. So okay, so once I'm reduced, what I'm doing is, this is the area when the scope is in, those who do the ERCP, when the scope is really in a short position, your scope becomes quite stable. It's like it gets hung up on, it kind of hugs around the duodenal apex and becomes stable in that position. When the scope becomes stable in that position, what I do is right and left movements, right and left movements. So here, if you look at there, when I'm doing the left movement, you see the right kidney right there, right? Everybody sees that?
Yes.
From there, look at my scope position. Right now, from there, I'm rotating the scope clockwise, and you see that IVC comes right there. It is easily compressible right there. That's the IVC. From there, I go further to the right, and the aorta comes. You see that aorta?
जी.
It's in the right position where it should be. It should be coming from here and going downwards in that. This is completely opposite of what you see at the GE junction. So when I see the aorta in this position, now I pay attention to this right upper corner. From aorta, what I'm going to do is I'm going to rotate the scope a little bit to the right to see if I see any pancreas there. I'm not really seeing any pancreas right there right now. So what it means is I'm just seeing the retroperitoneal fat here, but I have a little bit hint something is right in that upper corner, which possibly is pancreas. So to bring that down under the transducer, I need to pull the scope back, because if I push the scope in, it's going to go further up and disappear in this area. So instead of doing that, what I'll do is I'll pull the scope back a little bit. Now I'm going to forget about aorta, okay? I'm just going to pay attention to this right upper corner. Now it's becoming a little bit more apparent because I see those stones right there. My goal is to bring that area right underneath the transducer. I'll gently pull the scope back, gently pull the scope back. While I'm doing that, I'm making a right and left movement a little bit so that I know if I slip off the area, so I know which way to go back. So now a lot of pancreatic stones, I see that. And now I know I'm on the pancreas. This is all the pancreas. From here, I'm going to do one thing just to show you. If I go to the left towards the aorta, you see where the aorta is right now? It's underneath. It's not in that position where we started because I had to let it go to really get to the pancreas. Not going to happen always. Majority of the time, there's not too much pathology. Aorta still will stay in the position. You rotate to the right, and then you can see the pancreas. But here, in that position, I could only barely see a small portion of the pancreas. So to bring that down, I have to let aorta go into a different position, which is fine. I'm not interested in aorta to take a look at that. My goal is to take a look at the pancreas. So when I let that go, it moved down, which is fine. I still need to let it go a little bit further to really bring the pancreas underneath the transducer. So now look at that. This is all pancreas full of stones. There is no duct there. I don't even see the duct. And I will be surprised if I can even see a pancreas divisum, because that duct should be somewhere here in this area. Bile duct is completely compressed as well. I don't see that as well. This is the uncinate process right here, but I'm going to try to see if I can find the bile duct. Okay, right there, coming back. Okay, there you go. Right here, one of the ducts right there. I just need to figure out which one is it. I think it's the pancreatic duct right there. It's a very, very proximal pancreatic duct, I should say. There is a stone right there. You see the duct right here. Let's look for bile duct, which I don't see yet. I don't see it yet. I haven't tried that from the duodenal bulb. I can do that in a little bit. But here, actually, if I take a look at that, that was a duct right there. I need to pull back a little bit more. I'm doing, if you look, I don't know if you can imagine the subtle movements I'm doing with that. I found the bile duct. I'll show you in just a second. I'm doing a very, very subtle movements with my scope. I don't know if you can see that, appreciate that or not. So bile duct is right here. You see that? It's completely clean, nothing in the bile duct, right there. It's a small bile duct. You see that? Everybody sees that?
Gigi.
Okay. And the pancreatic duct is right here. You see that? And fully blocked by the stones. There was another duct which we saw earlier. That's actually now, I'm thinking that is the uncinate branch of the main pancreatic duct. That's what we were looking at. But the main pancreatic duct is right here now. So if I lose it, what I do is I'm going to just gently advance the scope. Not too much, just a little bit to bring it back. You see that? How it moved up to the right corner to become a little bit more stable. I overcorrected myself. What I mean by overcorrection is we're doing a little bit too much to the right, trying to find the pancreas. And that happens all the times with my fellows too. And I have to tell them, you're overcorrecting. You have to go back really to take a look at, to get back to your pancreas. So during that overcorrection, I fell back into the stomach. So that's what happens. Now sometimes you can read this as a pancreas, but this is a retroperitoneal fat. I don't see any structures. This doesn't look like a pancreas. And look there, I'm back into the stomach because of my overcorrection. See? Okay. So I'll go back in there. So we saw the bile duct. Bile duct looks completely clean, no problem with that. And here, if I look at the bile duct from here, I think right there, no problem with that. You see a big, huge stone right there. I don't see a dorsal pancreatic duct here at all. Maybe right there. Hold on. No, that's a vessel. I don't see dorsal pancreatic duct, to be honest with you. So I don't know if, even if there is a divisum, the dorsal duct is really small. One more time, I'm going to look for that from the D2. A lot of air bubbles, so that's one of the main reasons. So you can put some water in there too if you have to. Okay, so once I'm in a good position in D2, I really just try to go straight to the pancreas, but I'm telling the steps, the way it should be done. Try to find the aorta, bring the aorta in this position where it is. The aorta is the center of 5 structures. To the left of that, left of the screen, first thing is going to be IVC, and then is the right kidney. Right kidney, IVC, which was compressed right there. It's compressed right there. That's IVC. But this is the aorta. When I find the aorta, I pull the scope back a little bit and rotate right and left a little bit. Right and left. Very, very subtle movement. I'm just moving my body just to show you that how much movement I'm making. And but usually I just do with my wrist. It's a very subtle, literally very subtle movement. You may not even be able to appreciate that at times. And I'm just pulling the scope back and holding on to my big wheel, not too tight, because if I hold it too tight, I'm not going to be able to pull the scope back. So I'm just, if it wants to get released, I let it go a little bit so I don't get hung up on the duodenal sweep. So here I see a lot of stones. Now I know I'm right in the right place. There is a pancreatic duct right where that arrow is, and that's blocked by the stone right here. Okay, above that was the bile duct. What I'm gonna do is I'm gonna pay more attention to this area to see if I can find the pancreas divisum. And obviously this is not a true divisum because there are so many stones in there, so it's gonna be likely a secondary divisum. Not really a clear cut. To me it looks like there are stones everywhere. There may be one small here. This is going up. I don't, maybe there. Even if it is, I don't think it's gonna be, it's gonna be really, really difficult to open it up and won't be able to open it up. From there, now I'm gently moving the scope back while keeping that duct right underneath the transducer. I'm gonna fall back into the stomach, and I have to let go one of the portion of the wheel to get it straightened because it wants to straighten so it can come around the duodenal sweep. So I let it go, keeping in my mind that I didn't let that duct go. So we are back in there into the stomach, and I think this pancreas, not a clear-cut evidence of a pancreas divisum. If it is, it's a secondary and the duct is really small. Chronic calcific pancreatitis, dilated duct secondary to that. And these are the patients really hard to manage. For a pain, you can do a celiac block. For pancreatic insufficiency, pancreatic enzymes. Even his duct is quite dilated distally, but there's not much parenchyma left. You can ask the surgeon if they can do a Pusto procedure, maybe let it drain from the dorsal, from the distal part. So different options available, but unfortunately, it's a really, really bad chronic pancreatitis. And I think, I don't know, you guys, I have seen a lot of people with young people here with the chronic pancreatitis, and obviously alcohol is not the cause. Is a tropical or?
We are basically investigating it now.
Genetic pancreatitis.
Genetic, and in India they find a lot of that too, and so genetic is.
We are doing the genetic testing here. And
Okay. Yeah, this is this is a young guy. How old is he?
He's just
Yeah, so it has to be a genetic component to that. So here, if you look there, there's really not much pancreas left. You see a splenic artery there, splenic vein, but the pancreatic parenchyma is pretty much gone really, not much left, and there may be some parenchyma here, and if you look at it, it's all burnt out, and that's, I think it is, that's it. Any question about that before I move to mediastinum?
Dr. Khalid, can you hear me?
GG.
When you see the aorta in takeoff position, you just withdraw the scope and find the pancreas. That part of pancreas, the unseen head. What maneuver you do to find the head of the pancreas?
So uncinate, you just have to see that it's just like a downward pouching of the head, really. That's what it is, okay? So first you see the uncinate process. From there, you pull the scope back a little bit. Before you pull the scope back, you rotate to the right. You are looking for the ducts, okay? When you find the ducts, that's the head of the pancreas. And bile duct and the pancreatic duct, they open into the ventral part of the head of the pancreas. And the ventral part sometimes is hypoechogenic, okay? So once you find the duct, you found the head of the pancreas, okay? That was the question, right?
Ji, thank you.
Okay. So we'll move on to mediastinum. So the way we would do is we're gonna, yeah, that was perfect. Make sure all your the views are in neutral position, which Kashubai did that. And we're gonna just move the scope back into that. And I will do so you can pitch, just step back. Yeah, just a good control there. Excellent.
ये प्रॉब्लम आ रही है ना, जब मैं ये करता हूँ तो यहाँ से पकड़ने के लिए मुझे झुकना पड़ता है ना, उसका क्या, क्योंकि यहाँ से मुझे लगता है जैसे कंट्रोल।
मेरे ख्याल हम दोनों की एक ही हाइट है, पता नहीं मैं क्या कर रहा हूँ फिर।
यही तो मैं देखना चाह रहा हूँ इतनी देर से, मैं यही तो देख रहा हूँ कि मैं जब उसको यहाँ से पकड़ूँ
So
तो
what
क्या-
I think,
या-
yeah.
मैं समझ गया, तो इसको यूँ रखो।
हाँ, एग्जैक्टली, इसको दूर रखें, बिल्कुल आपको तो ओके। तो so you are getting closer. I saw the left atrium there.
left
Okay.
atrium is there.
Okay, right there. Okay. So big wheel towards you a little bit. Okay. Rotate a scope. That's a left ventricle actually. You see that?
Yeah.
Left ventricle. Where the arrow is, that's the left atrium. Okay. To pull it back a little bit, our goal is to bring the left atrium to the left side. Okay. Right there. Okay. Right, and now you see the left atrium there, and pulmonary artery is right here. That's the area of the subcarina. You see the left ventricle there, and if you go up further to the right, nothing there. That's an aorta. Okay. And left atrium, left ventricle, okay, and the pulmonary artery right there. Pulmonary artery, left atrium, subcarina. ठीक है, अब जब आपको सबक्राइना नज़र आ गया तो just from here just rotate the scope downwards, wheels facing downwards to the floor. Just rotate, keep rotating, keep rotating, keep rotating, keep rotating, keep rotating. Aorta right there. ठीक है, when you get to the aorta, pull the scope back because we need to get to the aortic arch. ठीक है, big wheel a little bit towards you, just a little bit. That's it. Okay, and we're going to come back a little bit. Now aortic arch is right underneath the transducer. ठीक है. From here, what we're going to do is we're going to just rotate the scope in a way, halfway that the views are facing the patient while keeping the scope straight. Just push maybe a 1 centimeter in, and now, hold on, stop there, perfect. So you see that pulmonary artery, you're pulling it up from the bottom, okay? Aorta, pulmonary artery, big wheel towards you a little bit, no, towards you, big wheel. Pull it up for a little bit more, okay. And rotate to the right. Rotate to the right, right there. Okay? So when it was moving away, you are rotating it to the left. So you needed to rotate it to the right to pull it up. So this is the AP window right there. Pulmonary artery, aorta, and the AP window. And if you pull it back further, that's a left carotid coming off there. Okay? Right there. And you can move, that's a left carotid there, subclavian underneath. And if we keep coming back, a little bit more. Okay. I think this is a thyroid right here, right there. This is a thyroid gland. Okay, go pull cut out. Good. Any questions?
ठीक है आपका, बिल्कुल।
Thank you for your patience.
इसकी रिपोर्ट क्या कर रहे हैं?
Harit, no question.
Oh.
Excellent demonstration. Wonderful.
Thank you.
रिपोर्टिंग में क्या कर रहे हैं?
So reporting में इसका ये है कि chronic pancreatitis, तो आपने tropical कहना है या genetics.
Tropic body of the pancreas with the
So all the features pretty much like it's a
major template से
हाँ जी कर देते हैं ठीक है ये बेटा ये आपके ग्लव्स साफ है? ओके, ठीक है, गुड.
Khalid, there's a Khalid. Can you hear me? Khalid.
I'm coming over there.
Okay. Saad, are you there? Saad? हाँ ये biopsy कर रहे हैं। ये most probably क्योंकि ऊपर है ना ये head of the pancreas बनना चाहिए।
Head of the pancreas, so
Yeah,
there
head of
must
the
be the
pancreas.
D1.
Yeah, ये D1 है।
कैसे वो क्या था
वो इस तरह के अगर तो
फीचर कोई इसमें और कोई चीज नजर आ रही है सवाल इसके ये
न जब हिलते हैं तो उस वक्त वो ऊपर से ना मुझे वो नजर आती है उसमें पोर्टल वेन और ये डक्ट नजर आती है। और दूसरा है कि ये जो है जो मेडियास्टिनल वेसल वो इस साइड पे जा रही है, ये एओर्टा है फासले पे, तो उसमें कि बिल्कुल जंक्शन पे ये एओर्टा है। हाँ ये बिल्कुल जंक्शन से कर। और दूसरा है कि जो आपकी जो फॉल है अगर ना आपका डिसेंडिंग तो इस तरह फॉल बनी नजर आती है ये ऐसे
फॉल क्या मतलब है
ड्यूटल फॉल नहीं फॉल यानी जो मिकोजा की जो लाइन है वो नजर आ रही है। ये क्या इंडिकेट करती है फॉल यूएस के मिकोजा
Done.
जी साद we can hear you now.
Okay, so this is a lady with obstructive jaundice, stent in C2 as you can see. With the, as we come here at the distal end of the CBD, you can see, I don't know if you can appreciate there.
Yes, we can see that.
See, okay, so we've got a mass here which is not very well circumscribed but hypoechoic, fairly diffuse, just at the distal end of the CBD. The pancreas is actually literally not there. The whole body and thing, but in the head here, the pancreatic duct seems to be a little visible. Doppler देना. एक मिनट ठहरो. Let's see a bit of it. So we actually went and did an FNA of this, and we've got cells on that, and we're just reviewing that. There are multiple lymph nodes, but they're not.
Saad, in this mass, how do you differentiate between the head of the pancreas mass versus low CVD mass,
Yeah, you
periampullary mass?
you really can't. Sorry, inflammatory mass.
No, periampullary mass.
Periampullary mass. I mean, you know, whether it's pancreatic or whether it's distal biliary, it will all look the same.
Yeah, I agree.
So you really can't differentiate. But in this case, she looks like a otherwise very fit lady. But that's the only abnormality we have found and there's hardly any body or tail of pancreas. That's something that we saw.
How about the blood vessels? Can you show the blood vessels around the mass? Are they standing clear?
Yeah, blood vessels are, that's the portal vein there. Hatana Doppler there. and you can see that it's going all the way. That's the superior mesenteric vein. You can see that going through it. The distal end of the CBD, if you look at there, if I follow it, it literally ends into this area. And then there is, it just comes here. If you come follow it here, this is where this is what we saw. Okay, so this is all we saw, but there is no vascular involvement. Acha, the other thing is we can't go deep into D2. There is a stricturing there, so it's not very narrow, but it doesn't allow our scope to go. Okay.
Okay.
Mediastinal. So what we focused on was not so much with Kamran. What we were working on was how do you bring something that's on the left side of your screen up down below, so that if you want to do an FNA of a lesion, how do you bring it to an area where we can insert the needle, or when do you advance the scope? What happens when you advance the scope? What happens when you pull the scope back? He did the gastric station well, and he did the duodenal station as well. But what I think we need to emphasize is, for those who are doing it, obviously who haven't done enough, is that their interest at the moment should not be so much on what we find, it should be on the movements and how we find them. Okay, so we go back in. You come out to the thing. So what I generally do is come back to 30. Now you see there is now just go just a little bit there. Tip up. Tip up. Right, tip up. थोड़ा सा अंदर डालें. No, pull back. Sorry. Pull back. थोड़ा सा pull back. Pull back. Pull back. Right, pull back. इसको यहाँ रखें. Pull back. Keep pulling back.
Minimum standards of reporting.
Keep pulling back. Now you've got the mitral valve, right? Pull. थोड़ा सा rotate करें. Okay. Right. ये जो नीचे वाला है ना, it goes. That's after for. इसको तो यहाँ पे रखें. So you can see the valve. Pull back a little bit more.
सर आप इकोकार्डियोग्राफी सिखावे?
सर जी मैं एरिया 7 को दिखाने की कोशिश कर रहा, but in that process we can see the.
Yeah, I understand. मैं वैसे it was just a light comment.
No, I got your comment. So what I generally do is area 7 is easy, so you just go in, take a tip up. So we have you keep coming there, you've got the left, you let go of the wheel a little bit. So you have aorta, left atrium. Go a little bit more on the left, you've got the mitral valve. Go a little bit more on, you will be able to see generally speaking, the aortic valve is well here. Let me see if I can get that. That's the aortic valve, okay? So you've got aortic valve, you've got mitral valve, and you've got the area 7 there. Okay? Now you don't go for area 7, you don't go completely down, because you're going to, this is what's going to happen. So if you keep this is where you really need to. Once you've seen this, what we were telling you is that once you've seen this, now you go down and pull back and pull back and pull back and pull back, and now you've got the aortic. Okay? And once you've got that in the mid, once you've got that in the so that should be the area 7. That's AP window. But as Rayas was saying, is it really of interest? I think area 7 is important because we see a lot of lymph node but AP window I don't know. Ghyas,
जी जनाब,
आप AP window से आपने पैथोलॉजी कभी कोई lymph nodes कोई कभी biopsy किया है?
हाँ जी.
How often is that?
How often is that? It depends on the referral, because number of times the bigger lymph node is the subcarinal. I go after the biggest lymph node or the most sinister looking lymph node in the imaging, and if the biggest lymph node is in the AP window, I am going to go after the AP window lymph node. If the biggest lymph node is in the subcarinal, I shall go for the subcarinal window.
In my experience, when I've seen, mostly it's tuberculosis that we do for, and really if you got lymph nodes in the AP window, then you always have some nice, decent, juicy looking lymph nodes in the subcarina as well.
Yeah,
But I think in the lung, with the pulmonary malignancies, etc., I think AP window becomes a more important thing, but we don't see it that often.
I entirely agree with you that if let's suppose that I've done 10 cases of mediastinal lymph nodes, at least 6 of them will be because of tuberculosis.
Okay. Right, I mean, you know. So we're done here, so next case is Lele.
EUS guided.
सर इसकी इंडिकेशन क्या? अगर पेशेंट हमारा 1 महीना हो गया है, फीवर नहीं जा रहा है, सीटी स्कैन में शोज
देखो, अगर तो फीवर नहीं जाएगा तो उसका मतलब ये है कि वहाँ पे दो ही पॉसिबिलिटी, यहाँ तो नेक्रोटिक मटेरियल है, तो यहाँ एब्सेस है.
ठीक है.
जब आप एस्पिरेट करते हैं, मिल्की कंटेंट है तो सेप्सिस.
ठीक है.
अगर डर्टी मटेरियल है तो देन नेक्रोसिस.
ठीक है.
तो आपने ओपन कर दिया, डायलेट कर दिया. डायलेट करने के बाद इनिशियली आपने खाली 2 स्टेंट रखते हैं, 3 से 5 दिन बाद दोबारा जाना है.
ठीक है.
उस पर जितना आपको जो है गंदन नजर आता है वो क्लियर होता है. बट मोस्ट ऑफ टाइम पेशेंट्स क्लियर, patients start improving pretty quickly as soon as you establish the drainage and you have a flushing catheter inside.
नेक्रोसेक्टमी के लिए आप क्या यूज़ करते हैं?
हम कुछ नहीं करते, एंटीबायोटिक
मतलब गैजेट
एंटीबायोटिक आम यार जितना भी है आपका जो पैकेज थे ओपन टू फिर
रोटेट या वो यूपीएम?
नहीं, मैं रोटेट नहीं यूज़ करता, मैं उसको वहीं फेंक जाता हूँ स्टमक में.
नेक्रोस हो जाता है तो हम डर जाते हैं, रेफरल और सोचते नहीं
कोई ज़रूरत नहीं, कोई ज़रूरत नहीं रेफर करने, जस्ट वेट, उसको ड्रेन कर दें और वेट करें, क्योंकि सर्जिकल साइड.
सर ड्रेन यूएस हमारा नहीं है खास में
जी हाँ, आज गर्मी की है असल में. कराची में वो बारिश हो गई
आपके होते हुए कम पसीने आ रहे
सीटी गार्ड तो नहीं, आप इधर से परक्यूटेनियस जा सकते हैं, यानी फ्रॉम द लेटरल फ्लैंक आप जा सकते हैं. लेकिन ये कि अगर Instead of sending it to the surgeon, send it to the endoscopic ultrasound specialist.
हमारे पास जो हैदराबाद कराची है ना उसमें देखिए सिविल हॉस्पिटल यहाँ पे
स्कैन करके ना तो फिर आपको दे दूँगा।
ऐसे रहिएगा पापा, कांधे से यूं रहिएगा और अपने ऐसे ही रहिएगा, बिल्कुल ऐसी अपनी जैसे पोजीशन मैंने आपकी बनाई थी वैसे रहिए।
लगा डॉक्टर निकाल ले
क्या?
लगा
कोई बात नहीं, लगा रहने दे।
इसको छोड़ दें, आप उसकी फिक्र ना करें, ठीक है?
हाँ जी, क्या हाल है?
And everybody hear me over there?
नहीं,
Can everybody hear me?
आवाज नहीं आ रही बेटा.
नहीं आ रही ना?
Hello.
Hello, can
Yes.
everybody hear me?
Yes, I can hear you and see you as well.
Okay, so this is a 53-year-old male patient with no previously known comorbids who presented with a complaint of jaundice and weight loss history since 1 year. His ERCP was attempted 3 times in the year 2019. Each of them showed distal CVD stricture. Multiple attempts were made and stent was placed. Currently, his CT showed non-functioning CVD stent and features of cholangitic abscesses in the liver.
Okay, so you've heard the history of this patient. Most likely this is a case of distal CVD stricture with cholangitis and hepatic abscesses. So I'm going to have a quick scan and then I'm going to hand it over to Dr. Shafkat, who is the trainee, and I'm going to talk him through this case. But थोड़ा सा जगह. Should I start?
डॉक्टर साहब थोड़ा सा लाइट कीजिए
बिल्कुल ढीला. बस ठीक है, that's it. उधर ले. इसको भी ठीक है, कोई ज़रूरत नहीं. Can you hear me? Can you hear me?
We are with you, sir.
Okay, but we have plenty of fluid in the stomach, so I'm trying to suck it out. Before
Okay.
giving it to the candidate, I'm going to suck out all the fluid.
So is that because the patient is obstructed?
Most likely, there has to be some kind of obstruction distally.
Yeah,
Otherwise-
this fluid is telling you that this is.
Yeah, that's right.
She's not eaten anything. It's more like.
It's more like a clay fluid or muddy fluid.
While you were screening, we saw the neck area of the
Yeah,
pancreas.
neck area, and that the
Yeah, we saw the pancreatic duct.
pancreatic duct is prominent.
स्टोन था, मैंने तो सिर्फ उस वक्त देखा जब वो नीचे आ रही थी तो
अच्छी खासी है। ये क्यों अटक रहा है बेटा? No, stop. All yours. Okay, I've made an initial scan. I've had an initial impression what exactly the patient is suffering from. I've given the endoscope to Dr. Shafkat. He's going to make a progress. Obviously, first thing is intubation. He has done the intubation in a nice way. He has been able to go down into the esophagus. One can see that there are certain erosions in the inner lining of the esophagus. Now, he has gone inside the stomach. This is the EG junction. At the EG junction, obviously, first, this is the station number 1 where he has to make an inspection of the left lobe of liver, and he can have a look at the other segments of the liver as well. And then turning to the aorta at this junction and looking at the tail and body of the pancreas. Now, one can see that the ducts, the biliary channels are dilated, and that has got an ear as well.
Can we put Doppler on it, please?
Yes, certainly.
Flo?
Close it. जी? This is left hepatic, that's right. This is left hepatic. This is segment 2, this is segment 3. Now, this is ligamentum venosum, fissure, umbilical part. Ligamentum teres on this side. ये वाला ligamentum venosum on this side. Fine, okay. This is segment 1. This is segment 8. This one is middle hepatic vein, this one. And this is porta hepatis. This is IVC. You can see IVC coming, and as we turn clockwise from this point, first we are going to see IVC and then the abdominal aorta.
Were you able to see the abscesses in the liver parenchyma? Shafkat bhai, did you see any abscesses?
Not really up till now, but then the periportal accentuation is there.
जो लिगामेंटम वेनोसम से आप ट्रेस कर रहे हैं ना टुवर्ड्स आईवीसी, तो उस साइड के ऊपर एब्सेसेस आई हैं इन सेगमेंट 1, वो ज़रा देखिएगा दोबारा।
कुछ नहीं है।
नहीं, यहाँ पे आगे जाएं ऊपर की तरफ।
This is IVC, this is middle, this is right. 187. Yeah. We don't see any abscess here, but periportal accentuation is there.
दोबारा स्कैन करिएगा पेरेन्काइमा को। There were 2 or 3 abscesses और एक हेमेंजियोमा आया है सेगमेंट ऊपर 4A में।
नहीं, मुझे नहीं लगी. To be honest, I have not seen any abscess in segment 1. Radiologists have got special eyes to pick up the things. My approach is just like Dr. Saad, pick up the major things, forget about the minor things. ऐसे कामों के लिए रेडियोलॉजिस्ट होते हैं। ओके, ये कौन सी हेपेटिक वेन है?
Can you stop here?
ओके,
Now can you see? नहीं आपने कहा इसी साइड में ना शफकत भाई इधर ही हैं, आप जरा इनको देख लें। Yes, now can you see?
ये आई नो, मेरा ख्याल सिंपल शैडोज है, कुछ भी नहीं है।
नहीं नहीं ये नहीं काफी बड़ी clear काफी नजर आई है जब इस करते हैं ना।
But yet, to be honest, we are not able to appreciate any abscess over here. No hypolucency with ring enhancement.
नहीं रिंग एनहांसमेंट तो भी आपको नजर नहीं आएगी ना इसमें।
Aorta. This is aorta, and you can see the spine on the back. Okay. He has to slide forward along the aorta. These are the blood vessels coming from the aorta. He has to bring them under the transducer. Suck, 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 suck. Celiac सा उसको हाँ जी हाँ. This is the celiac axis. This is the superior mesenteric coming straight. This is the celiac artery.
Bring this area of the pancreas right in the center,
Yeah.
and then you can go.
Let's go follow. This is the pancreas. Okay. Salt and pepper appearance pancreas. This is the pancreatic duct. Now keep the pancreatic duct under your transducer. Go to the clockwise side to take you to the tail of the pancreas, while keeping bring the kidney down here, and spleen should be here. Okay, fine, good, 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 good. Keep coming, keep coming. Okay. This is the pancreatic duct. Okay, fine. Keep coming. This is the spleen. Fine. And this is the tail of the pancreas. Okay, fine. You can go back.
The wall of the pancreatic duct is a bit.
You can go back. So pancreatic duct over here is normal. This is the adrenal.
See the little hyper echoic lining of normally
ठीक है.
you don't see
Good demonstration of adrenal. Okay, fine.
adrenal.
Excellent. Keep going. Bring the PD back under your transducer, and from there. Yeah, this is the confluence. Yes.
You have portal vein
Now
between
go to the counterclockwise.
superior mesenteric
Yes,
vein
good.
and process vein.
Okay, this is the fall of the PD.
The neck area of here. So you have the superior mesenteric vein here. The splenic vein comes from
4.8.
here, and you have the portal confluence here.
4.5. Okay, fine. So PD is little prominent. It's 4.5
Vein will come from
at the
here,
genuine.
and you will have the superior. You'll have the
Right.
You follow it more towards the right.
So this is basically the neck of the pancreas. So are we done here? So you have seen the pancreas, you've seen the confluence. This is the क्या कहना? हाँ, कौन सी? हाँ, but the far away is the CBD. नहीं, ये है CBD. CBD हमेशा ना वेग सी नजर आती है, ये वाली. तो इसको कोई ज़रूरत नहीं है इस जगह पे कंस्ट्रक्ट करने की. चलो आगे चलें. D1 क्योंकि वो है distorted है, so you'll have to do a bit of maneuvering. In a patient who's got a distended stomach or because there's a obstruction down in the duodenum, there's always a kind of difficulty in going into the D1. So one has to have a good endoscopic skills to go into the duodenum. Push, pull. That's how you go into the D1. No, you have to go to the duodenal apex. Yes. You could all vessels there. This way. Okay. We are straight on to the pancreas. Yes. You can see it's the pancreas. These are okay, fine. कौन सी? नहीं ये पैंक्रियास वही है ना? कौन सा ये वेसल्स है? वेसल्स है? मेडियास्टिनल वेसल्स? हाँ, तो उसको इस तरह ले जाके देखो ना ये go in like this. Go to the apex of the duodenum, duodenal cap, D1. Go in with a long scope. As soon as you enter into the D1, you can see the liver. This side, this way. Pose हो नहीं दिखाओ. Let me help. ठीक है? क्योंकि वो deformity है, so you're finding it difficult. You're not able to go down. Yeah. So just as Khalid says that this patient has not learned the book, so because of the deformity, we are not able to go in just as it's written in the book. We are trying to have a look at the pancreas from an angle. This is not the classical anatomy that we expect in the D1. इस साइड पे जाओ, ये फिर आप लिवर वाली साइड पे जाओगे ना. यू आर गोइंग टू, हाँ क्योंकि हाँ ये CVD एरिया, क्योंकि उसमें स्टेंट नजर आ रही है. या this is the common bile duct. You can see the linear lines inside the CVD. Just follow it down to the head region. Clockwise. नहीं लॉस हो तो उसको वहीं पे रखो. Go slow and slight subtle turn and keep the suction on. Big wheel up, big wheel away from you. Try to follow it. नहीं वापस पे जाओ, क्योंकि basically we are interested in the lower end of the CVD. Now you can see the things better. Yes, good. Trace it all the way down to the head of the pancreas. This is the PD, okay. Let's measure this. .3, okay, this is fine. 3.3, slightly upper limit of the normal. नहीं वापस पे हाँ स्टेंट पे आओ. Okay. Now, once you've seen the stent, क्या इशू क्या है इसके साथ, क्यों पंगा करते हैं? नहीं नीचे there is a structure at the duodenum, so you will not be able to go across the duodenal band. No, you will not be able to go into the D2. So whatever examination we have to do it in the D1. कौन सा? lymph node है. lymph node है mass है, lymph node है most likely. देख लेते हैं, देखिए मेरे तो खैर पैंक्रियास सॉरी ये पैंक्रियास वही है, चलो ठीक है ठीक है, ये पैंक्रियास सेपरेट है. We find something abnormal here. This is something which is not normal.
We're with you.
Yes, we find something abnormal here.
This is a large lymph node there.
Yeah, large lymph node. Some. This is PD. This is blood vessel. नहीं वापस आओ जहाँ पे जो.
Just for the audience, can we have flow? Just check the Doppler. When you had the ductal structures, yeah, look.
Go back in. Follow the strand. Follow the CVD down to the head of the pancreas. So suction कर लो. सक्शन ही हो आधी आधी सक्शन को आधा हाफ हाँ करते रहो ना या चलो गुड ओके. On the left hand you got the liver, on the right side you got the pancreas. So we don't want to have a look at the liver, rather we want to go to the pancreas. And in between we got the CVD, we need to concentrate on the CVD. Since the CVD has got a strand that is giving reflections, clockwise like this, just follow the ये distal जो CVD है उसको देखो. Since it's not following the classical anatomy, so it is ठीक है शाबाश. pancreas. हाँ, नीचे से portal vein. This is portal vein. This is pancreatic duct. We want to see the area here. We want to see the area here. जी? हाँ, ये there you see. Okay. हाँ जी. Big wheel up, big wheel down, slight rotation to the right, slight rotation to the left. कर सकते हो, बिल्कुल कर सकते हो. बैलून लगा हुआ है? लोड किया हुआ. नहीं, बहुत ज़्यादा कर दिया. इन्फ्लेट, डिफ्लेट, इन्फ्लेट, डिफ्लेट. लेकिन कम इन्फ्लेट कर, क्योंकि we are in the cap. We don't need that big a balloon. Suction, suction. We don't need a big balloon here.
Why are we using the balloon?
Shafkat wanted to put on the balloon because he was finding it to adjust the tip of his endoscope. So he want a better stable position.
Okay.
So suck back, suck
So
back.
you can
You
use
need
the
a big
balloon-
balloon like this. Okay, keep sucking, keep sucking. You need a smaller balloon. Personally, I don't prefer using balloon in the D1, and to be honest, with a linear scope, I don't use balloon either.
I don't use balloon either. I like you, Riaz, but I've seen some experts.
Khalid
Sometimes,
likes to use a balloon.
sometimes they use it, sometimes they don't.
ठीक है. Now this is PD. We are back to the same place, but we want to see the stent and CVD coming from this direction down here. आउटलाइन करो स्टेंट की, थोड़ा सा इस साइड पे जाके फिर उठाओ. जी?
Can you switch on the flow, please? Yeah, so that's the pancreatic
Saad, what
duct.
do you want to see in the flow?
No, we just wanted, the audience wanted to see the duct and the...
Well, this is the pancreatic duct.
Yeah,
This is the portal vein.
yeah.
These are the other blood vessels which are around pancreas. Now, which one is which? To be honest, I've never thought about it, and I've never tried to trace which vessel is which. Do you do that?
No. Keep it simple is the motto.
Balloon total off करो, balloon total off करो, ताकि आपकी maneuverability easy हो. Good. Now you're in a comfortable position. ये देखो ना, ये आया अब आपका. हाँ, नहीं आप इसमें आ रहे तो basically तो you're interested in, हाँ, you're interested in the
ये स्टैंड नहीं लगा था, ये हाइपर पे.
this one.
हाँ जी, वो हाँ जी.
Yes, maybe. Maybe. But then you need to visualize it better.
ये तो लगता है डबल.
Yes, we've got another 10 cases to do.
Okay. So,
आप तो देख करें.
okay, right. Okay.
Yeah, this is a stand.
Here we follow the stent and we are following the stent down. We are following the stent down. This is the stent, okay. I'm just trying to rotate my shoulder, and I'm going down like this into the pancreatic head.
We can't appreciate the stent lines as well as I'm sure you can from there.
Yes. Can you see now?
we can only appreciate one
this is
line.
the stent, yes, this is the stent, yes.
Is the stent above the? I mean, what is the shadow that is above? Just close to your cursor. If you put a that's vessel.
That's a vessel.
Now we can see it.
Yes.
Yeah, that's better. Can you?
Sorry.
Yeah, we can see it.
But to be honest,
Now,
I don't
now
see
you
any
can see
mass.
it even better.
Yeah. To be honest, I don't see any mass around the stent. Except for that lymph node that we are seeing.
Can you trace this stent down towards the? This may be
Because
flow.
of the deformity, I'm finding it difficult to trace it all
This
the
may
way
be
down.
flow,
to the-
RI. Can you have the Doppler again? This is very strange.
Yes.
Why do you have flow there as well?
No, it's not on the stent. It's around the stent area. There are blood vessels around the stent area.
Riyas, isn't क्या नीचे का duodenal end? Can you focus on that a little bit?
I'm trying to do that, but because of the deformity, I'm not able to
Oh,
go
yeah,
down.
that must be the problem, sir.
This is the maximum that I can see in this patient. Now, can you see better?
Yeah, I can. We can see that.
But still, I don't see any mass around the lower end of the stented area.
Can can we have the flow on here? The audience wants to see what the structures are.
Okay, they can switch to the next room while we try to figure out.
नहीं नहीं. What we were seeing the pancreas very nicely from one area within the bulb, right?
Yeah, that's right.
But now that doesn't seem
No,
to be.
I'm trying to concentrate on the lower end of the CVD.
What I'm saying is that
we can
the
go back.
pancreatic duct should be there as well.
Yeah, that's right.
Because the pancreatic duct was fairly prominent, so maybe.
Yeah, there may be something. Except that lymph node that we are seeing, I don't find anything other abnormality.
I think the issue that you're having is probably you can't pull the scope back a little
Yeah,
bit
that's
more,
right.
right?
Yeah,
because
that's
the
right.
moment you do that, you fall back.
I fall back into the
Yeah,
stomach.
yeah. So that is probably the big issue. And I think is that there is, okay, so you've almost seen it till the pancreatic mass to nahi hai.
No.
Okay. So you've only seen a big lymph node and that's it.
Yeah, that's right. That's the only thing.
ठीक है. Yeah, that's
Do you
the
want me
lymph
to
node.
biopsy that?
Do you want to?
Yeah, I think so. We
Okay.
should be doing biopsy of this lymph node.
Okay, go ahead.
This is a reasonably big lymph node.
Yeah. Sure, go ahead.
22 FNB. Next case ready? Next case ready? देखो.
मशीन को कई बार रेडी रहे स्लाइड आ रही है
तो बढ़ाइए होल्ड करना. It's a very soft lymph node.
Maneuvering of wheels से कर रहे हैं.
हाँ, maneuvering wheel से. चलो. Sir, in a patient like this, how many passes will you like to make?
Yes, usually I'm guided by what comes out and what they tell me after the evaluation. But I think, you know, with the way you went, at least 2 passes.
Yes. And
Usually 2 to 3 is what we do, but it depends on whether we've got the sample and we've got the cells on the microscope.
ever since you have switched on to FNB, do you find any difference in your yield while you were doing FNC?
Sorry?
When you were doing FNAC and now you switched on to B,
Yeah.
do you find any difference?
Yeah, obviously you get nice core tissue with the FNB, but we still continue doing the
On-site cytology.
on-site evaluation.
I think that's reassuring because
Yeah, but it's still and reassuring. Plus, I think it's also. I feel that it's also learning for us, so
Yeah.
we continue doing.
I agree with you. So what does the radiologist think there? Is it a benign looking lymph node or is it inflammatory or
Radiologist,
neoplastic?
we'll give the mic to the radiologist. Do you think this is a benign lymph
एक तो मुझे ना इस पे डॉपलर डाल के दिखा देना लिम्फ नोड. कल जो साथ में बात हो रही थी बिनाइन और मैलिग्नेंट की, जी वो हम लोग डॉपलर पे भी असेस करते हैं क्योंकि यूजुअली जो लिम्फ नोड की सप्लाई आ रही होती है ना दैट इज़ कमिंग फ्रॉम हाइलम. That is normal pattern of vascular supply to a lymph node, and we categorize it as type 1 vascular pattern. जो lymphom अभी ये देखते हैं इसका ना, अब ये हाइलम पे ही आ रहा है, so it is benign. जी, और जो टाइप 2 होगा वो भी हाइलर एसेंचुएटेड वेस्कुलर पैटर्न होता है, and that is mostly seen in lymphomatous lesions. लेकिन वो थोड़ा सा जिस तरह नॉर्मल हाइलर होता है उससे ज़्यादा सेंटुएटेड होता है। इसका मतलब आपको सेंट्रल हाइलम की वैसे नज़र आ रही है और फिर उसकी आर्बोराइजेशन नज़र आ रही है ज़रा ज़्यादा। और नंबर थर्ड जो पैटर्न होता है दैट इज़ पेरिफेरल, तो दैट इज़ प्योरली मैलिग्नेंट, टाइप 3 वेस्कुलर पैटर्न। ये नोड हम डॉपलर ऑन करेंगे तो यू विल बी सीइंग ब्लड वेसल्स अराउंड द लिम्फ नोड पेरिफेरी के ऊपर, तो वो टाइप 3 पैटर्न है जी, दैट इज़ मैलिग्नेंट। So it is sometimes it is very difficult to differentiate between lymphomatous and tuberculous even on Doppler. Benign जो lymph nodes हैं they just follow the normal vascular pattern, type 1 vascular pattern उसको हम बोलते हैं, that is you see the vessel coming from the hilum and then it is dividing into tiny branches, but the pattern is not accentuated or the branches are not dilated. That is basically seen in lymphomatous or tuberculous lesions.
So how many punctures do you make Riaz with the FNB now?
Generally, I make 2 or 3. It all depends. I also follow your routine. As long as I'm guided by my colleague, whosoever is reading the slides. If he says that you got the core, you got the tissue, and we have got the diagnosis right on the first pass, I may stop there. But generally, minimum 2 passes we do make.
Okay.
हाँ मतलब जब तक टिश्यू नहीं आते. Sir, do you want to switch to the other room?
Yeah, we can switch to the other room,
Okay,
please.
fine. क्यों नहीं? हाँ? अच्छा mediastinal. नहीं, तुमने करी बात से?
Other room is here with me.
Okay. Now I'm still on. Any question from the audience on this case? Switch off कर दो. केस हो था टेंशन ना लो, क्योंकि इसमें मुश्किल से वो स्ट्रेंथ को नीचे मैं लेके आऊँ ऑल द वे डाउन, और ये वाइड एब्नॉर्मैलिटी मुझे मिली थी. Pancreatic duct is prominent, I agree, but again nothing unusual, nothing abnormal except for this benign looking lymph node which is large. All other things are normal. हाँ जी, वो इसको ले क्योंकि इसमें काफ़ी कुछ होगा. वो सेंटर में ब्लड वेसल नजर आ रही है. लाओ जी,
टिश्यू आया है इसमें, लेकिन कह रहे हैं कि और
और ले लेते हैं एक दफ़ा ना, इसको सेलन के साथ फ्लश कर दें आप.
सर मैं ऑलरेडी वैसे
कर रहे हैं, बस ठीक, कर दिए तो बस ठीक. अभी ठहर जाओ. क्यों डिफिकल्टी होगी? चलो हाँ जी ऑल अच्छा ये ना कम्बिनेशन होती है कोई इसमें कोई हार्ड एंड फास्ट नहीं है कि आपने कहना है कि मैंने खाली बिग व्हील के साथ ही करना है एज में योर मूवमेंट्स आर मिनिमम यू कैन गो ईदर वे स्कोप की मूवमेंट बिल्कुल नहीं मतलब जैसे रोटेशन है मैं रोटेशन बिल्कुल नहीं इस वक्त करूँगा बस ख़त्म वो पिछली दफ़ा मैं लो में जाओ hopefully we are going to get something good करनी बाइप्सी चलो इसके बाद जो है इसी पे ये एंगल है इसको आपने सामने रखते हैं ठीक है जब आपने लिया है तो उस वक्त जनरली इस डिफ़िकल्ट पोजीशन में जहाँ मेंटेन नहीं होता रख के तो उसको आप लॉक कर दो लॉक करने के बाद फिर जो नीडल को डायरेक्ट कर दो विद द हेल्प ऑफ दिस वन एलिवेटर आ जाओ संभालो पेशेंट की फ़ोटो तो नहीं खींचते पेशेंट की फ़ोटो तो नहीं खींचते हाँ 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 अच्छा अच्छा ठीक हाँ जी क्या हाँ जी की कहते हो नहीं काफ़ी देगा आया की है स्लाइड चेक नहीं की तो बात तुसी हाले तक देखिए कि काम हाँ सैंपल आ गया आओ जी आओ
Can we,
एक
Wasim?
एक और लेना लो ना शौकत ज़्यादा से ज़्यादा चीज़ें अपने हाथ से करने की कोशिश करो अभी आप इधर देखो अभी आप इधर देखो
गयास
जी जी
खालिद ये कह रहे हैं
हाँ
कि लिम्फ नोड तो पूरा वापस आ गया है अब उसमें कुछ बचा नहीं है
वो तो बात ठीक है अब सिर्फ एक मैं चाहता हूँ शफकत जो है वो एक दफ़ा कर ले तो दैट विल बी इट दिस इज़ द लास्ट पास ठीक इधर देखो घूम के ना ना इसको इसको नहीं टच कर दिस इज नॉट द प्लेस ये देखो ना एक मिनट ए ठीक है वो है ना ये आ गई आपकी ठीक है इसको आपने यूँ क्योंकि नाउ आई एम फेसिंग दिस वे लुकिंग एट द लेशन दिस वे एंड दैट्स हाउ आई एम गोइंग टू कम
शीट भी तो बाहर करनी है मुझे
शीट बाहर करनी है वो तो उसका ये कि ये आ गया, लॉक कर दिया। अब आ जाओ, डायरेक्शन ये रखो, हाँ ये हम्म, हम्म, हाँ डायरेक्ट इसके साथ, हाँ हाँ, नहीं इसको यहाँ से आना चाहिए और डायरेक्ट, हाँ हाँ, गुड गुड, गो इन शार्प, या गुड, हाँ हाँ बस ठीक, दैट्स इट, गुड, ठीक है, गो इन आउट, गो इन, गो ऑल द वे, हाँ गुड, वापस, हाँ जाओ, हाँ गुड, जाओ वापस, जाओ वापस, जाओ वापस, ऑल द वे डाउन, हाँ हाँ गुड, और जाओ, ठीक, शाबाश, ऑल, हाँ इसकी डायरेक्शन ऑल द वे डाउन, ठीक, नहीं इसको नहीं, छोटे व्हील को तो, हाँ हाँ गुड, ठीक है, वापस लेके जाओ, वापस लेके, हाँ अब ठीक है, और चलो दैट्स, वापस कहीं, वापस कहीं, लॉक इट, चलो इसको ओपन कर, इसको नहीं, हाँ चलो दैट्स इट। अब आप मीडियास्टम को देखते हुए निकाल लें, चलो मीडियास्टम में आ जाए, बस बस बस, देना भी थोड़ा सा आपको स्टेशन देना, अब आप बस, ये कुछ यहाँ पे लगा था जैसे कोई एब्नॉर्मल से, ये वाला जो है बीच में आया था, ये कुछ एब्नॉर्मल से ये लगा था, मैं आपका रिपोर्ट एक्सेंचुएशन है, ये आ गया आपका 8, आगे पीछे, ठीक है, वेरी गुड, शाबाश, लेफ्ट एट्रियम फाइन, लेफ्ट वेंट्रिकल, लेफ्ट एट्रियम, ओके फाइन, pull back slightly and this is the place, okay, fair enough, good, नहीं big wheel up, हाँ अब थोड़ा सा आगे आ गई, हाँ वापस आओ, हाँ जी, हाँ थोड़ा सा और पीछे, थोड़ा सा और पीछे, हाँ ये दिस वाज द एरिया, जी हाँ बिल्कुल ठीक, ठीक है, ओके, अब एपी विंडो, हाँ जी ये आ गया आपका एओर्टा, गो टू द आर्च, फाइंड द आर्च, स्लाइड पुश एंड, हाँ ये और जाओ, और ऊपर लेके आओ, और ऊपर लेके, हाँ हाँ ये जब आ जाए तो हल्का सा उससे 1 सेंटीमीटर आगे पुश करना था, ठीक है, और घुमाओ, ऊपर आओ, ऊपर, हाँ
और थोड़ा सा पुश,
हाँ ये
ये आ गया,
नहीं वो तो चलो दोबारा ट्राई कर,
ये वाली, ये
या दिस इज द प्लेस,
इसको थोड़ा सा आगे करना पड़ेगा, सॉरी,
वो पेशेंट हिल गया ना,
ये
Wasim, next patient ready है?
ये ऑल्टा इस साइड पे, तो ऑल्टा
हाँ जी हाँ, तो इस साइड पे उठाओगे ना हल्का सा, एओर्टिक आज से आप ऊपर उठाओगे टू द क्लॉकवाइज, देन यू विल सी द एपी विंडो, ये
वाली,
ठीक है, चलो दैट्स इट, ये बंद कर,
थैंक यू सर।
वेल
उसके ऊपर रिसीवर
अभी फिर लास्ट ERCP फिर अक्टूबर में हुई वो उसमें भी स्टेंट डाल दिया और वो पोर्टा पे जो है लिम्फ नोड में दिस इज व्हाट फर्स्ट इंडिकेशन
इसमें क्या आवाज क्यों आ रही है स्पीकर में
बायोप्सी लेने का अगर वो लगेगी तो अच्छा
चलो माइक लगा स्पीकर है इसकी देंगे
Can you hear me? Saad bhai? Anybody?
Yes, sir, Saad, not here, John.
Oh,
We are
okay.
listening you.
Okay, you can hear. So we're gonna go ahead and present the case first, and then we'll start it.
Our next patient is a 40-year-old female who presented to us with a complaint of right hypochondrial pain since 1 year. ERCP and stenting was done 10 years back. Then lab chole was done 5 to 6 years back. Then an ERCP and stenting was done in September, and then in October it was done. So stent is placed. CT scan shows mild dilation of the intrahepatic duct and enhancing thickening at the confluence of the biliary channels, and few enlarged lymph nodes at the parahepatic and the para-aortic and the peripancreatic region. Now we'll proceed with the EUS.
So basically, the indication for EUS is there are porta hepatis lymph nodes, and there may be a possible thickening of the bile duct. Okay, let's go ahead.
पी जाइए शाबाश पी जाइए बस हो गया वेरी गुड
ठीक है, अब यहाँ पे तो स्कोप को जो है ना सीधा इसी तरफ अभी से कर लें, एंड जस्ट कीप थोड़ा सा इन्फ्लेट करें तो आपको वॉल नज़र आना शुरू हो जाए, क्योंकि कुछ का स्ट्रक्चर होगा तो यू हैव टू गो वेरी जेंटली, कीप गोइंग जेंटल जेंटल, ठीक है, gentle, you get through the GE junction. Okay, stop there, and then big wheel, rotate a little bit to the left, the scope.
Big wheel.
Rotation is not with the wheel, right?
Yeah.
So I will, when rotation is, this is the rotation.
Right.
ठीक है, तो अगर आप स्कोप को सीधा रखेंगे, वो व्हील्स का मैं ये जब होगा तो अप एंड डाउन राइट एंड लेफ्ट, ठीक है, व्हील्स. तो कैन आई सी द स्टमक इन्फ्लेट? Yeah, good. ठीक है, तो ये देखो, तो इसके whatever you do right here, that needs to be transmitted there. ठीक है, ये देख रहे हैं जी. नहीं, अभी भी स्कोप आपकी रेस्ट कर रही है, स्कोप नीड्स टू बी स्ट्रेट, ठीक है, थोड़ा सा पीछे हो जाए स्टेप. अब रोटेट करें, राइट, देख रहे हैं इस तरीके से, दैट्स व्हाट नीड्स टू बी डन. ठीक है, अब मुझे दिखाएं जी जंक्शन दोबारा, इन्फ्लेट हियर. आई जस्ट वांट टू शो यू लाइक, ओके, ठीक है. अब जी जंक्शन से आप नीचे चले गए, जस्ट गो टूवर्ड्स द ऑपोजिट वॉल ऑफ द स्टमक, राइट देयर, ठीक है. अब आपने सक्शन, ओके, बिग व्हील टूवर्ड्स यू, ठीक है, अब यहाँ पे रुक जाए, ठीक है. You see, you're right on to the liver.
Right.
ठीक है. Half of the liver is on the right and other half is on the left almost.
Right.
Okay, थोड़ा सा इसको रोटेट करें right की तरफ. Okay, good, excellent. ठीक है. तो अब जो है ना, move the scope back just a little bit, ठीक है, ताकि 2/3 लेफ्ट की तरफ हो जाए और 1/3 राइट की तरफ हो जाएगा. यहाँ से अब रोटेट करते जाएं टू द राइट, ठीक है, गुड 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 गुड, एक्सीलेंट, कीप गोइंग कीप गोइंग कीप गोइंग कीप गोइंग कीप गोइंग, चलते जाएं चलते जाएं चलते जाएं चलते जाएं, ठीक है, थोड़ा सा रोटेट, चलते जाएं चलते जाएं चलते जाएं। ओके, अब जो है ना आपके सिर्फ ये यहाँ पे हो रहा है, नथिंग इज हैपनिंग देयर, कुछ भी नहीं हो रहा, आप उल्टे हो जाएंगे तो फिर भी नहीं होगा, ठीक है,
ट्रांसमिट नहीं
तो
हो रहा।
हाँ ट्रांसमिट नहीं हो रहा, दोबारा यहाँ से शुरू करें, आप करें दोबारा, इट नीड्स टू बी ट्रांसमिटेड, ठीक है, नहीं तो आप एओर्टा तक कभी नहीं पहुँचेंगे, ठीक है, चलते जाए चलते जाए चलते जाए, ठीक है, चलते जाए चलते जाए चलते जाए, ठीक है, ऑलमोस्ट देयर, राइट, ठीक है, अब एओर्टा आ गया ना आपका, ठीक है, थोड़ा सा रोटेट करें राइट की तरफ, ओके गुड एक्सीलेंट, तो अब एओर्टा यहाँ पे आ गया, अब होल्ड करें स्ट्रोक को, ठीक है, और गोना जस्ट फॉलो द एओर्टा, हाँ जी प्रोसीड करें, बट एओर्टा नीड्स टू स्टे इन व्हील, ठीक है, ओके, एंड व्हील आपका जो है ना पुल कर रहा है, थोड़ा सा रिलीज करें, ठीक है, ओके गुड, ठीक है,
अच्छा एक मिनट यहाँ पे रुकिएगा, ये बहुत दूर मेरे लिए पड़ रहा है, जैसे
नहीं तो ठीक है, आगे नज़दीक हो जाए, व्हील आप बहुत ज़्यादा मूव कर रहे हैं, तो इसको जो है ना उसको रिलैक्स करने दें व्हील को ना, ठीक है, राइट देयर, ठीक है, जेंटली एडवांस करें स्कोप को, पकड़ें ना, देख रोटेट, देखिए कितनी रोटेशन आपको ये करनी पड़ी है, तो जस्ट डू अ लिटिल बिट मूवमेंट, वही वाला हिसाब है कि स्कोप का जो है ना 1-to-1 ट्रांसमिट नहीं हो रही, ठीक है, अगर यहाँ पे, ठीक है, थोड़ा सा एडवांस करें स्कोप को और रोटेट राइट एंड लेफ्ट टू सी समटाइम्स द सीलियक कम्स ऑफ द साइड ऑफ द एओर्टा, ठीक है, चलते जाए चलते, राइट देयर, वो देख रहे हैं आप सीलियक, राइट देयर, ये है सीलियक, ठीक है, अब जरा थोड़ा सा रोटेट करें राइट में, बिग व्हील अ लिटिल बिट टुवर्ड्स यू,
टुवर्ड्स मी,
हाँ जस्ट अ लिटिल बिट, ठीक है, इसमें वेरी जेंटल मूवमेंट्स है, यहाँ पे एओर्टा है ना, ठीक है, अब स्ट्रेट है, तो अगर आप यहाँ से इसको रोटेट करें लिटिल बिट टू द राइट और लेफ्ट, मैंने लेफ्ट की तरफ किया है तो सीलियक आ गई है, ठीक है, समटाइम्स द सीलियक कम्स ऑफ द साइड ऑफ द एओर्टा, ओके, बिग व्हील अ लिटिल बिट टुवर्ड्स यू, inflate the balloon a little bit, वो थोड़ी सी है, राइट है, that's it, okay, अब दे लेट्स फॉलो द सीलियक, ठीक है, सीलियक को फॉलो कर रहे हैं ना, ठीक है, जेंटली पुश करो, हाँ जेंटली, वेरी जेंटली, और थोड़ा सा इसको रोटेट करें राइट एंड लेफ्ट टू सी वेयर इट इज गोइंग, ठीक है, okay, looks like it's kind of the common hepatic is going downwards right there, and this is splenic, so we're going to just follow the splenic, ठीक है, फॉलो द स्प्लेनिक, जब थोड़ा सा दिन और दूर राइट और लेफ्ट करना पड़ेगा, ठीक है, तो रिलीज द व्हील नाउ, रिलीज मींस ओके,
अवे फ्रॉम द वर्ड,
yeah, away from and just gently advance the scope, takes you straight to the pancreas,
ठीक है, pancreatic duct,
yeah, that's the pancreatic duct, ठीक है, तो अब स्प्लेनिक आर्टरी यहाँ पे है, स्प्लेनिक वेन यहाँ पे है, pancreas यहाँ पे है, we are not seeing anything because there is too much artifact there, ठीक है, तो आप deflate करें बलून को completely और थोड़ा सा inflate करें, very minimal, थोड़ा सा inflate करें बलून को, थोड़ा और करें और put a lot of water in there in the balloon now, okay, अब दोबारा उसको deflate करें,
ये क्यों कर रहा है,
ताकि वो एयर जो है ना बलून जो है ना वॉल को लगे, हाँ आर्टिफैक्ट से देयर इज अ एयर ऑन द वॉल, तो थोड़ा सा इन्फ्लेट करो दोबारा, आई थिंक दैट्स फाइन, अ लिटिल बिट बेटर, तो एटलीस्ट आपको ये नजर आ रहा है ना पैंक्रियास, ठीक है, ये क्या है,
दिस इज स्प्लेनिक आर्टरी,
ये क्या है,
स्प्लेनिक वेन,
ठीक है, और ये होल पैंक्रियास, ठीक है, पैंक्रियाटिक डक्ट राइट इन द सेंटर, तो आप ऑलमोस्ट बॉडी के ऊपर है, ठीक है, to go towards the tail what do you need to do,
हमें क्लॉकवाइज रोटेट करते हैं एंड हल्का सा उसको
पुल करते हैं, ठीक है, अगर पैंक्रियास आपका राइट की तरफ जा रहा है, ठीक है, तो आपको स्कोप पुल करनी पड़ेगी टू ब्रिंग इट अंडरनीथ द ट्रांसड्यूसर, अगर लेफ्ट की तरफ जा रहा है तो आपको पुश करनी पड़ेगी, ठीक है, सो रोटेट टू द राइट, किधर जा रहा है पैंक्रियास,
पैंक्रियास अब ये इस तरफ जा रहा है, टू द लेफ्ट जा रहा है,
तो क्या करना पड़ेगा आपको,
थोड़ा सा अंदर पुश करना पड़ेगा,
बिल्कुल, ठीक है, एंड देन रोटेट, कंटिन्यू रोटेशन, ठीक है, कुछ काइंड ऑफ लॉस देयर, ठीक है, तो आपका there's no pancreas anymore, right? ठीक है, go to the left.
वो इसी पोजीशन में आ रहा
Yeah, I don't see any pancreas right there. I think pancreas may be up here.
है. Okay.
Pull the scope back. Pull back, pull back, pull back, pull back further. So rotate करें. Right there. That's the pancreas. You see that?
जी.
ठीक है. तो आपका pancreas ऊपर था, वहाँ पे जहाँ पे हम देख रहे थे वहाँ पे नहीं था. तो ये नज़र आ गया आपको pancreatic duct? ठीक है. If I put a Doppler on there, there's no flow in that. ठीक है. और यहाँ से अब rotate करें right को, pancreas आपका यहाँ पे है, चलते जाए. Pull the scope back a little bit, ठीक है? Just a little bit. Good, excellent. Keep going to the right. Keep going, keep going, keep going, keep going, keep going, keep going. We still have a pancreas there, ठीक है? We gotta keep looking at it until we completely there is no pancreas there, ठीक है? चलते जाए. अब आपका left kidney आ रहा है ना ऊपर, ठीक है? Nice. Left kidney आ रहा है. और looks like it should the tail. I still see a duct right there. Maybe a little bit. It might be ending in there. Something maybe even going downwards, which you are not seeing in the right plane right now. So what I'll suggest is release the wheel a little bit, and rotate to the right. Right. No, this way.
Right. Oh, sorry.
Other right. Right. So I don't see much. I still see the duct right there, but nothing beyond that. ठीक है?
Right.
आप ऐसा करें, थोड़ा सा एडवांस करें स्कोप को.
अब मुझे देखना है.
नहीं स्प्लीन को छोड़ दें, हमने स्प्लीन नहीं देखना.
मैं यही पूछ रहा हूँ कि क्या चीज़ दी.
हाँ, वो जब स्प्लीन पे हम
यही पूछ रहा था कि किस चीज़ को देख रहे हैं हम.
पैंक्रियास को देख रहे हैं ना. तो हम सिर्फ पैंक्रियास का कर रहे हैं. ठीक है, आपका लेफ्ट किडनी नज़र आ गया. रोटेट करें राइट को, करते जाए. ठीक, थोड़ा सा लेफ्ट की तरफ जाए, थोड़ा सा. Looks like it ends right somewhere there. ठीक है जी. ओके, अब लेफ्ट की तरफ एंटी क्लॉकवाइज रोटेट करते जाएं. हमने नेक की तरफ जाना है. ठीक है, बॉडी से होते हुए चलते जाएं. गुड, एक्सीलेंट. चल अब यहाँ पे रुक जाएं. देख, नाइस पैंक्रियास. ठीक है, डक्ट इज गुड. कीप गोइंग टू द लेफ्ट. कीप गोइंग, एक्सीलेंट. डक्ट राइट देयर. ठीक है, अब जब ये जो है ना थोड़ा सा आपसे भागने की कोशिश कर रहे हैं. ठीक है, you need to advance the scope just a little bit and big wheel towards you. थोड़ा सा एडवांस करें स्कोप को. ये देख, it will fall down into the neck right there. ठीक है,
जेन्यू में आ रही है.
जी बिल्कुल. ठीक है,
एंड यहाँ पे पोर्टल वेन भी नजर आएगी. Sorry. I'm just asking.
Okay. Let's just say the duct. ठीक है. अच्छा,
इसी को follow.
हाँ, इसी को फॉलो करते हैं.
So we are going to anti-clockwise.
Big wheel towards you a little bit. Big wheel towards you a little bit. ठीक है. I'll just advance the scope a little bit. Okay. Left की तरफ rotate करें anti-clockwise. Okay. We're losing that. Rotate it to the clockwise. Right there. ठीक है. अब ये confluence आपको नजर आ रहा है portal vein का right there. ठीक है. This is what you are talking about. ठीक है. तो duct यहाँ पे. Big wheel towards you a little bit. ठीक है. अब थोड़ा सा एडवांस करें स्कोप. आपको नजर आ गई ना पोर्टल वेन. दिस इज व्हाट यू आर टॉकिंग अबाउट. ठीक है, तो एक्सीलेंट राइट देयर. ठीक है, तो ये दैट्स व्हाट यू आर लुकिंग एट द पोर्टल कॉन्फ्रेंस. पुल द बिग व्हील टुवर्ड्स यू अ लिटिल बिट. रोटेट टू द राइट देयर. ठीक है, पोर्टल वेन आ गई. Portal vein, why there is no flow? That's portal vein or something else? Rotate to the right? No, that's a solid organ, I think. Right there. This is that area. Portal confluence now. ठीक है? तो
कौन सा सर यहाँ पे arrow है ये?
Yeah, this is a confluence. So this is a splenic.
ठीक है.
This is SMV.
ठीक है.
That making a portal vein.
ठीक है. And
that's going towards the liver here. You see a portion of the pancreatic duct right there? ये जहाँ पे arrow है, right where the arrow is. You see that? That's a part of the pancreatic duct. So pancreatic duct is coming right here, and you're seeing a one portion over there, other portion over there. So this is the portal vein right here. Go to the left.
ये pancreatic duct जो है ये
crossing into the from the neck into the head. ठीक है? तो portal vein, yeah, you can follow that downwards. Or bile duct would be somewhere in there, and but we are not going to pay attention to that right now. यहाँ से आप left की तरफ जाएं. लेफ्ट ओर ठीक है. No, just let's see the duct right there, that's it. Okay, I think I saw the neck of the pancreas right there. I'm just wondering what that is. Is some solid organ or the lymph node or something is there? But we'll take a look at that. It may be close to the hilar area. ठीक है. तो चलें अब चलें D1 में चलें. I think it may be a lymph node right there. वो डॉपलर बिल्कुल नहीं है उसमें ना. This is the one porta hepatis lymph node possibly could be in that area. ठीक है. तो चलें. हाँ जी, आप duodenal bulb में. If you don't see it, what you can do is like वापस अब दूसरा ये कि आप स्क्रीन बड़ी कर सकते हैं. ठीक है. So you are getting a little farther. ठीक है. So that's why it's important sometimes just take a look with the bigger screen. Okay. Now let's come back to the stomach and then go again. Come back to the stomach because you need so when you are pulling it back, the scope is coming into a short position, but we need it in long position when in the duodenal bulb. So come back a little bit. Okay, start over. Good. Right there. Good. Now let's go into the bulb a little bit. Big wheel, say just यहाँ पे stop हो जाए. Big wheel a little bit away from you. Away. ठीक है. To see where the lumen is. थोड़ा सा उसको inflate करें आप. I just want to show you what you need to take a look where the transducer needs to go. हाँ जी बिल्कुल. Let's go do it again. It's okay. ठीक. आप no, you keep falling back. Inflate करें जरा इसको. ठीक है. तो वहाँ पे duodenal apex शुरू हो रही है. The goal is to go into the left upper corner of the duodenal apex. ठीक है. Big wheel a little bit towards you. Okay. So just go in with the scope a little bit while big wheel towards you, and now suction everything. Inflate the balloon a little bit. Okay. Rotate a little bit to the right. यार ये बड़ा कर देना. बस ठीक है. Go a little bit to the left now. आपको क्या नज़र आ रहा है यहाँ पे आप? Okay, मैंने I'll stop it here. ठीक है, freeze करता हूँ.
ये this is probably the portal vein here. This one, it's the portal.
Yeah, this one is portal. Okay.
Flow करके देख लेते हैं. And then ऊपर जो है आपका bile duct. ये pancreatic duct is this?
One thing at a time, right? So this is what is
CBD.
ठीक है.
This is pancreatic.
ठीक है. And the head of the pancreas. ये क्या है?
Again node.
You think it's a node?
पहले flow करके देख लें.
नहीं what the possibility is flow करके
यहाँ
देख
पे
लें.
this is portal vein की continuation में आ रहा है.
SMB.
Is it? SMB.
ठीक है. वो यहाँ से आ रही है और splenic नीचे से आ रही है, making the portal vein right there. ठीक है. तो just इसको थोड़ा सा rotate करें. Just gently advance the scope a little bit. ठीक है. अब इसमें से आपने एक चीज़ पिक करनी है. या तो आपने pancreatic duct पिक करनी है या bile duct. We'll take a look at one thing at a time. ठीक है. तो कौन सा किस पे आपने concentrate करना है? You just pick. ठीक है. Bile. Okay. Let's pay attention to that. Let's find the bile duct properly. Rotate a little bit towards the left. Okay. ये वाला lymph node जो है ना, ये वाला हमें नज़र आ रहा था जो हम पहले देख रहे थे. So it's a porta hepatis lymph node. जो हम स्टमक से नहीं नज़र आ रहा था हमें. That's what it is. ठीक है. तो
पूछ सकता हूँ ये lymph node वैसे well circumscribed नहीं है.
It doesn't look like malignant lymph node to me honestly. It looks like a benign triangular shape. You see the fibrous strands, and it's not like a hypoechogenic. It's more like a portions with the isoechogenicity. ठीक है. ठीक है. तो let's go back to the bile duct. Good. Right there. ठीक है. ये bile duct आ गई ना आपकी. ठीक है. bile duct में stent लग रहा है ना. स्टेंट है ना इनका आपको. हाँ जी.
ये जो whitish line आ रही है.
ये whitish और दूसरा ये कि एयर भी है bile duct में आपके. और दूसरा ये दोनों जो है ना hyperechogenic. That's a stent. ठीक है. और pancreatic duct right यहाँ पे. तो let's just follow that. कहाँ अब आप ना ऑलमोस्ट सेंटर में है, ठीक है ना बाइल डक्ट के, तो टू फॉलो इट टुवर्ड्स द एम्पुला व्हाट यू नीड टू डू,
राइट साइड पे
ठीक है, कीप गोइंग, कीप गोइंग, गुड जॉब। यहाँ पे अब देखें ना आपसे, इट्स रनिंग अवे फ्रॉम यू, सो व्हाट डू यू नीड टू डू, बिग विल टुवर्ड्स यू, दैट विल पुल इट अप, gently advance the scope to approximate it further and then keep rotating to the right. Nice. Keep going, keep going, keep going, keep going, keep going to the right. Excellent. Keep going. Okay. We still did not see the pancreatic duct very clearly in that area. Okay. Let's go back anti-clockwise. Anti-clockwise. Maybe just because of the shadowing from there as well, from this time. Okay. राइट थे, ये क्या नजर आया, जबरदस्त, ठीक है। तो बाइल डक्ट ऊपर है, पैंक्रियाटिक डक्ट नीचे, ठीक है। रोटेट टू द राइट अ लिटिल बिट, राइट देयर इज द पैंक्रियाटिक, राइट, बाइल डक्ट इज राइट हियर, थोड़ा सा रोटेट करते जाएं राइट पे, थोड़ा सा और, लुक्स लाइक इट्स दिस इज द एम्पुलरी एरिया, क्योंकि ये आपको डुओडेनल वॉल नजर आ रही है, ये मस्कुलरिस प्रोप्रिया ऊपर से आ रहा है, ठीक है, तो लाइकली दिस इज वेयर इट्स एंड्स, ठीक है। अब दो चीज़ें कर सकते हैं, बाइल डक्ट को फॉलो करें टुवर्ड्स द हाइलर एरिया, ठीक है, या पैंक्रियाटिक डक्ट। लेट्स फिनिश विद द बाइल डक्ट, सो लेट्स फॉलो दैट टुवर्ड्स द हाइलर एरिया, क्योंकि एक चीज़ इसका ये था कि हाइलम हमने देखना था फॉर द लिम्फ नोड्स, ठीक है। तो इसको कंटिन्यू, उसके लिए क्या करना होगा आपको, परफेक्ट, कीप गोइंग, बिल्कुल। तो ये सारा जो है ना, देयर इज सम स्लज इन द बाइल डक्ट एज वेल अराउंड द स्टेंट, यू सी दैट वाइट, सो ओके। तो अब यहाँ पे, ठीक है, आपको बाइल डक्ट जो है ना, अब आपके पास और कोई चारा नहीं है, अगर आप रोटेट करेंगे तो इट माइट डिसअपीयर, सो व्हाट डू यू नीड टू डू इज मूव द बिग व्हील अ लिटिल बिट अवे फ्रॉम यू, देयर यू गो, लिटिल बिट मोर अवे फ्रॉम यू, ठीक है। अब दोबारा आपके व्यू में आ गई है, नाउ यू रोटेट एंटी क्लॉकवाइज, कंटिन्यू दैट, आपके फिर गायब हो रही है, तो यू पुश द स्कोप इन अ लिटिल बिट, push the scope in and keep rotating and move the big wheel away from you. You see the bile duct, there's a lot of sludge in there, and you see the stent. There's a sludge around the stent. You see it's moving around as well, and it's whitish. The lumen is not very clear. So and you see
sludge की क्या identification है?
ये देख रहे हैं ना कैसे मूव कर रहा है आपका, और दूसरा ये कि और स्टेंट के आसपास मूव कर रहा है, वी नो इट्स अ बाइल डक्ट, देयर इज अ स्टेंट इन देयर, एयर भी है, ठीक है। और दूसरा ये कि इट्स नॉट, इट्स काइंड ऑफ अ मोर लुकिंग लाइक अ आइसोएकोजेनिक, ठीक है, कुछ देयर इज सम शैडोइंग व्हिच मोस्टली फ्रॉम द एयर। तो आप जो है इसको रोटेट करते हैं लेफ्ट की तरफ, यू स्टिल आर नॉट डन विद द बाइल डक्ट, स्टिल नॉट डन विद द बाइल डक्ट, keep going until you see the liver area, you see the air in there, big wheel a little bit towards you, so maybe release a little bit now, that was too much, keep rotating to the left, keep rotating, now we started seeing the liver, you see that, so that's we're right at the porta hepatis right now, ठीक है, ये सारी air है और sludge है इसमें। तो लिवर आ गया ना, वो इसलिए आ रहा है कि हम हाइलम के बिल्कुल करीब हैं, पोर्टा हेपेटिस, ठीक है। अब यहाँ से दोबारा आप रोटेट करें क्लॉकवाइज while keeping the bile duct in view, good, keep going, keep going, keep going, keep going, keep going, देख रहे हैं bile duct, बिल्कुल, keep going, right there bile duct, ठीक है। अब थोड़ा सा big wheel towards you to get rid of that air, you see that how it disappeared, ठीक है, चलते जाएं राइट की तरफ, चलते जाएं, get big wheel towards you now, pull the scope back a little bit because you are losing it this way, ठीक है। बहुत ज़्यादा आर्टिफैक्ट आ गया, तो आई थिंक मे बी जस्ट पुट अ लिटिल बिट वाटर इन देयर इन द बलून, और जब ठीक हो जाए ना तो उस वक्त स्टॉप देयर बिकॉज यू डोंट नीड टू फिल इट अप रियली, I mean, still, yeah, I think a lot of air bubbles there. Challenge, if it doesn't, what you need to do is need to completely get off the wall, see the lumen, and then fix it. You see so much air in there. Okay. You can always start over, ठीक है? और हमने वो तो देख लिया, हमने पहले एम्पुला देख लिया था, तो but we need to go back to the ampulla to take a look at the pancreatic duct. You remember? Okay, come back a little bit. come back. You can come back into the stomach and go back in there. That is fine. हाँ, ठीक है, चलते जाओ. Good. Big wheel towards you. Okay, अब छोड़ दें इसको ना, ज़्यादा करने की ज़रूरत नहीं है. Big wheel towards you, approximate, perfect. ठीक है. Let's find the pancreatic duct now. क्योंकि bile duct is right here. ठीक है. अब and this is the area of the ampulla. You see the wall muscularis propria? That's the ampulla. So PD is going to be right here. ये जो black नहीं है नज़र आ रही, ठीक है, यहाँ से ये जो इसको कहते हैं duodenal fall. आपको stent नज़र आ रहा है, उसके नीचे PD नज़र आ रहा है, ठीक है. Let's follow the PD now, ठीक है. So big wheel towards you, little bit towards you. We are at the ampulla, so we have to get to the neck, okay. From here, big wheel towards you a little bit more towards you, or rotate to the left while pushing the scope in a little bit. Good. You see, अब बेहतर हो गई है, more from. It will go this, then this way, and then it's going to come around the portal confluence like this. Okay, so that's the course we will have to follow. Okay, let's not lose it. Push the scope in a little bit. Okay, a little bit more. Okay, now keep rotating anti-clockwise. Keep rotating. You got it. You see that? How it's going? Keep going. And the portal confluence is coming. Keep going. Perfect. Excellent. Keep going. Big wheel towards you. Little bit, because you're losing that. And it's going to go into the genu and fall down that line. But you got all that. Right? You see? Still there. You remember this is why the lymph node we were looking from the stomach earlier? So that's the same lymph node which you were looking. And it was close to the portal vein, it was close to the pancreatic duct, and that was the area where it was in the genu. Big wheel a little bit towards you further.
खालिद भाई duodenal fall एक दफ़ा प्लीज़ दोबारा से demonstrate कर देंगे?
अच्छा. Keep going. Anti-clockwise. Keep going. Good job. Excellent. Keep going. Anti-clockwise. Let it fall down. There you go. Okay? That we saw that area from the stomach as well, and we saw that again, and we see a lymph node again. Earlier it was on the opposite side, and now it's closer to the transducer. Consider it. Earlier we were looking from the top down, and now we're looking from the bottom up, because it was a short scope position from the stomach looking down. We are in a long position and looking up like that. Right. So that's why everything flipped. Okay? Right. Okay. So good. The duodenal fall. 1 minute, sir.
Thank you.
Good. Excellent job. So ये वाला मैं आपको दिखा रहा हूँ, ठीक है? अब look at that, how beautiful. As soon as I put my scope right where I need to into the duodenal bulb, right at the duodenal apex, you see the pancreatic duct right here. If I need to follow that, I'm just trying to keep the pancreatic duct right underneath the transducer until it disappears into the genu. Right there, you see that? And now going back. Right there, going back means towards the ampulla. Going towards the ampulla. थोड़ा सा और दे दें. Light हुई है, ठीक है. Just give me 30 seconds. Let the patient stabilize, and then I'll show you the duodenal fall again. Okay? So, anybody there? Does anybody want me to FNA the lymph node, or you guys are happy that it's a benign? Okay, nobody wants to answer that.
क्या करे कर ले?
It looks benign to me. I need to ask Saad bhai or Dr. Sajda.
खालिद भाई
जी.
जो पिछला केस था ना जिसमें बिनाइन लुकिंग नोट था वो मैलिग्नेंट निकल आया तो मैं ख्याल कर ही लेते हैं फिर.
One thing where I don't know if you noticed lymph node, that lymph node was not sticking to the needle. Needle was moving very easily into back and forth. So, yeah, so that was one thing I said, like a benign lymph node usually sticks to the needle. Okay. तो आप duodenal fall की बात कर रही थी यहाँ पे ना? So you see the bile duct right there, you see the pancreatic duct right there. So I will follow that towards the ampulla, following that towards the ampulla. And do you see this black line right there?
जी hypoechoic जो CBD के साथ आता है जी ठीक है
CBD, that's the duodenal muscularis propria.
Okay.
इसको duodenal fall कहते हैं. You need it to go down to really take a look at them.
ठीक है. Thank you Khalid bhai.
To keep that, because if you don't see that, you don't know if you're maybe in the upper head of the pancreas and the just pancreatic duct and bile duct are coming close to each other. That's it. And sometimes they go parallel to each other for 2-3 centimeters, and you think you are at the ampulla, but you really are not. You are in the distal head of the pancreas.
यहाँ से जो pancreatic duct को देखा था वो आप clockwise rotate करते हुए
नहीं, हाँ clockwise ampulla हो गया ना, तो फिर उसके बाद बाकी pancreatic duct को देखने के लिए you have to do the whole movement is anti-clockwise.
अच्छा, the same. उसके लिए CBD के लिए भी anti-clockwise था और इसके लिए भी anti-clockwise.
Exactly. बिल्कुल ठीक है. ये बहुत ही benign lymph node लग रहा है, seriously.
ये बहुत ही लग रहा है तो फिर देख लें खालिद भाई रहने देते हैं.
Okay. So I know it's a larger and but it really looks very benign. If they want me, I can. I'm happy to do it. I don't know how many cases are left. So. ये आपको नज़र आ रही है pancreatic duct. मैंने D2 से शुरू किया है यहाँ से. You see that pancreatic duct nicely right at the ampulla, and it's going through the genu up there. It's taking a turn and it's going to go up there. So I'm coming back from D2 and just mainly basically paying attention to the pancreas. You see the pancreas is still there. Pancreas is still there. You see the duct right there still?
जी खालिद भाई आ रही है.
Yeah, I'm almost in the proximal body now. I'm back into the stomach and right there you see that, and getting back to the tail, right that area in this area. Right here, going all the way to the tail. ठीक है? आ जाओ आप. Let's do one time D2. नहीं D2. हाँ जी D2 एक दफ़ा कर लें. करना है आपने?
जी जी.
हाँ जी ठीक है. I think you noticed that everything in there, like aorta, IVC, right kidney, and then from there I rotated it to the right to get to the pancreatic duct and bile duct, and then just moved back. Okay. ठीक है, good. ठीक है, अब short position में आ जाएं. ठीक है.
आपने उससे कहा था एम्पुला देखना जरूरी नहीं.
जरूरी नहीं. Exactly. Short position में scope is stable. You see that here at the stand, so this now big width towards you. ठीक है, suction करें all the air out. Actually जो है ना वो ज़रा लगा दो उसको दोबारा EUS पे. ठीक है, तो air is still there, so air should be suction from right in the center of the lumen. So right there. Okay, good, excellent. So here, what do you see? Just stop right there. Do you see anything which makes sense? What is this? Yeah, IVC, okay, very compressible. You see that?
Yeah,
okay,
yeah.
so IVC is, and from there you rotate it to the right. and what did it come?
aorta.
Aorta. ठीक है. अब यहाँ से आप rotate करें left की तरफ.
Sir, ये तो यानी ये खुद ब खुद ही हो गया. I didn't do
No, because you are in the right position. You said shorten the scope, and you're in the right position. You rotate it a little bit. Something is going to come out of those 5 structure if you are in the right position. ठीक है. So either it's going to be right kidney, it's going to be IBC, aorta, bile duct, pancreatic duct. One thing will come out of those 5 if you are nicely reduced in the right position. And one thing you will see that like there is not much space in the between those if your scope is in the right position. तो अब aorta आ गया, ठीक है. उसको aorta को लेके आए position में दोबारा, right there, ठीक है. अब यहाँ पे जब aorta position में आता है, तो I start looking in the right upper corner and I see the pancreas right there, ठीक है. This is a pancreatic tissue right there. नजर आ गया ना आपको, ठीक है. अब इसको मैं भूल जाऊँगा aorta, ठीक है. I will pull the scope back gently. Pull the scope back, pull the scope back, pull it, pull it, pull it. Release the wheel a little bit, just very little, ठीक है? आप pull करते जाएं और, and the reason I'm releasing the wheel is so I don't want to put too much pressure on the duodenum, ठीक है? चलते जाएं और pull करें थोड़ा सा और, ठीक है? And this is one of the duct looks like, right? Right there, ठीक है? Rotate करें right या left की तरफ? Maybe not. That's a vessel. So let's rotate to the left. So this is pancreatic tissue, no question. So let's go back into the on the aorta, release the wheel a little bit. Okay. Now rotate a little bit to the left. हाँ, ठीक है. आपने over correct कर दिया था अपने आप को, ठीक है. आप बहुत right की तरफ चले गए थे. This is a very nice actually view. You see the pancreatic duct here, you see the ventral head of the pancreas, and you see the dorsal head of the pancreas. There's a nice demarcation right there. Okay? Okay. So big wheel towards you. A little bit. Okay. A little bit more. Okay. Now pull the scope back a little bit. Can you get the PD in the better view? ये air मेरे ख्याल stent की में से आ रही है. ठीक है. Rotate right or left?
थोड़ा सा hard हो रहा है यानी pull करना. थोड़ा सा wheel
stent आ गया आपका वहाँ पे, ठीक है. Right there is the stent. You see that?
That is CBD.
Yeah, CBD stent. यहाँ से rotate करें right की तरफ a little bit more, little bit more, little bit more. You see the PD right there. ठीक है. तो ये pancreas था वो. अब go a little bit to the left. So you never put too much pressure. When it's not coming back, you stop there and then do a right and left. To find your structure, if you don't find, then you release the a wheel a little bit bigger one. Okay? So we got that here. We know that right there, pancreatic. So we're just gonna pay to the attention to the pancreatic duct. Never lock the wheels, which you did the right thing. Okay. Now start gently pulling back your scope. Gently, and when it gives you a resistance, the wheel, you let the wheel go slowly. Okay. Keep coming back. Keep coming back, big wheel a little bit towards you. You see that? Yeah. Just to take a look at that. Okay? Chalte ja. Keep pulling back. Keep pulling back. This is all pancreas. Okay? It's going to fall back in just a second. Okay? Into the stomach. Good. Release the wheel a little bit more, I think.
This is pancreas?
Yeah, this is the pancreas. Yeah. No. This is a vessel. This is a mesenteric vessel. Okay? Yeah. You see that pancreatic duct right there? You fell back into the stomach. I could see that, the way it fell. Okay. Yeah. Yeah. Up to just you are on the pancreas. Just follow that all the way to the tail. That's it. That's it. Okay. Left kidney आ गया और यहाँ पे tail. चलो, good job. I think mediastinum रहने दें.
ठीक है.
हाँ जी. Because we have done plenty. I think we need to move to the next case. Yeah. Okay. Any question?
One thing only, okay, if possible, in the mediastinal, actually I have done it just to ask वो जो आप वो वाला maneuver बता रहे थे कि ये वाला hand पूरा आपका this is left atrium and left ventricle.
हाँ जी. थोड़ा सा इसको rotate करें right and left. Pull it back a little bit. Yeah. There you get left atrium. Pull it back. Pull it back. Pull it back. Now you are right at the
subcarina.
Subcarina right there. Pulmonary artery is there, which is not seeing. You are not seeing it better, but now it's better. You see that? Too much air in it. ठीक है? और यहाँ पे subcarina.
So what was that maneuver that you said? ये left hand बिल्कुल for that.
Yeah. Rotate to the left, anti-clockwise. Anti-clockwise.
जी मैं निकाल
Keep rotating.
Left side?
हाँ जी. Keep rotating until you get to the aorta. You see that? ठीक है. हाँ जी. Come back a little bit. Okay, right there. Aortic arch. Big wheel towards you a little bit. Push the scope in 1 centimeter. Rotate to the right. Rotate to the right. Rotate. There you go. The pulmonary artery, aorta, and AP vein. Okay. Chalo.
Thank you.
Sir, Sir Gyad? Sir Gyad, we are not hearing you.
Be straight, right? Now, this is IBC. Find the aorta. Yeah, this is aorta. Try to slide along the aorta down into the stomach so that you should be able to see the first take of the big vessel, which is celiac trunk. Push a little forward. This is the, you can say this is the aorta, okay. Okay. This is the celiac trunk, fine. This celiac trunk, but make it a little more prominent. Just a light jiggle right, left. Yeah. This is dividing into, and these are few small lymph nodes here.
Which are normal.
जी हाँ जी केस करंट प्रेजेंट कर दें.
So we have a 26-year-old male patient with no previously known comorbids. He presented with a complaint of pain in the epigastrium since 5 years. That was recurrent. His MRCP was done in December 2018, which showed atrophic pancreatic tail with the dilated and beaded pancreatic duct, which was filled with multiple calculi. His ERCP was attempted twice in 2019, which showed pancreatic stricture. Stenting was attempted. Later, a stent was removed and a sphincterotomy was done.
You need to push a little further. Now, it's a clear-cut case of most likely chronic recurrent pancreatitis, chronic calcific pancreatitis, where the stones were there, stricture was there. It has been managed previously. Dr. Kamran is with me. He has already done a good demonstration of various segments of liver. He has seen ligamentum venosum, he has seen ligamentum teres, and he has had a good look of porta from the E junction. Now he's looking at the aorta. Now this is aorta, and you can see that main vessel, the celiac axis coming out of the aorta. He's going to follow this celiac axis, and he's going to go forward. Go ahead. Go ahead. Gentle slide along the celiac axis, a little further. हल्का सा आगे. ठीक है. ठीक है. Just slide along. You need to go further because your target is going to the pancreas. Okay, go ahead. A little further. You're going to see two vessels. ठीक है. Now, good. Okay. If you are finding it difficult because of the hiatus hernia, go to the endoscopic view, go down into the stomach. No, that's the endoscopic view. Inflate. Yes, go further. This is the kidney. Yes, go ahead. नहीं, inflate करके just see the stomach and then try to find your landmarks again. You've seen the kidney fine, that's okay, but we want to go to the pancreas. नहीं, छोटे-छोटे movement. You're trying to make too many movements. दिखाएं? ये देखिए, ये है ना स्टमक में. आपने स्टमक को क्लियरली देखा. ओके. And there you go. Right? Go ahead. No, you need to go a little further. You're back to the big blood vessels. Go ahead. Push slightly further. ठीक है, शाबाश. Now, stop. Now, what do you see here? चलो थोड़ा सा उसको मज़ीद क्लियर करो ताकि आपको पता चले क्या चीज़ है. ठीक है, ओके फाइन. हाँ, ये किडनी आ गया ना. This is what I wanted to show you. Okay, at times you get confused. This is kidney. So if this is kidney, you need to go a little further down, because here is kidney, here is spleen, and in between the spleen and kidney you expect that there is going to be tail of pancreas. So you need to go little on this direction, right here. You are stuck at kidney. कोई बात नहीं. हाँ, स्टक हुआ ना तो उसको आगे ले जाओ, आगे जाकर फिर वापस आओ. अच्छा नहीं, अगर इफ़ योर मूवमेंट्स है ना वो छोटी, बहुत ज़्यादा मूवमेंट्स नहीं, क्योंकि ज़्यादा लंबी मूवमेंट करोगे तो उसमें यू विल गो पास दैट एरिया. You are looking at the liver. So basically you need to look towards the other direction, clockwise. हाँ, ये ठीक है, fine. Okay, ठीक है. So you are back to your familiar structures. Okay, fine. Go ahead. I suspect that you're going to land again onto the kidney. So you need to go past the kidney. देखो, now, are you able to make any structure? Yes, no. You're not able to make any structure, so that means you are lost somewhere. It's most probably retroperitoneal tissue. Now this is again kidney, what you're seeing. So it is right next to the kidney, between the stomach and the kidney. So again come back to the kidney, and once you've seen the kidney, because that is your landmark. Suction, suction, suction. Okay, fine. Now, this is beating heart, this is liver. So this is not the thing that you are interested in. You need to come to the aorta. Keep rotating, keep rotating, keep rotating. Now this is the kidney. Kidney, and then you got blood vessels. शाबाश, ये नीचे पोर्टल वेन आ गई, ये किडनी आ गया, दिस इज किडनी अगेन, this is kidney again. So once you've seen the kidney, the pancreas has to be here. ये spleen है, ये kidney है, so pancreas has to be here.
ये सर splenic vessels हैं किडनी से ऊपर.
हाँ, but then you need to make them a little more obvious for demonstration or for understanding. Because this is kidney. So you need to concentrate on this area. This is kidney, okay, and this is the area that you want to concentrate. So you need to go past that area, meaning by from lateral to the midline structures. Okay, fine. Now you can see the salt and pepper appears. Fine. Now you need to identify the pancreatic duct first. Now you have to identify the pancreatic duct. Otherwise, you can it can be just the retroperitoneal fat as well. हाँ क्या?
Is it the duct, pancreatic duct?
I don't know.
Thin one. This one.
कौन सी? कौन सी वाली? ये वाली? ये वाली?
हाँ ये वाली.
Okay, let's see. प्यार से? हाँ जी. देखें इसमें कौन सी डक कौन सी?
सबसे ऊपर जो है सर वो
एक तो इसमें स्ट्रेनिंग काफ़ी है, ठीक है. So it can be pancreatic duct. बाकी ये भी तो नजर आ रही कुछ.
इसमें सर pancreatic tail की atrophy है सर.
Pancreatic tail की atrophy, fine. So that's the reason that you're not able to find it very clear. Okay, fine. So hardly any pancreas here.
There is no pancreas. It's just the kidney.
हाँ.
And splenic vessels.
ठीक है, okay, fine. But then you can see the
ये जो है सर.
हाँ.
This one. ये neck region तो नहीं है सर.
Unless you see the portal vein, you will not be able to make out that this is the neck of the pancreas. So you need to find the portal vein, or you need to find the splenic vein first. So we have not been able to find the splenic vein yet. ये देखो ना, ये आई है. This is something. So this is, you need to make it a little more clear. हाँ.
अब आ गई सर.
नहीं अब हाँ ठीक, चलो ओके. ब्लड वेसल्स आर प्रोमिनेंट जो आर्टरीज है. हाँ ठीक है, ओके. अच्छा अब कॉन्फ्रेंस आप दिखाओ.
ये सेंट्रल कॉन्फ्रेंस नहीं याद कर सकते हो आप.
जी.
ये कॉन्फ्रेंस नहीं.
हाँ दिस इज द कॉन्फ्रेंस, ठीक है, ओके. ठीक. Once you've seen that, this is the time that you need to see the neck of the pancreas. Okay, fine. Go for the neck of the pancreas.
Now, sir, I will go a little bit counterclockwise.
Okay, fine. But then big wheel up so that everything stays close to you. Fine. देखो, remember one thing, that you have to understand the anatomical length. Fine, okay, good. हाँ, ये. This is the
Pancreatic duct.
this is the pancreatic duct, this one. Okay, and we put a flow and we find that that is the pancreatic duct. ठीक है? चलो, okay. Now once you've seen the pancreatic duct, don't let go the vision of that. Yes. Now follow this pancreatic duct down by a slight counterclockwise rotation. Big wheel up, big wheel down, and slight pull back. Okay, fine, good, 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 good. Keep going, keep going, keep going, keep going. Big wheel up and counterclockwise rotation. Counterclockwise rotation, not the clockwise one. Yeah, good. गो 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 गो, हाँ ठीक है, शाबाश। सो वंस अगेन फ्लो,
नीचे जा रही है ना सर।
हाँ ठीक है, ओके गुड।
ये जो पैंक्रियास है सर, पैंक्रियास का
हाँ जी, इस मडी the foci of hypo or hyperechoic area, then there's increased straining. So a typical picture of chronic pancreatitis is there. You're gonna ये follow. This is the pancreatic duct. This is the this is the one which is coming down.
स्टोन में थोड़े से कमी सर।
हाँ जी बिल्कुल, उसमें sludge वगैरह है। Yeah, it's not very clear, but then this is the pancreatic duct. Okay, fine. Go ahead.
आप सर मैं नेक्स्ट क्वेश्चन पे जाऊँ कि इसको
नेक्स्ट क्वेश्चन भाई हो गया, जो इसमें देखना था, जो देखना देख ली, इस पे जो चीज़ आप देख सकते हैं देख ली। So starting from midline, where you see the left lobe liver, going clockwise, first you have the IVC, then the origin of the left hepatic vein, middle hepatic vein, right hepatic vein, and then to the aorta. On the aorta, you have seen the takeoff of the celiac trunk, and from the celiac trunk, you have identified that the left kidney. नहीं, आप इसको मत, हाँ, balloon को ना लगाओ. So, you've gone to the celiac trunk, you've gone to the left kidney, you've seen the spleen, and then on to the pancreatic tail, and then a body of the pancreas. There you have identified the confluence of the portal vein, and then the fall of the pancreatic duct. That completes your station 1. नहीं, in order to go to the, ये आराम से, easy, दिखाएं, easy.
सर थोड़ा सा झल लगाएंगे ना,
कोई बात,
टंग बहुत ज़्यादा वो कर रहा है।
अच्छा देखो, इसमें जब आपने जाना है तो इम्पोर्टेंट चीज़ है, ठीक है, कोई बात नहीं,
बहुत प्रेस कर रहा है।
हाँ, अच्छा जो जेली है दैट इज बेसिकली, अच्छा देखो, आई एम होल्डिंग इट लाइक हियर, ठीक है, अब मैं इसको सामने नहीं लेके आ, बिकॉज आई नीड टू गो टू दी D1 इन अ लॉन्ग पोजिशन, ठीक है। अच्छा, इसमें पुश एंड पुल,
वो है ना सर, वो नहीं है
क्या
जो नेशनल मूवमेंट होती है ना सर ERCP में,
हाँ,
वो इधर उस लेवल से सही नहीं जा रहा आराम से।
ठीक है, कोई बात नहीं जाए तो बाज़ औक़ात आपको थोड़ा सा स्टमक को डिफ्लेट करना होता है। देखो, जो इस तरह के जो क्रॉनिक पेशेंट होते हैं उसमें थोड़ा बहुत डिफॉर्मिटीज़ होती हैं, so that is a natural thing.
आपने शुरू में बता दिया था कि कोई नीचे स्ट्रक्चर हो।
हाँ, नहीं, लेकिन उसमें स्ट्रक्चर के चांसेस इसलिए कम है कि वी हैव नॉट फाउंड एनी एक्स्ट्रा फ्लूइड इन द गैस्ट्रिक ल्यूमन. सो just because of the deformity, we are finding it a little difficult to enter into the duodenal cap, and otherwise there should not be any problem. Now we can see the portal vein and तो सर इसको कंधे को पीछे करते हैं, ये जो पकड़,
प्रोपोफॉल की ड्रिप आपकी निकल गई, बंद करें।
कोई बात नहीं, इसको ये लगा दो यार, यहाँ पे लगा दो, कोई इशू नहीं. Okay, we deflate and then go in again. Just like ASAP at times becomes difficult to enter into the duodenal cavity. नहीं press ना करें क्योंकि वो बहुत thin है. नहीं, he's too thin. No, I think we have got it. Still difficult. Now we're finding it difficult to enter into the D1. I'm trying to maneuver my way into the D1. No. Now, I've gone straight into the descending duodenum, so कोई बात नहीं, निकल गए तो कोई बात नहीं. हाँ, नहीं हो जाएगी, स्टेबल बन जाएगी, कुछ ना कुछ तो हो ही जाएगा ना. Okay. So at times, हाँ जी, नीचे आप देखो, लो. I've given you in the descending duodenum. नहीं, don't put in the, don't inflate the balloon. Or you want to inflate the balloon? Because your balloon is inflated. Yeah, or. Okay. Now over here, you need to identify the left kidney first, then inferior vena cava, and then aorta.
Right kidney, sir.
Huh?
Right one,
No, right kidney. Sorry, right kidney. So right kidney, you're going to find like this. This is IVC. Slightly on the left side, you got kidney. Here, you got the kidney. This is IVC. This is aorta, and you got the kidney right here. So basically, you're interested in the aorta, and right here on this side, this is the lumen of the duodenum, and right here on this side, you got the pancreas. No, you're lost. You're gone. Yeah, once you've seen that, now you need to concentrate on this side of the screen. Forget about the left side now. Try to bring it down under your transducer, this area under your transducer. Big wheel, let go big wheel and go a further pull back, pull back, pull back, pull back, pull back. Okay. नहीं ये तो वेसल्स आ गई ना, तो बेसिकली आप एओर्टा देखो. एओर्टा देखने के बाद यू नीड टू कंसंट्रेट ऑन दिस हाफ ऑफ योर स्क्रीन. ओके फाइन. ये तो आईवीसी आ गया ना, जो बैकी है वो आईवीसी है. हाँ, ये the smart is aorta. This is aorta. Now once the aorta is here, try to focus on this half of the screen and try to bring it under your transducer. Okay, now it's good. Try to clarify the structures underneath. Yes, good, good, good. Pull back slightly, pull back slightly. ये ब्लड वेसल है। थोड़ा सा इसको आप बिग व्हील को लेट गो करो ताकि आपको जो टिश्यू अंदर नीचे आनी शुरू हो जाए। ओके, हाँ, शाबाश, ठीक है, ओके, फाइन। देखो अनसेंट, पहले तो आप ये आइडेंटिफाई करो कि आपकी रेफरेंस पॉइंट क्या है। जब तक रेफरेंस पॉइंट नहीं आपका आएगा तब तक आप उसको अनसेनेट डिफाइन करना या उसको हेड ऑफ पैंक्रियास डिफाइन करना आपके लिए मुश्किल हो जाएगा। ठीक है, ओके, फाइन। ऑब्वियसली दिस इज ये टू एंड फ्रो मूवमेंट, सो दैट मीन्स के यू गॉट अ ब्लड वेसल। ठीक है, ओके, शाबाश। नीड सम हेल्प? ये अभी कुछ नजर नहीं आ रहा, हल्का सा राइट, हाँ ये, नाउ यू एबल टू सी समथिंग बिकॉज दिस इज द लाइन बियॉन्ड विच यू एक्सपेक्ट द पैंक्रियास टू बी देयर। ये लाइन है, ठीक है, तो इस लाइन को आप और नीचे लेके आओ। आई नो इट्स गोइंग टू बी अ लिटिल डिफिकल्ट बिकॉज ऑफ द स्टिफनेस ऑफ द duodenal cap, हाँ ये, हाँ हल्का, हाँ लेट गो, हाँ ये, बिकॉज दीज आर दी means direct blood vessel. So pancreas is all here. Try to identify the pancreatic duct. Suction, suction, shabash. This is the duodenal fall and pancreas right here. This is all pancreas. तो इसमें से आप pancreatic duct ढूंढो। शाबाश। Slight sweeping movement from 4 to 7 o'clock. 4 to 7 o'clock. नहीं, हल्की हल्की, बहुत ज़्यादा तेज़ नहीं, हल्की, gentle, very slow. हाँ, slow, slow, slow.
वो जो सामने नजर आ रही है सर, वो तो है नहीं ऊपर।
कौन सी? ये वाली?
ये नहीं सर, ऊपर।
हाँ ठीक है, वो इस तरह घूमती ही आएगी आपको। हाँ ठीक है, ट्राई डूइंग इट, ठीक है। हाँ ये आई थी, हाँ तो सा और तो इस तरह घूमती हुई आएगी टू दी ड्यूडल फॉल। यहाँ पे क्योंकि ये एम्पुला है तो इसके यहाँ पे आपकी बनेगी, ठीक है, ओके फाइन। Any question from the audience? Or they all busy? हाँ,
पूरा पेंक्रियास है ना सर?
शाबाश, अब पेंक्रियास बेहतर आ गया, ठीक है, फाइन। ठीक है, अब नीचे से आप ये पोर्टल वेन को ट्रेस करते हुए यू आर बेसिकली फॉलोइंग द पैंक्रियास। अब आप ये फॉलोइंग टू दी पॉसिबली, जी क्या? हाँ, डक्ट इसमें सही नज़र नहीं आ रही क्योंकि डक्ट प्रॉब्ली वो सारा उसमें कचरा वचरा फंसा हुआ है, ठीक है, ओके फाइन। बट बेसिकली यू लुकिंग एट द पैंक्रियास नाउ, ठीक है, और कीप कमिंग, ये बेसिकली यू आर डूइंग सर्विलेंस ऑफ पैंक्रियास। वो इतना स्टिफ है कि उसमें आपको नहीं पता चलता, ठीक है, और so you don't see any masses but you do see increased stranding, hypoechoic areas. ठीक है, अब ये कुछ नहीं है, इस सिंपल एयर, ठीक है, अच्छा। Now, do you want to see the portal vein and CVD now?
अब सर जो उस बिल्कुल एक्सट्रीम पे है।
नहीं, अब ये वैसे ही कोई आ गई है जो tissue which doesn't make any sense, meaning bilateral tissue. So उस पे कंसंट्रेट करने के फ़ायदे कोई नहीं है। At the same time, you see you are 50, so you're roughly again to the EG junction. तो आपने वो पूरा स्वीपिंग एक्शन के साथ देख लिया है, Shabash. This is liver, but you need to have a look at the, this is the portal vein, fine. And when you see the portal vein, obviously a little clockwise rotation, you're proximal to the palloic region, suction, आपने palloic vein अच्छी निकाली थी, नहीं, ख़त्म, वो क्योंकि आपकी, हाँ, yeah. Try to enter into the duodenal cap now. Although I know it's tough to get into the portal vein because of the deformity, but try to get into the portal vein again. It is difficult to enter into the D1. नहीं, स्ट्रक्चर नहीं है, because of the chronic pancreatitis you have got a deformity of the duodenal cap. The duodenal cap is deformed. You can enter into the duodenal cap from an angle, and then you go straight to the descending duodenum. Fine, okay, good, good. ये दिखा, ये क्या? Go back. Now let's see. Okay. ठीक है. Go on. No, wait, you are finding it difficult to enter. ठीक है. So basically you've done the examination from D2, you have seen the head of the pancreas in a nice fashion. The only thing that you are interested in is CVD. This is the portal vein going into the liver. This is the gallbladder. जी? नहीं, क्योंकि इस साइड पे होता है ना, जब आप when in the cap, obviously you will be going into the pancreas then. जब कैप में होंगे ना इतना clockwise पे, तो आप उसमें हो गए. चलो try again. इसमें बेटा सवाल क्या है? इसमें सवाल क्या है? यानी हमने देखना क्या है? Is it just for the demonstration purposes, or we have a question as well?
No, sir, there is no question.
शाबाश. Help? क्या हो गया? वो सर पीछे चल जाता है. Okay? There we go. जी हाँ जी, स्टेंट तो पहले ही नज़र आ रहा था ना, स्टेंट पहले ही नज़र आ रहा था, और इसी स्टेंट की वजह से ही वो आपको पैंक्रियाटिक डक्ट डायलेटेड नज़र नहीं आ रही. ओके. दूसरा तरीका ये कि
पैंक्रियाज में पड़ा हुआ है ना,
नहीं अभी भी
पड़ा हुआ है. ये किस चीज़ में है?
चलो ये लो. अब यहाँ से आप दोबारा अपना ट्रेस कर. You're in the descending duodenum now. apply your transducer right on top of the papilla.
Gyas bhai, can you
Ye-
hear us?
Yes, I can hear you.
So the management is asking to please let's wrap it up.
Okay, right. Do you want to switch to the other room?
I think they want to take a break.
Okay, right. Lunch break.
Lunch break. People are getting hungry.
Okay, get the food ready. I shall be there with you in 5 minutes.
Okay.
ये अब जो राइट फैन है सर ये यूडिनल स्वीप है ना
जी?
यूडिनल लुमन है ना राइट और वो जो ऊपर
आई नो, क्योंकि मुझे जब तक नज़र नहीं आएगा आई कैन से कि ड्यूटल से
ये नहीं वो
देखो ना, ये स्वीप है.
हाँ हाँ ये अब वो स्टैंड नजर आ रहा है ना सर
हाँ, ये आ गया. ये ब्लड वेसल है, ठीक है. कौन सा स्टैंड आप कह रहे थे? ये
नीचे सर थोड़ा सा
ये है. हाँ, दिस इज द स्टैंड. ठीक है, ओके फाइन. हाँ, ये स्टैंड, ठीक है. ओके, अब इस स्टैंड को फॉलो करें ऑल द वे टू द अदर साइड.
अगर जा रहा है आराम से, तो हमने लेनी तो लिम्फ नोड्स हैं बस. So normally we wouldn't do anything more. आप pull back कर लें, अपना वो कर लें shorten. वहाँ तो कोई है ही नहीं ना, तो खालिद वगैरह नहीं है. लेकिन खालिद और गियास वहाँ पे नहीं है, वहाँ पे कौन है? Oh God, look at this lymph nodes, yeah. Huge. So you are in D2. So pull back. हाँ, तो ये D2 है, तो अब आप अपना शॉर्टन करें जैसे आप करते हैं ERCP. Yep. Excellent, ठीक है, good. Now tip up. Oh my God. Picture ले ले एक सेकेंड यार इसकी. एक तो ये lymph node हो गया ना. So caliper we press. We get this cross sign. We measure this. That's about. ये क्यों नहीं आ रहा भाई?
ये सर इसके नीचे आता है यहाँ पे.
चलो 49 mm by 24. So this is almost a huge lymph nodes. Okay, now you keep rotating, pulling back slowly. Slowly tip up.
बाहर तो आई नहीं, मैं पहले.
नहीं वो I think वो आपको lymph nodes की वजह से this is so what.
आ जाता है, मैं बाहर आ जाता हूँ.
आप बाहर आ जाए इसमें कोई फ़ायदा नहीं होगा. हाँ नहीं आगे जाने की ज़रूरत नहीं, कोई फ़ायदा नहीं होगा. दिखाया मैं एक दफ़ा ट्राई करता हूँ, बट आई डोंट थिंक इसमें आपको कुछ मिलने वाला है. इतने lymph nodes हैं. मैं इसको शॉर्टन करता हूँ. So I'll try and see if I can get. Look at that. I mean this. Actually, they are so big that it's not just allowing. That's the pancreatic duct there, and I think that's the best I can see. Because the moment you, ये जो duct है मेरे ख्याल में जी, Doppler देना, ऊपर ले जाओ. हाँ ठीक है, that's a duct, छोड़ दो. So that's the max duct because ये जो है ना इसमें. In fact, this is the pancreatic duct. That's the CBD. छोड़ो, Doppler दो. Okay, that's the uncinate. आप देख रहे हैं दो duct हैं. एक ये duct है, एक वो duct है. Closer to the अपना वो to the probe should be the. And we can see the pancreatic duct going all the way up there. Picture लो, sorry, ले लो, ठीक है, and छोड़ दो. And if I do anti-clock, I should see the CBD coming here. It is going at the same place. You see that?
CBD कौन सी वाली?
ऊपर वाली.
ये वाली?
ऊपर वाली CBD है ये नीचे pancreas. ये देखते pancreas is going exactly where CBD. This is the ampulla. This is the duodenum. This is the uncinate. So pancreas तो इसमें कुछ नहीं. अब इसकी FNA कर दें. I think the best place to do FNA probably in his case would be stomach. The other option is to go out quickly and have a look. Mediastinal एक quick में नज़र डाल रहा हूँ, फिर मैं आपको दिखा दूँगा. So in area 7, this is not that big. है, but this is not that big, right? So yeah, we'll come back and see it, but this is not. यहाँ से लेते हैं. Ideally, we'll go to that big one in D1.
D1.
You also take this one, but this is good. Okay, Lao. F&B please. Huh? 22. Yeah. Okay, good. Let them have lunch. Is there anybody in that room or can they hear me? Kamran, can you hear me?
Yes, sir.
Well, you can't see any more, any better lymph nodes than this case really. This is full of lymph nodes and these, can you see they are dark?
Yes, sir.
And some of them are
small.
If you can see they are small but they are really dark, round. Can you see this one?
This one, yes, sir.
So
Quite
there are
dark,
multiple
yes.
lymph nodes. Look at this one here.
Yes,
So
sir.
there are multiple lymph nodes that we've seen in this patient. We've seen the pancreas. Dr. Kashif has actually done that, and we are now going to do FNA. FNA करना है? पहले मैं कर दूं फिर मैं हाँ FNB. I'll show you the largest lymph node because I'm going to try and see if I can get that.
Sir, what do you think? What is the reason for this lymphadenopathy?
Oh man, itni zyada lymphadenopathy, the first thing that comes to my mind is lymphoma.
Yes. Because pancreas probably was normal, isn't it?
Pancreas is normal to me. Pancreas is a Pakistani pancreas. Look at this lymph node here.
Yeah, it's quite a big one.
Okay, so there's one which is really big, which Dr. Kashif saw, and
the liver is also normal. No
liver abhi
no,
मैंने देखा नहीं है इतना ज़्यादा. When on our way back we'll have a look. अभी तो we were just focusing on doing certain things. Where is that big lymph node? Was it this one? What's happening? भाईजान? नहीं, is he okay? मुझे इसकी आवाज़ से फर्क नहीं पड़ता. Is he okay ना? नेक ऊपर करो यार, जो भी करो. Doppler? Okay, fine.
ये सर आपके प्रोब के नीचे भी नोड्स हैं और
जी, this is, can you see this big node?
sir.
This is round, black. This is really malignant.
Yes.
And नहीं, मैं तो सिर्फ दिखा रहा था ऐसे कि look at the lymph nodes we have. It's everywhere. ये मुझे वही लग रहा है lymphoma ही. मैं इसलिए दिखा रहा था कि इतने barn door large lymph nodes आपको. So this to me looks like lymphoma.
Okay, sir.
हाँ. वसीम. तो अपना काशिफ.
सर जरा डॉपलर लगाएं इसका.
जी डॉपलर लगा दें जी.
बायोप्सी के स्टेप में हमने बताया पहले हम इसमें शीट निकालेंगे बाहर. आपने क्या माना?
मैं वो अगर आप नई नीडल यूज कर रहे हो ना.
ठीक है.
I have it here. Khalid likes it here.
ये सर अभी मैडम कमेंट्स कर रही थी कि जो मैलिग्नेंट नोड्स होते हैं उनके पेरीनोडल वेसल्स ज़्यादा होते हैं ना, प्रोमिनेंट मोस्टली. तो
so if it's a new thing, you don't have to touch anything in Boston. It should automatically come. इस फ्लो में भी भेजना इसको because ये लिम्फोमा लग रहा है. So over to you. So now we use the needle from
सर लिम्फोमा में सेंट्रल वेसल ज़्यादा होते हैं कि पेरिफेरल?
यार good lord, you're asking the wrong person, man. I can tell you whatever, but if the histopathologist says that it's not lymphoma, then मैं क्या करूँगा?
मैंने मैडम क्या पूछा है वो है नहीं, इसलिए मैंने सर आपसे पूछने की जरूरत की.
नहीं सर, मुझे इसका आइडिया नहीं है, किसी और से पूछो. Okay, so we are in the lymph node, right?
Yes, sir.
And generally we go back one space, and I think because we are doing FNA, we are not going to go back again. FNB, sorry. So I'm now come out and going to go back into a different area. 2 passes in that area. Then I'm going to come out a little bit more, and this time try and see if I can go to my
FNB में सर आप कितने passes करते हैं usually?
Yeah, 6 is enough generally speaking, in my opinion. Khalid takes about 4 or 5, but he's very good.
Okay.
Let's see what we've got. If it doesn't come in this one, then I will. I'll use the next thing I do is use suction with it.
अच्छा.
My threshold for using suction is low because I think the results are really good.
और सर ये FNB में वैसे यूजुअली रोज की ज़रूरत होती है कि नहीं?
हैं?
FNB में रैपिड ऑन साइट एग्जामिनेशन की?
यार ज़रूरत तो नहीं होती. To be honest, I mean, if you've got good sample, then you don't really need to. But we do that. I mean, it's nice to know that we've got cells. We can also learn, so
yes, sir.
It's worthwhile. But you see, this is as now. If I don't know if we can't focus. But what you do now, if you want to measure it, I freeze the thing, right?
Yes, sir.
I press the caliper button. You get a plus sign here, right? Then you press the set button.
Yes, sir.
And you get the option to, then you're using the roller ball to move it. So we've got that measurement. Now once we've done that, we want the vertical measurement, and then you press the set button, you get the option again. Once you've done that, you press the set button and you've got both the measurements.
Oh, it's 7 into 8 millimeter.
I'm not too sure this is correct. क्या इन्होंने बढ़ाया हुआ है? साइज एक मिनट ठहरें. Now this is the smallest. Now we've zoomed out.
Yes, sir.
And so if I increase the size, then that's what this looks like. Okay. But I am surprised that this is showing this here. Is it really 7 to 8? I don't think so. वही मैं कह रहा हूँ कि ये
सर ये मिलीमीटर से तो ज़्यादा होना चाहिए.
हाँ, ये मेरे ख्याल में there is some issue here.
कैलिब्रेशन में कोई मसला लग रहा है.
There may be something because this is looking much bigger. Even when I go to the smallest, this is quite big. This is definitely not what we are seeing.
Yes, sir.
But the largest lymph node we saw in this was about 4 point something by that. But you can see there are loads of lymph nodes.
Oh, yes.
And they're all, obviously this is what tells us. And you can see the pancreas now. I don't know if you saw the pancreatic duct a little bit there. I'll show it again if you saw it going down. So we are in the neck. But the lymph nodes are making it so difficult to see anything. They are everywhere. Can you see that?
Yes, sir.
They are parapancreatic. They are in the celiac, celiac axis. They're in the they're literally everywhere. Bike sample. Is it enough? Huh? Huh? They want more. They always want more here. Now, quick. And I want suction this time.
सर आपके ये बड़े नोड के नीचे दूसरा भी नोड है?
जी, possibly there is one more.
अच्छा.
It's actually he's got so many nodes that it's unbelievable. I mean, like that's what you would expect.
उसमें सर कोई क्लासिफिकेशन नजर नहीं आ रही नीचे वाले नोड्स में सर?
नहीं, आप इतनी दूर हैं कि you cannot comment on that.
अच्छा अच्छा ठीक.
Doppler. Okay. When you can't see the needle, all you need to do is just move your shoulders to see where your needle is. Okay, so we need to check this. We are not in yet. Okay.
Thank you.
So you can see the needle going now. It's actually pushing it away. So I'm going to pull back, keep it in this direction, and now we are in. See, can you see the needle?
Yes, sir.
So the needle goes away if I move my shoulder. If you can see me, and I move my shoulder, open up my shoulder, I can see the needle. That's all you need to see when you want the needle to be in focus. Okay.
This movement should be either way, sir, or
yeah, you start with one way and then you can go to the other way.
Okay.
See, the needle's gone, needle's back. Okay, now put this. Yeah. Unlike Khalid, unlike Khalid, I actually do 1, 2, 3, 4. Now I'll close this and then I'll take 1, 2 and 3.
Almost 7.
कैलिबर में कुछ प्रॉब्लम है, क्या चक्कर है इसकी? ये कौन सा वाला है? ये हमारा है ना? इसमें क्यों प्रॉब्लम हो रही? कल कर्सर में भी प्रॉब्लम हो रही थी। इसमें पहले तो कभी नहीं हुई। उनका यूनिट है क्या? कीप योर पोजिशंस। ठीक है, अब आपने सारा पोजीशन इसको छोड़ देना है, ये हाथ फ्री करना है, ताकि अब आपने, क्योंकि ये हाथ आपका उस पर आ जाएगा।
ठीक है।
सो दिस हैज़ टू बी फ्री। नाउ दिस इज़ अ गुड पोजीशन बिकॉज नीडल इज गोइंग टू गो लाइक दिस। हाँ जी, दिखाओ। हाँ, सेल्स की ऐसी की तैसी वो है, टिश्यू या नहीं है? ये किस में डाला है तुमने? उसमें आया कुछ?
में लेना, उसमें ले लिया, उसमें स्लाइन में मैंने ले लिया।
कितना है?
थोड़ा सैंपल है, इतना अच्छा नहीं है, बाकी स्लाइड्स में मैंने।
अब इसमें आएगा, काफ़ी आना चाहिए। कहाँ है सिलाइन?
वो आगे रखी है मैंने।
हाँ,
ये रखी है, बहुत कम सैंपल है, इतना अच्छा नहीं
ये कहाँ है? इसमें तो सैंपल ही नहीं है। अबे है ही नहीं। कहाँ है भाई? नहीं 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 है ना, ना होने के बराबर है। इसको दोबारा ले लेना। चलो डालो।
चलो भाई। स्लाइड बड़ी अच्छी है
हाँ, अच्छी है। ये साफ ही नहीं नज़र आ रही। ये इसमें क्या हुआ? ये तो वही वाला बीमारी इसको हो गई जो वहाँ पे ज़ियाउद्दीन वाली। सही करो। 40 पे। कुछ हुआ है इसमें, इसको सही करो। आया? हाँ हाँ, दिखाओ। ठीक है ऐसा। ओह दैट्स नाइस।
अभी पैथोलॉजी के लिए
ले लो। आगे
ये अभी नहीं आया, ब्लड आ रहा है। अब आया, अब आया। आने दो, आने दो। कंप्लीट हो गया। एक मिनट है, उसमें आ गया बैग ले लें और पास वो सेट हो गया। स्टेपैथ के लिए भेज देते हैं।
इसी में डालना फिर ना।
स्टेपैथ नहीं करानी।
ये क्या है?
ये तो सेलिन है ना सर।
भाई तो ये नॉर्मल सेलिन में क्यों लिया?
एक तो साइटो के लिए लिया है।
हाँ, बस नॉर्मल सेलिन में ज़रूरत नहीं। इसको फॉर्मेलिन में ले लो बस। दैट्स इट। हाँ, काफ़ी सैंपल। यू वांट टू हैव अ पास? हाँ,
कर लेते हैं।
चलो एक ले। ये देना मुझे ज़रा एक दफ़ा।
काम हो गया?
क्यों, अब ख़त्म हो गया? यू वांट अस टू स्टॉप?
मैं ब्रीदिंग थोड़ी मुझे असिस्ट।
यार काशिफ, हैविंग सम इश्यूज विद द ब्रीदिंग। नो प्रॉब्लम। आप इसको ज़रा मीडियास्टिनम में आ जाएं बस। वी आर जस्ट ऑलमोस्ट डन डॉक्टर। सो कम, व्हाट आई डू इज़ आई कम टू 35।
ये 35।
ठीक है, एंड कीप द स्कोप हेयर स्ट्रेट। ठीक है,
अभी तो डिलीवरी है ये।
ठीक है ना, ये आ गया ना। अब टिप अप करें अपनी। ठीक है, और आप पुल बैक करें थोड़ा सा। ये स्कोप को ये रखें। इसका तो पूरा का पूरा सिस्टम ही। वेयर आर वी? हम थोड़ा आगे 35 पे हैं बस। 35 पे रखें। टिप अप करें और थोड़ा सा रोटेट करें। मे भी थोड़ा सा और अंदर तो नहीं जाना, थोड़ा और अंदर जाएं। हाँ, बस हेयर टिप अप बिल्कुल अपनी तरफ कर लें, बिग व्हील। और आप थोड़ा रोटेट करें अपने स्कोप को। you're actually yeah keep coming out a little bit. हाँ, there you are. ठीक है ना, अब रोटेट करना है। ये you actually got the area 7 तो ऑलमोस्ट आ ही गया था आपको। थोड़ा सा पीछे, थोड़ा सा पीछे। पुल बैक करें। that's left atrium. पुल बैक, थोड़ा सा रोटेट। दैट्स योर एरिया 7। थोड़ा सा इसको नीचे जाना। दैट्स राइट पे एओर्टा, लेफ्ट एट्रियम। यू गॉट अ लिम्फ नोड आल्सो इन द सबकराइना। ओके, ठीक है। अच्छा, अब आप पुल बैक करें स्लोली थोड़ा सा और इसको नीचे जाने दें। इसको नीचे, अब पुल बैक करें, पुल बैक करें, पुल बैक करें, पुल बैक करें। पुल बैक करें और पुल बैक करें और पुल बैक करें और बस यहाँ यहाँ अब थोड़ा सा अंदर जाए और रोटेट करें जस्ट अ लिटिल बिट। ये आ गया आपका एपी पी है, ठीक है, दैट्स इट। एपी विंडो भी आ गया, अब आप बाहर निकाल दो। थैंक यू डॉक्टर साहब।
थैंक यू जी।
दिखाओ वो सही किया। वो जो मैंने कही थी एक स्लाइड दिखाने को, जो मैंने खालिद को दिखानी थी यार, दिखाओ। हाँ No, no, उसको intubate किया हुआ है. कर दिया. उसको थोड़ी सी टाइट हो रहा था चेस्ट का तो कर दी. But he was stable otherwise. So I'm waiting. Wasim? Wasim? Eric? Beta, oh sorry, Wasim here. Okay. We have most of the people here, I think. Okay. So we had to cut down a lot of talks because I know most people are more interested in hands-on, and some of these talks are going to be given to you in, or you can ask from Dr. Sajda, and she should be able to give them. I request Professor Ghiasun Nabi Tayyab to just come and tell us about subepithelial lesions because we don't have any cases of that.
Thanks, Zat. So, just earlier today, one of the candidates was talking to what are the other indications of endoscopic ultrasound except for pancreatic lesions, except for lesions in the lymph nodes, or something that we see in the gallbladder or bile duct. So one of the indications is subepithelial lesion, and this is something which is not all that uncommon. In almost day-to-day endoscopy, if you look at the upper GI tract carefully or lower GI tract carefully, you'll find some kind of subepithelial lesion in at least 10 to 15% of the total number of cases that you do. Now, if you look at the wall of the gut, you can see that we have got 4 layers starting from this side. बाज़ इसको 7 लेयर्स कहते हैं, बाज़ 4 लेयर्स कहते हैं. तो 7 की तरह मैं अपनी चीज़ों को सिंपल रखता हूँ कि मिकोज़ा है, then we got submucosa, then proper muscle, and then serosa. In between एक extra आप कह रहे कि muscularis mucosae जो है आप कह सकते हैं वो है. And how do they look like? This is how they look like. कि मिकोज़ा की मिकोज़ा और submucosa और serosa, ये 3 लेयर्स आपको ब्राइट नजर आएंगी. मस्कुलरिस मिकोसी और मस्कुलर लेयर ये आपको डार्क नजर आएंगी, हाइपोइकोइक नजर आएंगी. सो आफ्टर एवरी ब्राइट यू हैव गॉट अ डार्क लेयर. तो ब्राइट डार्क. तो अगर आप केयरफुली इनको, इट्स जस्ट अ मैटर ऑफ ट्यूनिंग योर आईज एंड यू विल बी एबल टू मेक आउट दीज लेयर्स इन एनी गिवन पर्सन. व्हाट आई डू इज़ कि मैं जो स्क्रोल है उस पर एक पिक्चर खींच के तो अपने आईफोन से या जो भी मेरे पास फ़ोन हो उसका उसको एनहांस करके देख लेता हूँ कि अच्छा भाई एग्जैक्टली क्या लग क्या है. नाउ द होल आइडिया इज़ कि इफ़ आई फाइंड समथिंग सब एपिथेलियल, एक तो है मिकोजल लेशन. मिकोजल लेशन में मैलिग्नेंसी हो सकती है, इन्फ्लेमेशन हो सकती है. दिस गोइंग टू बी ऑब्वियस ऑन योर एंडोस्कोपिक व्यू. बट इफ़ द protuberance is there but overlying mucosa is normal, from which layer this lesion is arising हमें कुछ पता नहीं. For that obviously we need a gadget, a device which can look beyond the epithelium. तो उसमें इन layers के अंदर हमने आइडेंटिफाई करना है कि है कौन सा. तो उसमें आपका इंट्राम्यूरल को लेशन हो सकता है. दे कैन बी कंप्रेशन कमिंग फ्रॉम द आउटसाइड एंड एंडोस्कोपिक अल्ट्रासाउंड इज द वे टू गो. अब जनरली वी आर यूजिंग अ फ्रीक्वेंसी 7.5. अगर हमने नज़दीक के लेशंस को देखना है तो एट टाइम्स इट्स बेटर टू इंक्रीज द फ्रीक्वेंसी, although it's going to reduce the penetration, but with an increase in the frequency say to 12, 10
12 तक हम जा सकते हैं on the available EUS scans, तो हम 7.5 की जगह 10-12 पे जाके तो उसको ज़्यादा क्लोजली इनको असेस कर सकते हैं। तो जनरली किस लेयर में क्या ट्यूमर्स आते हैं, दिस इज़ अ वेरी कॉम्प्रिहेंसिव स्लाइड। Professor Kida from Kirsada University Hospital, he published his work on this particular thing, and it is still one of the most prestigious paper on this subject. So second layer, muscularis mucosae, उसमें से लियोमायोमा ये ग्रैनुलर सेल ट्यूमर बन सकता है। और जनरली जब इनकी प्रोजेक्शन आती है तो दिस इज़ प्रोजेक्टिंग इनसाइड टुवर्ड्स द ल्यूमेन। जो मस्कुलर लेयर है दैट इज़ गोइंग आउट, यानी अंदर की जो डार्क लेयर दिस इज़ गोइंग अवे, जो इधर की जो ब्राइट लेयर है दैट इज़ प्रोट्रूडिंग इनसाइड। सो दैट्स हाउ वी गेट टू नो द lesion is arising from the second layer. Then from the third layer, carcinoid tumor, bradyneroma, lymphangioma, lipoma, fibroma, cyst, ectopic pancreas. और फोर्थ लेयर में ग्लोमस ट्यूमर, जिस्ट, लियोमायोमा, श्योनोमा, ये हैं जनरली जो कि ट्यूमर्स इन टर्म्स ऑफ डिफरेंशियल डायग्नोसिस। अब अगली बात है कि हाउ डू दे लुक लाइक, डू दे लुक लाइक ब्राइट, डू दे लुक लाइक हाइपोइकोइक, एनेकोइक। तो जो सिस्ट है वो आएगा एनेकोइक के तौर पे, यानी उसमें कोई शेडोज नजर नहीं आएगी। जिस तरह कल डॉक्टर खालिद बता रहे थे कि ये एनेकोइक एरिया, ये हाइपोइकोइक एरिया। सो एनेकोइक इज बेसिकली टू थिंग्स, सिस्ट और लिम्फेंजियोमा। जो हाइपोइकोइक है, जितने भी सेलुलर ट्यूमर्स हैं दे विल ऑल बी हाइपोइकोइक एक्सेप्ट फॉर वन, एंड दैट इज लाइपोमा, विच इज गोइंग टू लुक वेरी ब्राइट। लाइपोमा इज ऑलवेज वेरी ब्राइट, एकदम से शाइन करता है। और हिमेंजियोमा भी बाज़ औक़ात उसी तरह नजर आते कि शाइनी ब्राइट, इसलिए फरिया उसको फर्स्ट से कह रही थी कि नहीं ये हिमेंजियोमा है। एक्टोपिक पैंक्रियास सॉल्ट एंड पेपर अपीयरेंस उसकी नजर आ रही थी। एंड देन एट टाइम्स ग्लोमस ट्यूमर, फाइब्रोमा, दैट ऑल्सो गिव्स द सिमिलर काइंड ऑफ पिक्चर। अब जिस्ट can come from layer 2 and layer 4, mostly from layer 4. This can come from layer 2, layer 4, mostly from layer 4. Ectopic pancreas, mostly from 2, rarely from 3 and 4. Lipoma, generally from layer 3. Carcinoid, layer 2 or 3. Cyst, generally from layer 3. तो ये इसका स्टैंडर्ड है। और इसके आगे उनकी अपीयरेंस कैसी होगी, हाइपोइकोइक, हाइपरइकोइक या माइल्ड हाइपोइकोइक विथ होमोजेनस जैसे कार्सिनोइड है, और सिस्ट एनेकोइक। इसमें जिस्ट इज समथिंग जब देखें तो उसको इमीडिएटली पिक करते कि यार दिस अपीयर्स टू बी जिस्ट, जिसका क्लोज डिफरेंशियल डायग्नोसिस किससे, फ्रॉम लियोमायोमा एंड नंबर 2 श्योनोमा। तो ये तीन लेशंस हैं जो कि हाइपोइकोइक हैं और उनकी जो अपीयरेंस है एंडोस्कोपिक अल्ट्रासाउंड पे मिलती जुलती है। But out of these three, which is the commonest one? It is GIST. Although leiomyoma can also, leiomyoma is not all that uncommon. जिसकी ये कि जो आउटर जो बाउंड्री है थोड़ा सा बिजार सी होगी, थोड़ा सा मुख्तलिफ डायरेक्शंस में उसकी कोई चोंचें वोंचें निकली होंगी। लियोमायोमा जब ग्रो करता है तो लियोमायोमा grows with a very good, well encapsulated lesion. So that's how you can differentiate between leiomyoma and the GIST tumor. Schwannoma, much more uncommon. खालिद साहब उसको शायद पहचान लेते हों, मैं तो अभी तक उसको नहीं पहचान पाता कि schwannoma को किस तरह उसको differentiate करना from the leiomyoma and the GIST tumor. तो EUS जब भी हम देख रहे थे उसमें और भी कुछ चीज़ें देखने वाली होती हैं। इन एडिशन टू द लेयर ऑफ ओरिजिन, ऑब्वियसली कि साइज़ क्या है। जब साइज़ 5 सेंटीमीटर से इंक्रीज़ कर जाए तो बहुत ज़्यादा आप लेयर्स को डिफ्रेंशिएट करने में कामयाब नहीं होते, बल्कि जितना साइज़ ज़्यादा होगा उतना आपके लेयर्स की डिफ्रेंशिएशन मुश्किल होती जाती है। एंड टू बी ऑनेस्ट, इन रियल प्रैक्टिकल लाइफ इट बिकम्स इररेलेवेंट एज वेल। नंबर 3 इको टेक्सचर, जो पहले कि एनेकोइक, हाइपरइकोइक, हाइपोइकोइक, और इनमें से होमोजेनस कौन सा है, नॉन होमोजेनस कौन सा है। उसके बाद बॉर्डर्स क्या हैं, वेल डिफाइंड बॉर्डर्स हैं, इल डिफाइंड बॉर्डर्स हैं। इल डिफाइंड बॉर्डर्स है तो उसका मतलब है कि समथिंग विच इज़ ए टेंडेंसी टू गो इन टू malignant side. So with poorly defined borders, उसके chances. Internal structure अगर internal necrosis है तो उसका मतलब है कि कोई ऐसा lesion है जिसकी vascularity है, and because of the increasing size the vascularity is not matching with the tissue viability, as a result the center is getting necrosed. या कोई अंदर ऐसी duplication cyst है, या कोई इस तरह की कोई pathology कि जिसमें cells have started to secrete something. So in addition to the solid component, you have started to have cystic component as well. The solid cystic component is combination में. Then vascularity. There are certain tumors which are very vascular. Gist is very vascular. Leiomyoma is not all that vascular. Schwannoma borderline दरमियान में आ जाता है. And then lymphadenopathy के साथ associated lymph nodes हैं कि नहीं. और अगर हैं lymph nodes तो किस तरह के lymph nodes हैं? Are they benign looking lymph nodes or they are rounded lymph nodes which are bigger than 1 centimeter with peripheral enhancement and no blood vessels going towards the center. तो ये चंद चीज़ें जो कि देखने वाले, तो ये 7 parameters जो कि देखने वाले. Now coming down to the things one by one. जिसका क्या होता है, ये जिसकी जो है स्टैंडर्ड पिक्चर है कि एक अम्बिलिकेटेड है. मोस्टली किस तरह प्रेजेंट करते हैं? जस्ट रूटीन GI में, generally with GI bleed, but when they're small one can pick them on routine endoscopy, and routine endoscopy being done for any other reason. So ये दो presentation. तीसरा कभी कभी radiologist हमारी तरफ भिजवाते हैं कि there's something there in the stomach, so you better do the endoscopy. तो ये 3 presentations हैं. How do they look like on endoscopic ultrasound? तो this is the general picture जो कि endoscopic ultrasound पे इनकी आती. तो variable echogenicity, contour and size. Once they cross 5 centimeter in this size, the chances of malignancy they get higher. लेकिन diagnosis की basis क्या है? Diagnosis की basis biopsy है. अब biopsy कैसे, सब epithelial lesion की biopsy कैसी होगी? एक तो है कि ऊपर से mucosa हम काटें, mucosa काट के तो फिर directly biopsy लें. But this is possible when the tumor is already ulcerated and it is bulging inside the lumen. Otherwise, the best bet is to push a needle within the center of that lesion and take out the biopsy. FNB कर लें, FNA कर लें, generally with a size bigger than 3 centimeter. FNAC, FNB, they are working equally fine. They present with the bleeding, abdominal mass and abdominal pain. Or 10 to 30% of the patients who are suffering from GIST, they are suffering from malignant GIST and not the benign GIST. इस पे हिस्टोपैथोलॉजी पे क्या नजर आते हैं? टिपिकल स्पिंडल सेल्स. आज भी एक केस में स्पिंडल सेल्स जो आई थिंक खालिद साहब कह रहे थे, या एक केस में स्पिंडल सेल्स थे, क्योंकि मैं उसमें हिस्टोपैथोलॉजी पे देख रहा था किसी एक में, ये शायद कल था स्पिंडल सेल्स का. तो मैलिग्नेंट जिसके क्या फीचर्स हैं? मतलब कि देखने से EUS को पे देखते साथ ही आप कहते हैं कि नहीं, दिस लुक्स लाइक टू बी मैलिग्नेंट. नंबर 1, इट इज़ गोइंग टू बी लार्ज. Number 2, the borders are going to be ill-defined. Number 3, the echo pattern is going to be variable. तो ये 3 चीज़ें हैं जिसके बेसिस पे आप कहते हैं कि most likely this is a malignant GIST and this is not a benign GIST. और ये इसके cells हैं जो कि आपको एक दफ़ा आप देख लें तो कभी आप बोलते नहीं. Every time you are going to see them, differential diagnosis between again 3 things: schwannoma, leiomyoma and GIST. उसके बाद वो फर्दर उसका कर जो उनके मार्कर स्टडीज उस पर किया जाता है. एक्टोपिक पैंक्रियास, यूजली एक्टोपिक पैंक्रियास राइजेस फ्रॉम लेयर 2, कभी कभी लेयर 3, लेयर 4 से भी. किस तरह का होता है? एग्जैक्टली सेम hypoechoic salt and pepper appearance, but the difference is that it is rising from within the walls of these figures. Mostly they are 1 to 2 millimeter lesions. कभी कभी they are large and they can give us a diagnostic challenge, but most of the time one can see them and ignore them without even going further. Although having said that, number of times the granular cell tumor and other similar tumors have been found, carcinoid have been found in these people. तो endoscopy पे central umbilicus होता है इस तरह का. I'm sure you must have seen many of these lesions and you recognize them very well. देखिए आप कह देते हैं कि this is ectopic pancreas, no need to proceed further. तो इसकी आगे वैसे तो काफ़ी डिटेल्स हैं कि उसमें, लेकिन there is no point in going into the details like this. और किस तरह ये नज़र आते हैं उस पर इंडोस्कोपी पे, इस पे EUS पे, तो वही जो पैंक्रियास की इतनी दफ़ा आपने इमेज देख ली है पिछले 2 दिन में कि आई एम श्योर यू विल नॉट बी एबल टू फॉरगेट दैट. Lipoma, something which if you have seen lipoma once, you'll never miss it, and you can easily tell on the endoscopic ultrasound that this is lipoma, hyperechoic homogeneous lesion with regular border, and that's how it looks. एक दफ़ा आपने इसको देख लिया तो कभी आप इसको मिस नहीं करेंगे, और इसकी इतनी क्लियर कट पिक्चर होती है. And similar kind of pictures there in the pancreas. This similar kind of picture is there if the lipoma is present at any other place too. तो अगर यहाँ पे हम देखें कि अब लेयर्स को कैसे ट्रेस करना है, दिस इज अ मैग्नीफाइड इमेज. तो आप स्टार्ट पे देखिए कि पहली हाइपरइकोइक मिकोजा, नंबर 2 हाइपोइकोइक मस्कुलस मिकोजा, नंबर 3 हाइपरइकोइक सबमिकोजा, और उसके बाद ये ट्यूमर है एंड द मस्कुलर लेयर इज गोइंग अराउंड दिस लेशन एंड देन यू हैव गॉट द सेरोसल लेयर. ठीक है. लियोमायोमा, नेक्स्ट relatively common thing. किस तरह नजर आएगा? Well encapsulated rounded hypoechoic lesion. डिपेंड करता है किस लेयर से उठ रहा है, मस्कुलर मिकोजा से उठ रहा है या मस्कुलर लेयर से उठ रहा है, मीनिंग बाय लेयर 2 and 4. ये 2 लेयर्स हैं जहाँ से आमतौर पर लियोमायोमा उठता है. शवनोमा किस तरह पता चलता है? हैज़ अ लो malignant potential, but then it's of importance क्योंकि इसका डिफरेंशियल डायग्नोसिस है. एंड अनदर थिंग, अगर आपके पास एलास्ट्रोग्राफी की फैसिलिटी तो उसमें मोस्टली ब्लू इज़ बैड, लेकिन दिस इज वन ऑफ द फाइब्रोटिक ट्यूमर्स, सो जनरली इट गिव्स अ ब्लू पिक्चर. अनफॉर्चुनेटली यहाँ पे अगर ये लाइट हम बंद कर सकें तो दिस इज़ गोइंग टू कम आउट लिटिल बेटर. Still not good. Well, this is a hypoechoic rounded lesion, और जब आप FNAC करते हैं तो ये उसकी पिक्चर होती है, उसके इम्यूनोहिस्टोकेमिस्ट्री पे ये आपकी पिक्चर आएगी. नहीं, कोई इतना मज़े का नहीं आएगा. तो न्यूरोएंडोक्राइन ट्यूमर्स, दैट्स हाउ दे लुक. जनरली ये उसकी एंडोस्कोपिक पिक्चर होती है. किस लेयर से उठ रहे हैं कोई बताएगा? ये एक की ये मिकोजल लेयर आ गई, उसके बाद एक डार्क लेयर है, एंड देन इट इज मिक्स एक्सोजेनिसिटी लेशन ओवर हियर. तो कौन सी लेयर बनी? लेयर 3. तो relatively bright but then well encapsulated lesion, mostly neuroendocrine tumor. Gastronoma अब थोड़ा सा ये relatively uncommon है. Picture not very different from ectopic pancreas, लेकिन that's how they look, and this look is also not too different from ectopic pancreas, except कि इसमें उतनी fine solid pepper appearance नहीं, बल्कि इसमें थोड़ा सा coarse white fibers आते हैं, जिसकी वजह से one is able to differentiate कि नहीं यार ये typical classical ectopic pancreas नहीं है. Glomus tumor is next. That's how it looks. Mostly इसको biopsy आप वैसे भी करने की कोशिश कर सकते हैं, but then the way to go is obviously final aspiration, or diagnosis is not on the histopathology, rather it is on the immunohistochemistry. Lymphangioma, very rare benign tumor. किस तरह पता चलता है? That's how it appears. Hematomas, हर तरह के उसमें आपको reflections मिल रही होती हैं, and that's how it appears. Granular cell tumor, this is how it looks. Sorry, फिर वही बात है कि इसमें वो इतना अच्छा नहीं आ रहा, लेकिन on this screen it is looking good. Or diagnosis again on immunohistochemistry, not simple histopathology. So I thank you for your patient listening. Any question, you're more than welcome.
One thing about GIST and leiomyoma, if you see that in the esophagus, 90% chances are it's going to be leiomyoma, 10% chances it will be a GIST. It completely flips. If you see that in the stomach, 90% chances it's going to be GIST, 10% chances leiomyoma.
Location.
Location.
I always question the significance of looking and the characteristics are there, but I think they were far more important when the EUS was basically a diagnostic procedure, wasn't it? Now that you're actually started puncturing more than often, because I mean, unless you decide on the basis of that you will or you will not do an FNA or biopsy, then it makes a lot of difference. But otherwise, does it really make a difference nowadays as much as it used to do before? When you see a subepithelial lesion, are you confident enough not to generally? I'm not talking
जो
about
तो lymphoma है, वो तो आपको देख के साथ ही पता चल जाता है.
I'm talking about hypoechoic lesion
hypoechoic.
arising from the third, second, fourth layer.
Second or third or fourth layer में अगर rise करें तो then I agree, Khalid will be able to tell better. For me, any lesion bigger than 3 centimeter, I'm definitely going to biopsy. A lesion smaller than 3 centimeter, I shall look at the cost effectiveness. या इसको मैं biopsy करूँ या ना करूँ, और इसके बाकी characteristics क्या हैं? क्या ख्याल है Khalid? आप क्या?
It's debatable. Okay, so both ways is right. When the lesion is 2 centimeter or less, and if you don't see any those what we call those cavities in there, like in necrotic areas, it's not irregular, it's very smooth, and boundaries, and 2 centimeter or less, we generally tend not to do FNA. Just observation and bring them back in a year, 2 years, take another look. If the lesion is more than 2 centimeter, up 3 kind of what we do 2, or any features which are suggestive of aggression. So these are the patients you can debate about that. Should I prove it to a FNA for surgeon to take it out and confirm before they do a surgery? And our other is it going to really make a difference? It looks larger in size, and in that case, some surgeons they say at least 3 centimeter or more for to do surgery. So larger in size, and surgeon is going to take it out anyway. Does that FNA make a difference or not? It's debatable. If it's more than 2 centimeter, we tend to do a FNA afterwards. Less than 2 centimeter, no worrisome features, observation. Between 2 and 3 centimeter, do a FNA, see what the mitotic activity is on that. More than 3 centimeter, doesn't make a difference, they need to come out and just do surgery.
इसमें एक चीज़ ये है कि जिस्ट है या leiomyoma, तो practically we do is कि जब हम देखते हैं, usually they present with upper GAP, हम जाते हैं globular mass.
It depends. No, it depends on the geography. आपके पास कोई regular वो इतने ज़्यादा endoscopy नहीं होती, just like just for the heartburn, not everybody is getting. हमारी जो जिस practice में मैं हूँ, there's so many EGD, so many endoscopy done, and we see these lumps and bumps all the time. So that doesn't apply. In your case, majority of these patients with the GIST coming with a bleeding, it's going to be 3, 4, 5 centimeter. So it's a different population.
उसमें do you recommend should we go with FNA because surgeon is sitting here, they don't like it. They कहते हैं कि जब resection तो करनी है.
Then 3 centimeter or more, and especially if they're bleeding, there's no
Life is easy if they're bleeding.
So if the bleeding becomes easy, need to come out. FNA or no FNA is not going to make a difference.
Incidental finding, then less than
Then
2 centimeter, you
no,
have to
less than 2 centimeter you can observe. Between 2 and 3 centimeter, no high-risk features, I tend to do FME of that. Just to get an idea what's the mitotic activity is, how aggressive that looks like, gives you an idea, and like how it's going to grow over a certain period of time. More than 3 centimeter, if bleeding, I may not do it. And actually, sometimes you make them bleed even more by doing FME because they're very vascular. More 3 centimeter or more, I'll just ask the surgeon, do you want to just take it out? And I don't need to do it.
What about endoscopic?
Ready?
Endoscopic.
We take the questions as they go.
Just last question.
Yeah,
what is the question?
Endoscopic management of small lesions.
Endoscopic management, what do you mean?
I mean like ESG.
मतलब उसका मतलब कि अगर layer 2 तक है तो can we do the submucosal dissection or just the
no, he's talking about stir procedure, submucosal tunneling and resection. That's what.
No, I'm talking about endoscopic submucosal dissection.
That's it's submucosal dissection. It's more like a submucosal tunneling and resection. You can do a dissection. It goes all the way. It just goes to the muscular areas. It's submucosal. You're not cutting the muscle with that. That's up to a dissection. When you go below the dissection, it really becomes a resection. We call it a tunneling stir, submucosal tunneling and resection. For gist, that's what you need really, because the gist is coming off the muscles. So it's not really AESD.
This is not an ESD.
So these are two different terms. So you are talking about here about the stir, not an ESD. ESD.
The patients are intubated. Sorry.
Huh?
So we got one more case.
उसके बाद
Yeah. 30 minute deadline.
सबके 3 हो जाएंगे आज, right?
टोटल
आज के 2, कल का 1, 3 हो जाएंगे सबके आज
के सबका 3 हो गए?
नहीं 2 बस अभी
क्या चीज?
नहीं टोटल 3 तो सर हमने अपने टारगेट कंप्लीट कर दिया। मैं इसीलिए आपको बोनस मिलेगा।
Can you hear me? No, beta. हाँ हाँ जी, क्या देख रहे हैं आप? हाँ जी, अस्सलाम वालेकुम, कैन यू हियर मी? ओके, आई एम विद डॉक्टर अब्दुल्ला. हाँ जी, अस्सलाम वालेकुम.
जी वालेकुम सलाम, वी कैन हियर यू.
खाल साहब, मैं देख रहा हूँ कि आप कुछ बोलने की कोशिश कर रहे हैं लेकिन आपकी आवाज़ नहीं आई.
नहीं नहीं, मैं बोल रहा हूँ, आवाज़ भी आ रही है. कैन यू हियर मी?
हाँ जी, दिस इज लिवर, ठीक है, फाइन.
और आपको आवाज़ आ रही है?
नहीं, आप नहीं, सबसे पहले आपका हार्ट कहाँ पे? हार्ट कहाँ पे? हार्ट, दिल, ये. ओके, राइट. सो यू आर लिटिल फर्दर डाउन. अगर थोड़ा सा वापस आएंगे, थोड़ा सा वापस आइए, क्योंकि लिवर को आपने देखना है कि आपका आईवीसी कहाँ पे. हेलो, आपकी आईवीसी कहाँ पे? थोड़ा सा वापस है. अब लिवर को ये आपकी देखे ना.
कैन यू हियर अस नाउ?
Yes, I can hear you very well. Thank you very much. Okay, now this is the liver. Now in this liver, can you identify which is the left hepatic vein, which is the middle hepatic vein, where is the umbilical portion of the ears? Fine.
These are the hepatic veins.
हाँ जी, these are the hepatic veins. Fine. Okay, ये umbilical portion of left portal vein है, ठीक है. And here's the segment 2, segment 3. This is the diaphragm, right? This is the diaphragm. ये कुछ चीज़ आपकी आई थी. What is this? This is obviously this is one of the hepatic veins जो कि इधर से आ रही. जो ये umbilical portion, ये तो portal vein तो ये हो गई ना. तो this has to be hepatic vein, ठीक है. थोड़ा सा इसको घुमाइए ताकि देखें कि और क्या चीज़ है आपको. हाँ, ये मिडल हेपेटिक वेन थी, ठीक है. और घुमाएं, और घुमाएं. यहाँ पे आपके राइट आ जाएगी और साथ ही आपके इन्फीरियर वेना के आ जाएगा. थोड़ा सा आगे पुश कर दें आप, हल्का सा जेंटली. तो ये दिस बिकम्स योर एग्जामिनेशन ऑफ द लिवर. यहाँ पे आपको पोर्टा इस साइड पे आपको आना चाहिए. सो पोर्टा भी आप थोड़ा सा देख लें. यहाँ पे हल्का सा दाएँ बाएँ टर्न करें. You will be able to big wheel up and slide push further. हाँ, घुमाएं clockwise. हाँ, ये आगे चलें और आगे चलें और आगे चलें. थोड़ा सा आगे पुश कर, क्योंकि ये जगह जो है और आगे जाए. हाँ, ठीक, शाबाश, ठीक. अच्छा, अब यहाँ तो मज़ीद इस साइड पे आएंगे तो यू विल बी एबल टू सी द inferior vena cava. Inferior vena cava with 3 veins entering into the inferior vena cava. Slight pull back. हाँ जी, ठीक है. और पुल और रोटेशन इस साइड पे लाइक दिस. हाँ, ये देखिए, दिस इज द पोर्टा वेन, दिस इज द पोर्टा वेन, ठीक है. और यहीं पे इसके साथ ही आपको सीवीडी मिलेगी. ओके, और इस साइड पे, और इस साइड पे ये आ गई आपकी बैगी. दिस इज द लिगामेंटम वेनोसम एंड आईवीसी, ठीक है. दिस इज आईवीसी. Now these are the midline structures. Now if you are going to turn further clockwise, you are going to go to the other midline structure, that is abdominal aorta, and here is the abdominal aorta, right? तो अब abdominal aorta को अपने ट्रांसड्यूसर के नीचे लेके आए, ठीक है. टर्न, ठीक है. थोड़ा सा और. हाँ, ये now you seen the abdominal aorta. Okay, fine, no problem. दोबारा आ जाएगी, कोई बात नहीं, no big issue. हल्का से वापस जाएं. ये आ गई abdominal aorta. अब हल्का सा देखो, ये this is the abdominal aorta. अब once you seen the abdominal aorta, keep it under your transducer and gently slide along the abdominal aorta into the, और हल्की सी रोटेशन के साथ ये ऐसे ना देखते हुए ये जो ना ये ऐसे हल्की, so that everything should be under your vision, and the first blood vessel which is going to come out of the abdominal aorta is celiac trunk. Now once the celiac trunk is there, you need to follow the celiac trunk. This is mesenteric, this is the celiac artery. Now you need to follow the celiac. Okay, big wheel slightly away from you and slide gently along the celiac artery. शाबाश. Slide further forward. हाँ, you will be onto the pancreas. ठीक है. हाँ, तो हल्का सा, ठीक है, because this is the target where you want to go. Okay, go further. ये किडनी है, this is kidney. ठीक है. देखिए ना, this is lateral. हाँ, कोई बात नहीं. ये देखिए ना, ये जगह आपको नजर आ रही है कि salt pepper paste ये यहाँ पे है. This is the place where you want to go. Okay, fine. थोड़ा सा आगे. हाँ, नहीं, सक्शन. हाँ, if you're lost, come back and start all over again. ये किडनी है, obviously किडनी से हल्का सा big wheel slightly away from you, and keep keep the suction. हाँ, शाबाश. Suction, ये जितनी भी air suck out, हाँ ये. Now you're able to see the structures underneath. Okay, now you see. तो इसको और नहीं, ये देखो ना, आप लेवल फिर अब आपकी you start to see few other things. This is not where you want to go. आपकी जो जगह है ना, देखो आप कहाँ पे थे? Clockwise थे. If you gone so much counterclockwise, obviously you'll start looking the things on the right. So basically you want to see the things on the posterior aspect of the liver of the stomach. So you have to stay clockwise or to the midline. तो इस जगह पे आपका ये चीज़ें आएंगी. ठीक है, तो स्लाइड फर्दर पुश बिकॉज द ब्लड वेसल्स आर ऑन दी retroperitoneal टिश्यू. ठीक है, थोड़ा सा आगे जाएं. हाँ, ये थोड़ा सा और आगे. ओके, गुड. ठीक, यहाँ पे कुछ ये जो शेडोइंग है क्या हो सकती है? ये वाली ये हाँ, एयर आर्टिफैक्ट्स हैं. कहाँ पे एयर हो सकती है? क्या ख्याल है? if this is your lumen, जिस पे चीज़ें मूव भी कर रही हैं
सर, उसमें गट के अंदर.
हाँ, गट. तो obviously this is some kind of gut. So this is not the thing that you want to see. ठीक है, तो you need to come back again, identify something which is identifiable. ठीक है, sharp. Now, good. That makes sense. ठीक है, ये आ गया. अब this all. हाँ, this is a mass. Yeah, बिल्कुल जी. Some kind of mass formation. तो इसको ज़्यादा clear करें. हाँ, ये now let's see what is right there in the center. Now, नहीं, वो जो center में था उसको देखिए. ये क्या है? Let's try to find out. नहीं, जिस चीज़ को आपने center में रखा है उसके आगे जाएं, जहाँ पहले वो डक्ट आई थी, इस साइड में. हल्का सा लाइक दिस. नहीं, वो चीज़ फिर मिस हो गई. ठीक है, ओके, फाइन. आओ
जी सर.
Now, what have I done? Just fine movement, nothing more than that. ठीक है, इसके अंदर अब now I can see that there is a clear cut fall of the. This is the नहीं, मैस नहीं है. देखो ना, ये pancreatic duct आपको अच्छी खासी नजर आ रही है. This is the pancreatic duct. ठीक है. This is the pancreatic duct. ये ठीक है, this is the pancreatic duct. अब इसको pancreatic duct को मैंने follow करना है to the right. What I'm going to do is that big wheel up, slight pull back, गायब, okay, I go back.
मास सर, ये मास नहीं है यहाँ पे जो पैंक्रियाटिक बॉडी में जो लग रहा था?
पहले हमारा भी इम्प्रेशन था कि है, लेकिन बीच में पैंक्रेटिक डक्ट फर्स्ट क्लास नजर आ रही, तो इट्स जस्ट द अपीयरेंस.
अच्छा, ठीक.
There. ये गट है. चलो लेट्स टेक अ व्यू फ्रॉम दिस, वहाँ से देख लेते हैं.
नॉर्मल पैंक्रियाटिक जो पेरेंट का है ना, जरा एब्नॉर्मल सेल है.
हाँ, एब्नॉर्मल है. दिस इज एब्नॉर्मल. दिस डेफिनेटली एब्नॉर्मल.
नॉर्मल में आ ही जाता है, मतलब कुछ ना कुछ करके मैं तो थोड़ा बहुत.
कोई बात नहीं, वो देखो चीज़ एक ही तो बात है कि दैट इज समथिंग which called this is something abnormal, definitely abnormal. Okay, so possibly यही हम देख रहे थे वहाँ से. Okay,
this is the pancreatic head.
This is in the pancreatic head, बिल्कुल. लेकिन जब तक आप ये पोर्टल वेन ना देख लो, तब तक आपको ये नहीं होता कि अच्छा भी मैं हूँ कहाँ पे. Once you see the portal vein, then you know yes, I'm at this position. तो उसके बाद फिर going this way, you are able to make out different things. ठीक है? लो ना. ये portal vein. लो ना. इसको संभालो. So there is a mass lesion over here. हाँ, ये देखो ना. अब ये क्या है?
ये कॉमन बाइल डक्ट टाइप है.
शाबाश. वापस लेके आए कॉमन बाइल डक्ट. वापस लेके आए. नहीं, कॉमन बाइल डक्ट जो आगे गई है, ऑब्वियसली ये आएगी ऐसे. लेट गो, लेट गो, लेट गो, लेट गो, लेट गो, लेट गो.
ये लिम्फ नोड है बड़ा.
आई नो. ये ठीक है. लेट गो, लेट गो, लेट गो, लेट इट कम अंडर योर ट्रांसफर, बिकॉज दिस इज समथिंग विच इज ऑफ आवर इंटरेस्ट. ठीक है. स्लो ग्रेजुअल. नहीं, आप बहुत टेंस हुए. ये ठीक है. अच्छा, दिस इज कॉमन बाइल डक्ट. अब कॉमन बाइल डक्ट आपकी आ गई है. नाउ यू नीड टू फॉलो द कॉमन बाइल डक्ट अप, यू नीड टू फॉलो द कॉमन बाइल डक्ट डाउन. यू आर नॉट इंटरेस्टेड इन द ब्लड वेसल, क्योंकि
There is a case over here with gallbladder carcinoma. I want to show the audience that image. Can we shift?
हाँ, ये प्लीज. अच्छा,
ये कॉमन बाइल.
ये कॉमन बाइल. अब कॉमन बाइल डक्ट आ गई है, तो यू नीड टू फॉलो द कॉमन बाइल डक्ट टू द राइट. नहीं, देखो इसको ना ट्रांसड्यूसर के अंदर एंड फॉलो इट ऑल द वे डाउन to the pancreas. This is the pancreatic head. And then follow it back all the way up to the liver. ठीक है? That's how you do it.
उसमें मूवमेंट ये वाली करनी है आप.
हल्की सी इस साइड पे by keeping, हाँ ठीक है. Suction, 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 suction. To clockwise, big wheel up. देखो आपकी CVD गायब हो गई ना. हाँ ये. तो CVD should be clearly visible to you. हाँ. Make it visible to you. हाँ ये देखो अब ना. Beautiful.
It's entering into the ampulla.
It's entering into the ampulla. Now this is the ampulla and you can see some movement of the fluid as well. ठीक है. Suction, 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 suction. Air नहीं आनी चाहिए. ये air आ गई. हाँ किधर गई CVD? गायब नहीं होने. हाँ ये आ गई. ठीक है. Now you can clearly see that now. To go to the hilum of the liver, counterclockwise and big wheel away from you. And slight push. हाँ ये big wheel away from you like this with the movement of your shoulder. हाँ further बहुत ज़्यादा up. हाँ ये that's how you do it. Good, शाबाश. तो सब the whole thing. हाँ ये that's very good. Good. ठीक है, okay, fine. जी
एयर आर्टिफैक्ट्स
ये तो सक आउट दिया. अच्छा उसके बाद कि यू आर इन द स्टमक तो उसकी वजह से भी है, तो यू नीड टू गो लिटिल फर्दर डाउन. हाँ ठीक है, गो अ बिट फर्दर डाउन इनटू द ड्यूडेनल कैप. हाँ ये नहीं आप देखो मकसद है कि आपको स्ट्रक्चर आ गया नीचे. अब इसको स्ट्रक्चर को आपने फॉलो करना है टुवर्ड्स द हाइलम ऑफ द लिवर, जहाँ पे आप उसकी बाइफरकेशन देखिए पैंक्रियाटिक तक देखिए. तो गो लाइक दिस.
वो अभी तो दूसरे कमरे में ना, वो आ रहे हैं यहाँ पे या नहीं? हाँ अच्छा, जब शिफ्ट होंगे तो फिर हम तब.
Then I'm going to push
ये इनको दिखा के ना फिर हम अगर उन्हें FNA करना है.
This is
I don't know if that's going to make a difference or not. Looks like a cancer with a pulmonary mass.
like this. Now I'm bringing it under my
Age
translucent
कितनी है
like
इनकी?
this. और हल्का सा यहाँ पे.
मेरा निकाल के इनको कीमो मिलेगी या
ठीक है,
रेडिएशन?
this is the
तो
hilum of the liver.
okay.
This is the hilum of the liver. यहाँ तक मैं इसको CVD को ट्रेस करता हूँ पॉइंट.
क्योंकि gallbladder biopsy slight very tiny risk of bile leak usually is
Pancreatic duct की वो mass है तो इसलिए pancreatic duct
लेकिन
वहाँ
but
पे
there
इतनी
is
कोई visible नहीं है.
risk of bile leak.
अच्छा अब हम चले नीचे चले डिस्टल ड्यूडेनम में. चलो डिस्टल ड्यूडेनम में चले. अब it has to be under vision. कर लें, लेकिन ये कि अपनी आदत डालें. ये लो मैं कहता हूँ
लेते हैं क्या चाहते हैं वो, अगर उन्होंने कहा.
चलो
Saad bhai, can you hear me?
Yes, Khalid, we can see you and hear you.
Okay, let me just fix this. ये लगा. I think we'll go ahead and present the case.
Okay.
Okay, and then I just want to show you something, and you can go back after a few minutes.
You to, if possible, if it's a good case, then go to D1 and duodenal bulb, and just show us the structures here, because we were just discussing that, if possible.
No, I didn't hear you.
I said, Khalid, if the duodenal bulb is good in this patient,
okay,
then if you go to the D1 and just demonstrate what you do to get the CBD down to the duodenal fall off and then going back all the way.
Yeah, I can check on that. I didn't even go into the duodenal bulb yet. But
okay.
I want to show something. I'll quickly present the case, and then I want to show you something
okay.
to the audience.
Okay.
This is a 75-year-old female patient, previously known case of hypertension, who presented with complaint of abdominal pain, jaundice, and weight loss since 1 month. Her status is post-ERCP stenting. Her CT showed indefined circumferential thickening of the gallbladder, along with pulmonary methods.
Okay, so this is a 75 years old woman, and she had thickening of the gallbladder wall and also has some pulmonary lesion concerning for the mets. So the way you look at the gallbladder, because she has some not a best candidate for anesthesia either, so we went straight to the gallbladder. The way you take a look at the gallbladder, you go into the antrum and look for your lesser curvature. Okay? After you look at the lesser curvature, you try to put your transducer on that or suction on the wall towards you. Here, we went straight onto these structures. Do you see that? Nicely?
Yes, clearly.
Okay. So one thing I want to ask the candidates, do you see anything usual, unusual? Let's suppose this is the gallbladder right here. What do you see? What strikes you here? Anybody?
Dr. Khalid, it seems to be that the black area seems to be the lumen.
I can't hear you. I can't hear
the
you.
Lumen of the gallbladder seems to be very small.
Very small, right?
So, yeah.
And you see the like thickness. There is like a tissue. There is a mass.
Yeah.
Okay, that strikes you, but something else even more striking. Can you point to that? Anybody?
Walls. Look, walls. The walls of the gallbladder, is it calcified or some these walls?
So what does that indicate?
Seems to be a chronic inflammation along with some malignancy.
Okay. And what is this called?
खालिद भाई पोर्सलाइन गॉल ब्लैडर है ये डिस्ट्रक्टेड वॉल्स हैं इसकी कैल्सिफाइड गॉल ब्लैडर की विद इरेगुलर सर्कमफ्रेंशियल थिकनिंग ऑफ द गॉल ब्लैडर वॉल.
So that is a very, very indicative of gallbladder malignancy. So this is like, I don't remember when did I see this last. Maybe one case before I might have seen. And you see this calcification of the gallbladder wall and thickness of the wall. You see a tissue, it's irregular. There is a very central small lumen. This is like consistent with the gallbladder malignancy. So you won't see these this porcelain gallbladder and this calcification much in your life, really. So I wanted to show you that. And one thing is, she's 75, pulmonary nodules. I need a little bit help from the management. This is consistent with gallbladder cancer. Do you really want me to do FNA or leave her alone? Because there is a very, very small but definite risk of bile leak.
The hall says no, Khalid bhai. Just at the image which you have still for us, do you see any hypoechoic hepatic parenchyma adjacent to the lesion? Because I can see there is adjacent parenchymal infiltration as well, because the area which shows wall disruption, there is hypoechoic hepatic parenchymal lesion as well.
I don't see here right now. It's to me it looks like a all normal looking liver here.
Okay. So there is no hepatic parenchyma.
No, there is no. Okay. The thing here, what you are looking at is you are seeing this area right there. That's a shadowing from the calcification, really. And I don't see, this is the area, I don't think there is any involvement of the liver. All looks like it's contained inside the gallbladder. I can take another better look right there. You see the gallbladder, you see it. It's a nice calcified wall. Pulling it back, maybe a little bit in this area. This area might be, but I think majority of it is really a gallbladder itself. Okay. I think my personal thing is like leave her alone, because
absolutely,
and it's not gonna make a difference. I don't think she's gonna need gonna get chemo or radiation.
No, gallbladder cancer doesn't respond to anything as far as
doesn't respond to anything.
Really.
That's another thing. And if I see the mass, I have done many gallbladder FNAs for the mass. If you want to do that, you're going to use the smallest needle, 25 gauge needle. In this case, even that may be difficult because of the calcification in the wall, and it may not even go in there. It's going to be hard to push that through. But don't use, if you're going to biopsy the gallbladder or the bile duct, don't use 22 gauge needle or larger needle. Always go for the 25 gauge needle. So this is very, very consistent with the gallbladder malignancy. It's like a book picture of that. So here,
so Khalid, your steps as you go into bulb, just take the candidates through it while you're doing it, please?
So, okay. So here you can see the bulb. I'm actually sitting right into the pylorus right now.
Yeah.
And if I move the big wheel a little bit away from that myself, you can see where the duodenal apex is. So, and you see a little bit thickening of the fold right in the where the duodenal apex starts. And that's really my area, target area. I'm going to take my transducer right on top of it and then use the suction. I will do right or left, a movement sometimes a little bit to get to my landmarks. But here, I get my bile duct here. You see the stent in the bile duct. You see the portal vein right here. You see a portal confluence right here. This is a SMV. This is a splenic. When you're looking from the duodenal bulb, I want to point out to all the candidates, the pancreas here, head is in this area, the pancreatic neck is going to be in this area, body here, and the tail here. So it completely flips. A lot of people have a trouble understanding that. And the pancreas right now is right here like this, okay? And this is also because we are looking at the pancreas from the different angle. You are in a long position into the stomach, and this is totally different what you are seeing from the stomach itself, short position, right on top of it. Now in long position, trying to take a look at it from the totally different angle, because what you are doing is like right now the transducer is close to the head, and the body and tail and everything is further from that.
So from here, Khalid, you trace the bile duct down to the duodenal fall off.
Okay. So here you see the bile duct right there.
Yeah, we can see the stent.
You see the stent right here. So let's look at. You can see my scope the way I'm holding it. I'm just going to rotate the scope towards to the right, and that's how I'm trying to go towards the ampulla, and just gently adjusting my scope. If you pay attention, my goal is really to keep the bile duct in one place if possible, and I'm just gently pulling the scope back a little bit too, and trying to maintain that position until I get all the way to the ampulla itself. You see the wall of the duodenum falling right down here? You see? This is muscularis.
Yeah, we can
and
see
going there, that's called the duodenal fall. Okay, nice, very nice right here. Muscularis propria coming down, coming down, coming down all the way here. So I'm right at the ampullary area. This all is artifact from the fluid and junk and air into the duodenal lumen. So here, and this is right where the stent is, and we are all the way at the ampulla. Can you see that?
Yes, very nicely.
Okay. From here, what I'm going to do is I'm going to follow that stent all the way to the liver hilum now. I'm still keeping the bile duct right in the same place. That's my goal.
So now you're going counterclockwise.
Counterclockwise, but gently advancing the scope and sometimes pulling it back if I'm too far. So right now I'm just, bile duct is right there. I keep going, keep going. Now I have to pull the scope back a little bit because bile duct is trying to move to the right of the screen. So I'm pulling the scope back, and rotating, rotating, rotating. Still have the bile duct, until all the way to the liver itself. Now you saw that right here, okay? Now I'm going to do the opposite of what I just did. Bring the bile duct back, and going again to the area of the ampulla right there.
Okay, can you see the bile duct there?
Right there is the bile duct.
Yeah.
Okay. So that's pretty much.
Sorry, I mean, can you see the pancreatic duct there?
Oh, are you asking me if I can see the pancreatic duct right there? There is a right there. You see that?
Yeah.
Okay, right here. This is the pancreatic duct.
So you have the stack sign almost.
Yeah, almost the stack sign. And other thing is, if you pay attention to the bile duct here, that is also a kind of a thickened wall right there. This is not the, this looks more like a tissue than the debris itself. However, If I go a little bit further up there, this is the sludge in the gallbladder. Can you, bile duct I mean.
Yeah.
You see that all that moving around, that's the sludge itself.
Niche bhi, yeah.
So it's a gallbladder cancer which is also involving the bile duct itself too, the bile duct wall.
Khalid, once you placed a stent,
GG.
how reliably can you, can you evaluate the bile duct wall, because they just tend to become inflamed quite often after the stent?
Excellent question. Okay. And what I have come up with that, if I can see the 3 walls of the bile duct, that's inflammation. Okay. If there is no distinction between the walls of the bile duct, which are 3 walls, you are always going to see that white, black, white. If you don't see that, then it's likely is more than inflammation. But when you see that, then it's an inflammatory process. We do not see any distinction here in this area. You see that all is mingled together. It's just one thickness. I have no distinct layers of the bile duct wall. Okay, make sense?
Yes.
Okay. So that's pretty much about that. And
you can because the patient is 75. So if you want to call it a day,
yeah,
we've already got.
We're gonna do it for 5 more minutes, and then we're gonna call it a day. I think you guys can go back to the other room if you like. Okay. Let's just do the water.
स्टैलेट लोड करते हैं. डाल डाल.
We are not with him now, so we'll sort it out with the next day.
Okay, there we go. You see, yeah. So nah, good. मुझे दे दो यार, वो दे दो, स्ट्रिंग दे दो.
Yes, we are with you.
Okay. There's a mass in the head of the pancreas. We are trying to biopsy that. It's a hard scarce mass. Love it. Good. हाँ. CBD trace करें all the way down. ठीक, शाबाश. Size, let's see the size. Nine millimeter. ठीक है, this is slightly dilated. चले, ठीक है. अच्छा, अभी आप कहाँ पे? फॉल बैक कर गए. नहीं नहीं, ये है वो पर CVD आपको नजर आ रही. तो बेसिकली ये ना आप आने दें.
मैं तो असल में मुस्तकिल सक्शन कर रहा हूँ, लेकिन वो
नहीं, ओके, कीप डूइंग द सक्शन रिपीटेड. उस पर जितनी है वो निकल जाएगी. हाँ, कीप डूइंग दैट, कीप डूइंग दैट. दे शुड बी नो. हाँ, ये हाँ, ये जी बेटा. क्या आया? हाँ, क्या आया? हाँ, एकदम. ये तो एक जैसे सेल्स है. हाँ, क्या? हाँ, सेम सेल्स है जी.
एक ही बंच नजर आया, बाकी ये तो ब्लड आरबीसी.
हाँ, ये सारा ब्लड है.
बाकी सैंपल्स तो अच्छा आ गया. दिखा आपने?
ठीक है, और पास लेना है पास जी.
सैंपल नहीं, काफ़ी है सर.
काफ़ी है.
हाँ जी, काफ़ी है.
चलो ठीक.
सैंपल अच्छा.
ओके, कोई बात नहीं, वो होता है इस तरह. नहीं बस. हाँ, दिस द बाइल डक्ट. बाइल डक्ट को ऊपर हाइलम वाली साइड पे ट्रेस करें, नीचे लेके आए दोनों साइड पे. बिकॉज फॉर योर at your stage it's important to trace the duct on the two sides towards the pancreas and towards the hilum. This is something that you have to learn how to trace. Big wheel away from you and slight push. Going clockwise, you're going to go to the head of the pancreas. ठीक है, ये हाँ ठीक है. Clockwise pancreas, counterclockwise you're going to go towards the liver. Big wheel up, big wheel down. कोई बात नहीं, ये उसमें हाँ ये. That means that you are not, basically you are not right there in the lumen, so you just have to go into the lumen. Right. Meaning by that you're possibly in the stomach. So come back, identify, go back inside the, ये देखो ना ये. So go back inside the duodenal lumen and keep it collapsed. हाँ ये. अच्छा देखो आपने जहाँ पे देख लिया, अब ये नजर आ गया ना. Now keep the suction on. ठीक है, keep the suction on. हल्का सा turn right or left. थोड़ा सा push करो. हाँ ये हल्का सा now down, right, left. Okay. Right. Yeah, that's how you are able to image the things better. ठीक है. Great. इसकी आपसे प्रैक्टिस करनी. किधर गया फिर? हाँ हाँ ये ब्यूटीफुल. वो ठीक है, कोई बात नहीं. उसमें होता है तो उसमें जब चिपका के रखें दरमियान में कोई चीज़ नहीं आएगी. हाँ ये वो मैस आ गया, लिम्फोइड मैस। शाबाश। ये शाबाश, दैट्स इट, गुड। देखा, मैं देखूँ क्या रीज़न क्या। हाँ नहीं, अब ठीक है, वैसे तो यू आर डूइंग गुड। अच्छा पता है नो, जैसे ही अब फॉर मी इट्स नॉट अ प्रॉब्लम, आई नो। अब किसी मौके पे आता भी है तो बेसिकली व्हाट आई एम डूइंग इज दैट आई एम ट्राइंग टू कीप द ट्रांसड्यूसर राइट नेक्स्ट टू द mucosa, and that's what I'm doing, nothing else. हाँ जी, लो ना, ठीक है। My scope is straight, that's not an issue. एक जैसे हैं, ये वही है केस? हाँ वही है।
नॉर्मल, ये तो बिल्कुल नॉर्मल है, एब्सोल्युटली नॉर्मल।
Are we done with the FNA?
Yes, we are done with the FNA. We are done with this case.
Okay, great.
You can
so
switch to
we'll,
the next
we'll have
case.
to shift to the next case now.
Okay.
Abdullah, we'll have to move now.
Chali, 4 into 3 centimeter lymphoid mass at the. आप लिखेंगे?
बस हो गया आराम से
Okay.
D1
Yeah, go ahead. Straight to D1. We have a young 47-year-old. आवाज आ रही है?
हाँ जी आ रही है.
Khalid, we have a 47-year-old lady who presented with obstructive jaundice, had an ERCP, got a stent in C2. She has a CA199 of 600 plus, and she has a mass on CT scan, the distal end of the CBD, query pancreas.
Okay. Thank you.
So we are basically going to evaluate the distal end or the head of the pancreas and probably do an FNA if necessary because she is very young. There is nothing else. CT में बेटा doc.
सर उन्होंने सीडी दिया है टॉपिक पैंक्रियाज मल्टीपल कैलकुला विदाउट chronic pancreatitis CBD स्टैंडिंग स्मॉल कैलकुलस बस इन्होंने ये दिया
आपको नहीं दिया.
सर इन्होंने तो एविटनूल उन्होंने कहा है कि सर स्ट्रक्चर है नहीं.
Okay, sorry Khalid, the CT scan is actually that was the next door patient. It shows chronic pancreatitis with atrophic distal pancreas, dilated channels but no evidence of mass.
No evidence of mass.
Yeah.
Okay. ठीक है.
So where are we? So देखें थोड़ा सा, you can use the small wheel sometimes to get in. So when you get stuck, here, just use the small wheel a little bit. नहीं टाइट हो रहा. ओके फुल बैक कर ले थोड़ा सा फिर देखिए एक दफ़ा. ट्राई करें. या थोड़ा सा स्मॉल व्हील यूज करें. नहीं
याद हो गया सारा कुछ. याद हो गया सारा.
Okay. आप देखें. देखो ट्राई करें.
अब मैं वर्ड्स कैसे चेंज करूँगा?
दिखाना ज़रा. Okay, so we have there's a large lymph node there, and we've got this is a mass. That's not a lymph node. I'm sorry. That's the CBD. Ooh, what is that?
साद भाई.
Yeah.
ये स्क्रीन के ऊपर ना आपको वो ग्रीन एरो नजर आ रहा है EUS के ऊपर इमेज पे जहाँ पे नंबरिंग है 2, 4, 6. इस एरो को ना 4 तक ले आए. कैन यू?
ओह अच्छा, इन्होंने किसी ने इसको चेंज किया.
हाँ जी. दिस इज गुड. दिस इज गुड राइट देयर. तो मैं आई वाज डूइंग द अदर वन एंड somebody objected to that it was at 5 or 6. So I know we can see that, but I think the projection on the screen becomes a problem when it's not optimally focused.
So we've got a mass here, but I can't get in deep into through the pylorus. So there's
and that also indicates that there is something really wrong there.
Yeah. So in such cases, normally we would just do an FNA or FNB here. And then and that's it, because that's what we want in this patient otherwise. But for let me see if I can you see the stent now? While I am here, I will try and see whatever I can see from as close to the pylorus as I can. That's the CBD there. You can see a bit of debris going up towards the liver. Coming down here, you can see the stent and you can see the CBD all the way to this area. What I am not sure is what is this. Doppler, please. So this is Khalid. हटा दो Doppler.
Yeah.
Can you see this?
Do you think it's a thrombus?
Yes, that's what I'm thinking. But it's completely occluded, this portal vein.
Yeah, and
But
what
like
is above that? Is that a bile duct or a
That's not bile duct. This is a smaller vessel.
yeah.
But this is not bile duct for sure.
Can you put a Doppler on that?
I will. Just one
yeah.
second. Bile duct is just above if you see the stent there.
Yes, we
Can
do
you see
see
the
that.
stent there? Yeah.
Yep.
So this is a vessel there, and this vessel, when I try and follow,
I think
again,
it's a thrombus. That's what it looks like.
This is what I initially when I first saw, I thought this was a really a lymph node, but then
we thought the same thing too.
yeah,
but
you know,
when you moved around, it looked like a thrombus.
when I saw it, like, but this is a vessel, and where it is, it's almost certainly portal vein. I don't know. What do you think?
That's what it looks like.
Yeah. So this is bad news.
No, absolutely.
I'm not sure. Again, whether it's worth. So we are actually. You remember yesterday you were telling me. So I've actually done this examination from just pylorus.
Yes.
I could not peep into it properly, and I don't want to advance too much, because if you look at this, Khalid, the duodenal wall itself,
and
that area, it's all. To me, it doesn't. It's all infiltrated.
It is.
It's thickened, infiltrated, and
definitely it is. And also, there is when you're trying to go into pylorus, there is some bleeding. There is a thickness.
Yeah, so
and
there's thickness, and so I'm not.
Yeah, so I don't think there is a
no,
need to
I'm
go in
not going
there.
to go there. I'm just debating at whether to do an FNA or not here, FNB, FNA, whatever. What do you say?
I think you can do the FNA from the pylorus area after getting into the good.
So we'll just give Mansoor a few minutes to look at the stomach. This patient has been delayed by the time she has been referred to us, because this stent was placed in October. So I assume that when they, so now you bring the liver. So let's focus on what we are going to do. So tip up. Yeah, tip should be up. Okay. And where are we? Yeah. So liver आ गया? ठीक है. अब थोड़ा सा
जी. Do we have hepatic meds?
We are just going to have a look, Bhabhi. I've just for now I'm just focusing on getting him to the aorta, but we'll have a look at the liver as well.
Okay, thank you.
But I'm sure you may have spotted something that I've not.
Yes, so there are actually.
When you asked me that question, I knew there must be some there. Wait a minute. Okay, rotate slowly. Clockwise, doesn't matter. We are looking at the liver, so you're just following. There, can you see that?
Which one?
Let me put some flow here. Can you see that lesion there? Is that what you were talking about? और थोड़ा सा rotate करो. करो. लिवर को देखते जाए. पूरा लिवर को आप एक रोटेशन में स्कैन करते.
यहाँ पे साथ में basically they are small target lesions.
Yeah, they are small target lesions. I saw one of them. Yeah.
So there are multiple.
And there is, I don't know whether this is. Wait a minute. Just let me see. Is this thrombus there? No. This is obviously dilated ducts with some debris in it. So if you want to scan the liver, you keep rotating yourself. Keep rotating. Keep rotating. Keep rotating. Keep rotating. Keep rotating. Keep rotating. And your hands going down, 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 down. You've gone all the way. Now you can actually do the same thing again slowly, and so you should be able to see if there is anything there. Certainly you can see debris in the ductal system. Ductal system is dilated. There is at least one area that I saw. There are more there. There, can you see that? I don't know if you can see that clearly. There's that shadowing. अब जाते रहो इसी तरफ, जाते रहो, जाते रहो, जाते रहो, जाते रहो, जाते रहो, ठीक है, all the way हो गया. लेकिन अब आपका tip up है.
जी.
Okay. Now again do it. चलो एंटी क्लॉक जाओ. हाँ एंटी क्लॉक जाओ.
ये तो हार्ड आ गया तो
थोड़ा सा आगे जाओ. हाँ थोड़ा अंदर जाओ. टिप अप करो एंड रोटेट करो. ये तो तुम मेरे साथ कर चुके हो यार.
नहीं तो यही तो मैं मेरे साथ
जाओ
से तो मैं
आयोटो. जाते रहो, जाते रहो, जाते रहो, जाते तो जाते जाते. यू शुड कम यार. ये आ गया. सो दैट्स योर celiac take off above. ठीक है. Now you just advance your scope a little bit. बस जी. तो उनको ले लो आंटी को फौरन.
ये पेंक्रियाटिक
possibly no. So we go back. We won't waste time. We will go back to something that we understand. So if you're not sure, we go back and try and find the aorta. So let me show you एक चीज़ दिखाता हूँ. ठीक है. आपने ये पकड़ा है ना इसको. ठीक है.
वॉल से अलग हूँ.
ठीक है. आप एक तो एयर निकालें. ठीक है ना. एयर निकालने के बाद we are here, right? ठीक है. Come back here. This is why you're getting stuck. See there, can you see the shadowing there?
See the shadowing?
Yeah, calcification. आप लोगों को नजर आ रही है ना?
बिल्कुल जी, बिल्कुल.
So we've got pancreas here, right? Now once I've got this pancreas here, I'm going to just keep it in the middle and go whichever way then I want to go. There's definitely chronic pancreatitis here. इसमें तो there is no question now because you've got once you've got such bad pancreatitis, you really can't see anything. Pancreas का. Let me see if we can see the kidney here. There's the aorta. मैंने आपको निकाल. There's the aorta. ठीक है. That's the aorta there. So now we're not going to let it go away. We follow the aorta. We've got the celiac takeoff. We've got the superior mesenteric takeoff. We follow the celiac. Okay. I'm just gently letting the big wheel away a little bit, going in, and you have complete atrophy of the tail, so you're not seeing any tail. The thing that you normally see here, we are not going to see. There are some varices, I think. See, these are varices there, and this is probably from the pancreatitis she's had. Oh yeah, most likely because she must have had. So there's no tail there at all. And when we hit this structure here, this is all calcified pancreas. So really, I can't see the duct. Yeah, this should be the body. There are so many varices here. Can you appreciate that? I don't know. So, let me see kidney. Let's see if we can see the kidney here. It's actually slipping off. This is.
सर यहाँ पे इनके पीढ़ी नजर आती है?
Yeah, I'm just trying to see the PD, but I'm not sure because everything here is a vessel. See that? These are all varices there.
Yes.
And you have this area. There's no. Even the CT said there was no pancreatic tail at all. And you can't see anything in the pancreatic tail area except for this calcified area. I don't see anything else. And from here, when I try and move my scope, we slip off because I'm pretty sure there is some kind of a mass effect here in the stomach as well. And I'm not surprised because the pylorus is non-negotiable and the tumor looks pretty bad. So we'll just go ahead and do the FNB or A, whatever they give me.
22 gauge sir?
Huh?
22 gauge FNB?
22 please.
जी. The size.
Could this be a unlikely? This is not inflammatory. Lots of varices here as well. So this is the area where I'll be. This is the area that I'm going to be targeting. Rayas, can you hear me?
Yes, I can hear you, but yes, it is hypoechoic.
This is the only abnormal.
Yeah, that's the only abnormal area.
Yeah, and you see the CBD coming down from there. That's the stent there.
Yeah, that's
comes
right.
here and then you lose it.
That's right.
So this is, to me, this is the area really, and I can't see anything else. And so it's pretty hypoechoic, looks abnormal, and it's at the right place.
Yeah, that's right.
Agree or
it's at the
disagree?
right place.
Do you agree?
साथ सवाल है कि इसकी पीडी क्यों नहीं डायलेटेड, क्योंकि अगर chronic pancreatitis तो पीडी डायलेटेड होनी चाहिए.
ज़रूरी नहीं है, because what is happening is we can't actually see it between so many vessels. I really can't see it anywhere. अब इसमें आप ये देखो ना, if you look at it here, you have कहाँ गया cursor here? हाँ, you have you can see acoustic shadowing here, so you have calcification here. And so if you have pancreatic duct somewhere here, it is not necessary that it should be dilated, should it?
That's right, I agree.
Especially in the head, it is quite possible that there is stricturing. That's what we see with chronic pancreatitis. And the tail is gone, so that's the only explanation I have. I tried looking for it, I can't see it. If it was dilated, you don't have to find it. Dilated PD and pancreatic ducts are easy to, in fact they come and shout at you themselves. It's when they are not dilated that you're struggling to find. So this is what I feel. I don't know, Riyaz, you agree with that? This is the only area that I find abnormal.
Yeah, that's right. That's the only area that we can say that it's abnormal.
And I can't go beyond, so we are stuck in this sense that this is the only place we have.
So are you going to do FNB?
I am going for FNB.
22 gauge.
The problem is I am in the stomach. So I'm going to try and see if I can get. I just want to go where the stent kind of. Okay. Doppler, please. Take this off. Doppler once again. क्या दोबारा यूज हो रही? हाँ? So what I'm going to do is, we tried pushing the needle, advancing the needle, and it wasn't going very smoothly. So what I generally do is, I will get the sheath out just to make sure that it's clear. You can see it on endoscopy, on EUS, the sheath coming out.
Yes, we can see
pull it
that.
back there, Now I'm going to try and reposition myself and see if we can.
Do you keep the Doppler on throat?
No, no. I'm just for now. Band kar do. Can't see the needle yet. So we are deep into the thing, but I am losing. I need to reposition myself. Difficult to maintain the position. हाँ थोड़ा सा मुझे पकड़ना पड़ेगा स्कोप को पकड़ ठीक है Yeah, that's fine. It is hard here. So I've done 4 or 5 on each side, and I'll try and see if I can change a little bit. That's it. And follow the stent up to here. And that's the duodenum. So you can follow the stent all the way here. This whole area is hypoechoic. Pancreatic duct. Doppler dena? Flow? No, that's not pancreatic duct. I don't know if that.
Off कर दो?
हाँ नहीं हाँ off कर दो. यहाँ पे I'm not sure. You see that? There is a duct here.
Yes, we can see that. Yes.
That I'm not sure, but because that's on flow, it's a ductal thing, but that's all I could see. Nothing more. I think we should have enough sample there. I've taken more passes than I normally do. आप इसको देखें, मैं एक मिनट देखूं. टिश्यू है? हाँ? आ गया टिश्यू? कैसे पता? स्लाइड नहीं, मुझे टिश्यू चाहिए. है? निकाल दूं बस? Okay, we're done. So you come back to. So Riaz, we've got nice tissue there. एक minute, this is good. इसको देखेंगे क्या है? That's a vessel. When you've got a lot of varices, when you have chronic pancreatitis, I find EUS really not much helpful, except for going for a mass and taking biopsies. Other than that, really you're lost because at least I can't make head or toe out of it. Yeah. So we come back. Just come back to the mediastinum, and let's. Our sample is very good. Got a nice 5 centimeter core.
Wonderful. That's brilliant.
So let's see what that shows. What I will do is I'll make sure that we send the histology जो हमने की है उसकी जो हमारे पास formal report आएगी ना, we'll share it with the faculty and the yeah, keep coming. Keep coming.
That's wonderful. Appreciate it.
Clockwise thoda sa pull back. Yeah, keep coming. So you've got area 7, right? Big wheel, tip up, air out. Tip up, air out, and advance a little bit. Yeah, that's it. So that's left atrium on the left.
And pulmonary
ठीक है. Left atrium here, pulmonary artery here. This is the area 7, okay? Or subcarina. Now,
now for the arch.
yeah, she's getting a little restless. तो देख लो. When you're doing AP, just इसमें lymph node है क्या यार? दिखाओ. There is a lymph node. इसको rotate करो. थोड़ा सा. Yeah, clockwise.
Yes, sir.
So you see there's a slightly biggish lymph node there.
Yes.
ये कहाँ पे?
ये नहीं वही सब कराइना में. So थोड़ा सा रोटेट करें. क्लॉक एंटी क्लॉक अंदर डालें. ठीक और थोड़ा एंटी क्लॉक. या क्लॉक. Yeah. Now do anti clock.
Anti-clock?
Yeah, anti-clock. I think there's more than one तो वो लग रहा था वहाँ से इतना. It's bigger than what you see, right? But looks like an inflammatory one anyway. So how often do you see these lymph nodes that are slightly larger than the expected one? निकाल दो. हाँ.
It's variable. It depends upon the underlying condition.
No, I see. Just when you're doing your endoscopy, where you don't expect subcarina, slightly larger lymph nodes, inflammatory-looking lymph nodes, we see them not that infrequently.
Not all that uncommon.
Yeah,
especially
not
in the
that
winter
uncommon.
season when the lots of flu season going on, lots of flu patients. We do come across lymph nodes, roughly about 0.7 to 1 centimeter in size, benign looking.
Yeah. So in this, the problem is the reporting. So I mean, generally, what I would write, and I would like, if there's anything you want to add, I usually would go in straight to the CBD stent scene. Air we saw, so there is patency. Thrombosis at the distal end of the CBD, hypoechoic, ill-defined area seen in the head of the pancreas, distal end of the CBD, FNB done, good adequate samples obtained. Pancreatic duct, question mark, seen in the head, lots of calcification and features of chronic pancreatitis seen, no tail and body of the pancreas seen, and then portal vein appeared thrombosed, small lymph node seen in the subcarina looked inflammatory. Review with biopsy. That's what I would generally report. Would you add anything more or what?
I think you have given a very comprehensive, nice report.
Okay, so good news is that I finally got a patient who has got abdominal pain.
Thank you.
तो खालिद की लगा दो
वो मुझे कौन भी दे दो हाँ जी थैंक यू
किलोस पेन
अब यहाँ पे जो है ना देखिए आप ये भी खड़े हैं अब यहाँ पे आप you've got the kidney right if I do too much tip up now my pancreas is now going to be squeezed right this is where I need to let go so that I can see a bit of pancreas. I'm pulling back now I've got a glimpse of the PD as well. Okay, so we'll follow this. Follow it to the screen here. Now there's something here, what the hell is that? Gallbladder? What do you think that is? That's not in pancreas.
It's not.
That's below pancreas. And it's away from everything else and it's not a vessel. So, right above the kidney. Huh?
Looks like a lymph.
Looks like a?
Lymph.
Yeah, that's right. इनका CT scan की report देना, was there a lymph node? Because she has abdominal pain, that's all she had. Anyway, we'll now go the other way.
सर तस्वीर आ रही है आवाज़ नहीं आ रही
क्या ये कैन यू हियर मी नाउ
Yes, we can hear you now.
ओके आवाज़ इसलिए नहीं आ रही थी कि माइक मेरे पास है और कैमरा इनके पास है
So we are at the neck of the pancreas now.
केस क्या है?
That's the
so you can
abdominal pain.
Sorry, आवाज़ नहीं-
abdominal pain.
Abdominal pain. Okay, just abdominal pain. Evaluation of abdominal pain.
Yeah.
Okay.
We could not find anything else, so there was some reason why we did that. So that's the neck and.
That you can see that we are right at the neck and the duct is falling down and there was a confluence, portal confluence, दोबारा दिखा दो जरा उनको, right there. And if you have to follow the portal vein, you can easily follow that from here to the liver hilum. So portal vein is there. Portal vein, he's just gonna follow the portal vein. Follow the portal vein. Excellent. Okay. And you see the bile duct is very small and it's right underneath the portal vein.
Yeah, that's right.
Yeah.
At the liver now.
Yeah. Oh yeah. We are right into the liver and there is still you see the bile duct right underneath. It's not dilated at all. And that's actually is a common hepatic duct. So that's good. We saw that. We can follow that portal vein back to the pancreas from here.
So for following, what I'm doing is practically just gently going back here.
And you're back at the confluence, right?
Back at the confluence again. Okay. So I'm just going a little bit of clockwise.
To go towards
the
the
advance. And now I'm going clockwise so I can see the superior mesenteric vein. And then we're back into the confluence. And we see the pancreatic duct coming down to the neck. And that's as far as, so we saw a lymph node. Or
Yeah, I
something.
think let's see that again. I don't know what it was. Pancreas looks very reasonable. I don't see anything major there.
Pancreas is absolutely fine. Pakistani pancreas is pretty good.
Yeah, for Pakistani pancreas it's really good. So there's left kidney right there. So can you see that? Haan ji. You're right at the kidney. I don't know what that was, and I think we can.
We saw a little.
That's all vessels there. That's the left kidney. That's in the kidney, son. Yeah, yeah. So that's in the kidney. It's like a lobby.
But that was not in the kidney,
No.
which I saw before.
जी नहीं सिस्ट इफ अगर सिस्ट होता तो वो फिर
Cyst
फ्लूइड
तो-
होता ना
हाँ,
तो
fluid
इसमें
में-
सिस्ट फ्लूइड नहीं है ना हाँ और लेफ्ट एड्रिनल इज राइट अबव दैट
Left adrenal is there, so that's not left adrenal for sure. Because the position was left adrenal anyway. And it was not in the pancreas. But at that time also I was a little
go to the neck area go to the neck area हाँ जी चलते जाएं it was close to that area pull the neck up a little bit in this area go back to the pancreas I think
somewhere here, but I'm just yes, the big kidney was not coming at that time. I'm just wondering whether
the kidney itself has some
kidney में there is
something going
something
on
abnormal. See,
yeah
there is not
right
a
there
cyst.
it's more like you see those embolic infarcts that's what they look like.
So can you appreciate that?
Can you see that area in the kidney? Usually the embolic infarction looks like that. So that leads to kind of a necrosis and you see a little bit necrosis there. That's what it looks like. So इनका kidney function ठीक है? कोई उधर तो कोई नहीं problem है?
How old is the patient?
She is.
Creatinine is normal. Okay.
I'm sure she's in her 60s. 60. Yeah.
I think renal ultrasound करवाना चाहिए इनको special.
मेरा भी यही ख्याल है कि मुझे
Just to make sure.
I just wonder whether what we were seeing was actually
Is a part of the kidney, right, like that. हाँ ये वाला इसी तरह देख रहे थे. That's a part of the
I
kidney.
think that's probably part of the kidney. That
Yep,
we saw.
that's what we were looking at.
It was separate from the
Pancreas.
The pancreas. The whole pancreas looks okay.
Okay. We can go to the
So we
duodenal
just
part.
moved now. We've seen the body and tail. We've seen all the organs that we wanted to. We go into the D1. So we see the pancreatic duct there, which is on the pancreas. Can you appreciate that? I don't know. Can you tell it?
Can you
Yes.
see the pancreatic duct?
Yes,
and,
we can see the pancreatic duct,
Do you
yes.
see the bile duct too?
Bile duct coming
Yes,
down.
right
Okay.
there on the left
So,
upper
and
side
the
of the screen.
portal vein is right at the bottom.
Yes.
Portal vein, pancreatic duct, CVD.
And portal vein made by SMV and splenic. So where splenic is coming from the bottom.
Yeah, there.
Can you point out?
So
Yeah.
splenic
Right
will
there,
come
splenic
from here.
coming from there.
This is superior mesenteric vein from here.
Both getting together. Yeah.
Yes, superior mesenteric vein, both getting together. Confluence. And we can see the pancreatic duct and the bile duct.
Bile duct look normal. Yeah.
Okay. And they, in terms of diameter, they look normal. We'll try and see if we can trace them down.
Tracing those towards the ampulla. It's easily compressible. That's what's happening. You're getting close to
To
yeah.
the
Yeah, and there's nothing really there.
I don't think there's anything there really, and you can see the pancreatic duct going at the same place. So, to me, I'm happy.
Actually,
There
you
can
there
see
you
this.
see that.
There you
Okay.
can see that. I'll try and see if I can.
They both are
There's a
there.
pancreatic
Yep.
duct coming from below. as well.
Yep, there is.
So that's done. So we can follow this if we want to. Again, remember if you're following this, we're going anti-clock, letting the big wheel a little bit tip down, and just following that CBT. Although when it's not dilated, it's not always. I think that's. It's not always that easy.
Look normal, absolutely.
So we are almost as far as I. It's all normal as far as I can see. Want me to go any further? No, that's good enough.
No, I think we're fine.
That's good enough.
Mm-hmm.
So we're now left with just one bit. So we'll see if we can easily go there. So once you're in D2, basically you're looking for either IVC or aorta, and we've got both. So that's IVC.
Mm-hmm. The IVC you see right there.
Okay, so this
And,
is IVC.
Okay, yes.
And if you look at my hand here, I'm just using torque here, and we've got aorta. As I go
Aorta by the
clockwise.
right torque, yeah, clockwise.
Yeah. And I go a little bit more, I should be able to see the left
That's
kidney there.
right kidney.
Sorry, right kidney, just there. So we go left, IVC, go more, aorta.
Good.
And at this point, what we need to do is, we need to just keep going clockwise, and we start seeing the pancreas. You need to just gently move, and what will happen is you'll see the ductal structures coming from this side. But because these are not dilated, so
Should be, so, yeah. No, I
it's
think.
still not going to be that easy. But you still see the.
Actually, you may be able. You need to go a little bit to the left. You, the other left. You need to come back.
Yeah, I need to come back.
Yep.
So we are just going to see, that is the uncinate,
Mm-hmm.
and there's a duct above there. So we need to just, at this point, I think it's important to let go of your big wheel as well, because sometimes we are holding the thing.
No, actually, it needs to come and no, this way, this way, this way, further, yeah, to the left. Yep.
But we are going to.
That's a duct.
That's one of the ducts.
Yeah, I think you fell back a little.
Yeah, we've gone. That was the problem. I could feel the pressure coming.
Mm-hmm.
So when you're trying to manipulate this area, maneuver this area, it obviously, as you're approaching it, you get. So we will try and do it again. So this time we can see it better there.
Mm-hmm. Now you are at the ducts. You see that both ducts there, pancreatic and the bile duct.
So we can pull back a little bit. That's what. And so you can see the bile duct above and the pancreatic duct below.
At the bottom.
Both going at the same place.
Like
So
small
that's
diameter,
uncinate.
which
Can
is
you see
normal.
that?
Yeah.
So you can see both the ducts.
Yeah.
Can you see that? I don't know if these guys can.
Yeah. We. I think it's visible, so everybody should be seeing.
You can see both. Okay.
Yep, right there.
So you can see that there is no pancreas division here either.
Yeah.
Because they both are going towards.
And other thing is you can see those all the way to the ampulla actually.
Yeah.
This is the other part where you can see the duodenal fall. It's from the opposite side.
But this time it's coming from the other side.
Yep.
So the direction is different. So we've got that.
But you see the pancreatic duct and bile duct going all the way to the ampulla. Absolutely normal.
Okay. So that's done.
Okay.
So abdominal, we didn't find anything except for what we found in the pancreas. And so,
You mean the kidney?
sorry, the only problem we found was in the kidney. And that may explain why she is having pain. And so again, the mitral valve, the aortic valve, pull back, little bit of clockwise, tip up, and we've got aorta on one side, left atrium on the other, nothing in the subcarina.
And you see a small pericardial effusion there, and that is normal really. Can show you. Can you freeze it? Right there. Hanji. So you see a little bit fluid around in the pericardium, right there.
Yeah,
yes, sir. Very thin, which is normal. Okay.
I avoid doing AP because when you have got patients sedated, this is where they are actually uncomfortable. So you just try a little bit, and if we are successful in getting it straight, fine. Otherwise, we usually don't bother.
Yeah, every time you try to do that, it rubs against their trachea, and that makes them uncomfortable. If you do, yeah, just push it in, right
There.
Okay. Yeah. Thanks.
Okay.
Good.
So, ma'am, doctor, we need a proper renal assessment. There is no pancreatic issue, there is no bile duct issue, there is no reason for her pain coming from pancreas or bile duct. So we would say abnormal areas, two areas in the left kidney.
Abnormal echogenic area.
With abnormal echogenicity, about 1 centimeter around the circumscribe. No other abnormality. Okay dear, thank you very much. वो कहाँ हैं यार? गयास and गयास बेगम साहबा तो यहाँ हैं. Where is गयास? हाँ? आ रहे हैं ना? Because he has to go from. How has it been so far? Hands on. अभी मुझे देख के excellent नहीं बोलो. मैं really. Is it what you expected?
Far more better than our expectations.
Really?
Yes. It was very helpful.
Okay, so what I want you to do is, I want you to जो हमने सवाल पूछे थे ना, how many you've done, your difficulties, वो आपने हमें लिखने हैं अपने जो भी comments में लिख दें, कोई फर्क नहीं पड़ता. And then I want to know how you felt after on those counts, before and after course. If you can do that, that would be very helpful. नहीं, अभी जब आप आए थे और अभी 3 दिन जब कंप्लीट हुए, उसमें क्या फ़र्क महसूस किया आपने? आपके कॉन्सेप्ट्स में आपके कौन सी चीज़ ऐसी थी जिसको आप नहीं समझ रहे थे या समझ रहे थे in terms of whether it's recognition, whether it's usage of torque, or whether it's